Commissioner. This will be a very long day today. We will be looking at when presentations are a bit shorter or we finish earlier, whether we'll be able to bring the other presenters on earlier in order for us not to run past 2000 hours today. There is also already a possibility that the compensation commissioner would start around about 1530 to 1600 hours instead of 1700 hours. But we would see how the day runs. With that having been said, let me then welcome all of the members of the Portfolio Committee, the representatives of all of the entities, the staff of our Portfolio Committee, members of the media, especially our Parliament YouTube streaming members, members of the public. And before I continue, I will take attendance and apologies from Ms. Majalamba.
Good morning and thank you, Chair. Present is Dr. Jacobs, Mr. Munyai, Ms. Keller, Dr. Harvard, Mr. Siwela, Mr. Baba, Ms. Ishmael, Umamutlengwa, Mr. Van Staden, and Mr. Imam Sheikh. I haven't received any apologies yet. Thank you, Chair.
Thank you very much. Before we continue, honorable members, I wish to remind you that this virtual meeting is deemed to be in the precinct of Parliament and therefore constitutes a meeting of a committee of the National Assembly for official purposes only. In addition to the rules of virtual sittings, the rules of the National Assembly, including the rules of debate, apply. Members enjoy the same powers and privileges that apply in a sitting of the National Assembly. Members should equally note that anything said in the virtual platform is deemed to have been said to the House and may be ruled upon. All members who have logged in shall be considered to be present and are requested to mute their microphones and only unmute when recognized to speak. This is because the microphones are very sensitive and will pick up noise which might disturb the attention of other members. When recognized to speak, please unmute your microphone and connect your video. Members may make use of the icons on the bar at the bottom of their screens, which has an option that allows the member to put up his or her hand to raise points of order. The Secretariat will assist in alerting the chairperson to members requesting to speak. When using the virtual system, members are urged to refrain or desist from unnecessary points of order or interjections. Members are reminded again, I made the same request yesterday, that you should switch on your videos when you do speak. And I really hope that you'll be able to comply with this request in order for the public to see who is speaking or who is asking any particular questions or raising any discussion points with the presenters. With that having been said, we will I've been looking at the platform to see who is present. Before I take your hand, Honorable Clerk, to see who is present, Ms. Majalamba from our first presentation, and it might be our group of first presenters, and it might be that we have some of the other groups already present on the platform, and they're all very welcome. I'm not going to introduce them at this stage. But only the first group from the OHSC. Can Mr. Majalamba, you inform me who is here from the OHSC, or can
Dr. Mbaweni is on the platform, Chair.
Thank you. Before I hand over to the good doctor, I'm going to take the hand of Honorable Clark.
Thank you, Chairperson. I am going to be on the meeting all day today, but I thought I'd just advise you that I'm really not feeling well. My sugar is sky high today and I'm battling with my eyesight. So just to inform you that you are aware of it, but we'll be on the meeting the whole day and I have prepared. Thank you.
Thank you, Honorable Clark. I'm not going I can give you medical advice now, but very short medical advice. Please take care of yourself. If your sugar levels are high, hopefully consult somebody rather and get those levels down. I think you know, as a diabetic, how to take good care of yourself. But please do that. Honorable Kaba.
Thank you, Chair. Mine is to just indicate, Chair, that I will be off around 10, between 10 and 10:30, but I will still be in the meeting. Thank you, Chair.
Thank you very much. No one else? No other?
Sorry, Chairperson. Yes, Chairperson, I'm moonlighting at the moment between committees. So I thought I'll just let you know that I'll be in and out for a while. Thank you very much.
Honorable Shaky, Ma'am, I always hear in your presentations at Parliament, you're so against moonlighting. Now you're doing it yourself.
I didn't hear that, sir.
I say at Parliament, you're always against moonlighting.
Yes, I am. But the only difference is this moonlighting is without pay, without additional pay.
Okay, big difference. Yes. Honorable Dr. Susan Tembakwayo.
Morning, Chair. I will also be in and out, Chair. Thank you.
Noted. Honorable Munyai.
And we are here. Please, let's proceed, Chair. Thank you very much.
Thank you very much. I'll hand over to the presenters from the OHSC. Who is leading it this morning?
Good morning, Chair. Good morning, Honorable Chair, and good morning, members of the Portfolio Committee. I'm Dr. Kinoshi. I'm the chair of the board of the OHSC. I'm accompanied by board members and also by the executive, being led by the CEO, Dr. Mdaweni. I'm going to just start, and then we hand over to the CEO, Dr. Mdaweni, to do the presentation to the honorable board members, honorable committee, portfolio committee members. I just want to start by indicating that the OHSC has, I'm glad to say, reverted to pre-COVID days in its operation. It was seriously affected by during the lockdowns. So because our inspectors who have to inspect the facilities could not travel during the hard lockdown. And as a result, in 2020 and most of 2021, our performance when it comes to inspections was limited. We also tried virtual assessments, desktop assessments, but as you know, those can be effective if people don't actually go and inspect the health facilities. So, but we have caught up now, and we have doubled our speed, and the CEO will inform you in her presentation just how quickly we are recovering from the block of inspections of facilities. We know that OHSC has been given a huge responsibility by government, in that the OHSC is the one body that is mandated to inspect and certify health establishments, both private and public, for them to be accredited by the NHI fund when it's set up. Once the NHI bill becomes an NHI Act. So we have a lot of work to do. We have mapped out our work going forward, and we know what is in front of us. And we just need to double up our efforts. And in doubling up our efforts, we have identified that we need to spread our wings and decentralize. Instead of operating from one office in Tshwane, we are planning to decentralize to some of the provinces. We'll start slowly, but maybe start with 2, but increase them in the next 2 years or so. So that plan will be discussed, obviously submitted to the Ministry of Health, to the Minister and the Department of Health for approval and support before it is done. I think it is all aimed at increasing the inspections, but also taking care of the managing the complaints, the backlog of complaints that we have had. We also know about the intention of government to separate the Office of the Ombud, Health Ombuds from the OHSC, and we are encouraged by progress being made in that direction. And Chair, I would just like to, Honorable Chair, I would just like to hand over to Dr. Mdaweni, the CEO, for the rest of the presentation. Through you, Chair.
Good morning, Honorable Chair and Honorable members, and thank you very much to the Chairperson of the OHSC Board, Dr. Kinoshi. On behalf of the Office of Health and Compliance, we bring the 2021-2022 annual report to the Portfolio Committee, and we're going to briefly touch on the mandate of the office and then discuss our annual performance information with the accompanying financial statements. The overall priority of OHSC as a regulatory entity is really to contribute towards better healthcare outcomes through the activities that we undertake in inspecting the health establishments. We do so that we can eventually realize our vision, which is consistent, safe, and quality healthcare for all. And indeed, as we undertake these activities, we endeavor to do so in an independent, impartial, fairly, and also a fearless manner. We are then governed by a number of values, and these values really dictate our day-to-day activities. And most of our values as an entity are grounded on strong ethical considerations. We want to be accountable for the results and the outcomes that we share with the general public and also the health establishment. And transparency is quite important so that we can always create that openness between managers and employees and ourselves, and also to ensure the safety of the healthcare workers as well as the users of our health establishments and the recipients of our services. And indeed, we subscribe to highest standards of integrity as the office. We're guided by the strategic outcomes as we have outlined them in our strategic plan over a 5-year period. I will go into deeper detail in the subsequent slides on the strategic outcomes for the Office of Health and Compliance. This is our organogram. Maybe to mention that we did come to the Health Portfolio Committee to indicate that we have since developed a new organogram which seeks to really align our activities and also would ascertain us that we're able to expand in our scope. The Office of the Health Ombuds currently is located within the OHSC, but the chair has already mentioned the move towards separating the two offices. It is the fundamental responsibility of any government to ascertain that there is provision of safe and quality services. The establishment of the Office of Health and Compliance in 2013 as an independent entity conferred particular powers to the office to ascertain that we're able to undertake this work. We're also guided by the procedural regulations which pertains to the function of the office, as well as there's norms and standards regulations for the different categories of healthcare establishments, which were promulgated by the Minister of Health in 2018. There are quite a number of policy and legislative mandates, most of them premised within our Constitution, Section 27, which really says each and every person has the right to access healthcare services, including food and shelter, and other legislative mandates. The most recent one, which is quite critical and important to us as an office, the National Health Insurance Bill, and also the chapter in the National Development Plan of 2030, which relates to health promotion. And it was in that chapter where government took the undertaking to establish the Office of Health Standards Compliance. As we undertake our work, we also draw from some of the relevant court rulings which emanate from some of the work that we do, particularly for complaints and investigations. Section 78 of the National Health Act indicates that we promote and protect the health and safety of the users of health services. This would then imply the government has a responsibility to play an active role in ascertaining that there is not only access to health services, but those services are of good quality, and there is also responsiveness of the entire healthcare system. We then do so by conducting these inspections so that we monitor and enforce compliance where necessary with the prescribed norms and standards. We also ascertain that the complaints that we received in the office, particularly in the Office of the Health Ombuds, are then dealt with and considered and disposed in a procedurally fair and an expeditious manner. The work of the office, really, we have 5 programs, 4 of which are the implementing programs and 1 supportive program, which provides leadership and overall administration and administrative support to the entire organization. 2020-21, 2022 financial year was a fairly good year for the organization. Like all other entities, we were affected by the COVID-19 pandemic. It did slow our processes, but we're able to pick up the speed as the chairperson has indicated. However, this had an impact in us in terms of undertaking some of the inspections. We were able to try and cover ground later in the financial year. Of importance is that the COVID-19 pandemic then brought to the fore some of the weaknesses which were already pre-existing in our healthcare system, but they became much more apparent for all of us and for the various stakeholders, including us as a regulator, to pay more careful attention in terms of how do we turn the situation around to ascertain that our people receive good quality services. We also take the lessons learned from the COVID-19 pandemic to propel us to be better in terms of the regulatory work that we undertake. When looking at this depiction, for the financial year 2021-22, we had a total of 21 output indicators as indicated in our annual performance plan, which we were reporting. And out of the 21, we were able to achieve 14 of those, and we fell short with 7. Our biggest pressure point, if we look at the various programs, would be program 3, where out of the 5 annual targets which we had, we're only able to achieve 1 and 4 were not achieved. And as we go down through the other depictions, we'll then explain some of the contributory factors around this non-achievement. But overall, we are happy as an entity that we're able to do most or to be able to reach or achieve most of our targets. Now we're going to go through the programs. Program 1, in this program, we have all the supportive functions, the human resources, community and stakeholder relations, information communication technology, finance and supply chain management. I will then go through the output indicators. Honorable members will note that some of the indicators that we have in our annual performance plan will then be related to the establishment of the office as they are in our strategic plan. We wanted to ascertain that we have a fully functional office that is effective and efficient. The vacancies which were filled within a 4-month period, for 2021-22, we had a target of 90%. We're only able to reach 21.4%. The reason why we were unable to reach this target is that we were not able to fill these posts within a 4-month period. However, let me report that out of the 14 vacant posts, we're able to fill 10 of these posts. By the end of the financial year, out of a staff complement of 123, we were standing at 119. Again, on the sub-program Human Resource Management, we are required to train all our inspectors with a certified course. Out of a staff complement of 42 inspectors, 40 of those were trained and they were certified by the office so that they can be able to undertake the inspections in our health establishments. The two next output indicators will relate to the availability of information, communication, and technology services. As I've indicated, that part of the responsibility of the board and the OHSC management was to establish the office. Now here we were monitoring the availability of these services, particularly in relation to our core function, that is the automation of most of our activities, the inspection tool, the establishment of other regulatory processes like the early warning system and annual returns. We're happy that we're able to have an uptime of 99% for the entire year. Similarly, the next output would be the availability of IT services to support all other related processes for the organization. And once again, we were fine and we maintained 99%. As we move and to the next strategic plan, most likely some of these indicators will fall off because we wanted to monitor these at the beginning of the office. The next sub-program, communication and stakeholder relations. It is important that we interact with various stakeholders, both in the public and the private sector. Here we were monitoring the number of engagements that we were having, particularly in the public sector. We conducted roadshows in provinces, particularly focusing in rural areas, so that we can educate and raise awareness in the public around the work of the Office of Health Standard Compliance and the Health Ombuds. And we did these roadshows in Northern Cape, Northwest, and Mpumalanga. And overall, we were able to achieve 32 of these. We also undertook a radio advertisement campaign. We targeted community radio stations, about 80 in total, and the coverage was 4.9 million listeners. And during these interactions, the members of the general public were able to interact through live in radio calls with management colleagues in the Office of Health Standard Compliance. It is important for us as a regulator to have our footprint in the private sector. Most of the work that we did in the private sector started much later because we awaited the promulgation of the norms and standard regulations. We were able to reach this target as well. We do realize that we need to do much more in terms of reaching these stakeholders, particularly in the private sector. We're able to place advertorials in a number of different publications, both digital and print. And we also held a number of webinars and participated in other professional platforms where we're able to once again raise awareness around the work of the Office of Health Standard Compliance. Honorable members, we are pleased that for the 6th year in succession, we once again report that the office received an unqualified audit opinion from the Auditor General of South Africa. And for these, we thank the board, the OHSC staff, and also the support that we have received from the Health Portfolio Committee for us to have this achievement. The next program would be the Compliance Inspectorate. This is the largest program in the Office of Health Standard Compliance. And mainly it's meant to manage and conduct the inspections and to facilitate compliance with the prescribed norms and standards. Our targets are divided around inspections that we conduct in the public sector and those that we conduct in the private sector. For 2021-2022, we had a target of 299. This target was really based on the budgetary constraints which we had at that point in time. However, we are happy to report that we managed to conduct 544 inspections of the initial target of 299. And this is as a result of some of the internal financial and operational efficiencies which we had to undertake in order for us to be able to do more with the little that we had. We also utilized the surplus funds to also get additional human resources to assist with inspections. However, since these are surplus funds, it's difficult for us to make long-term commitments in terms of increasing the staff complement. We're able also to do some inspections other than the routine ones. These are the risk-based inspections, which we pick up through reports in the media. And we're also able to finalize the district and the regional hospital tools, which we also then piloted in the specific institutions. Overall, where we stand as a regulator at the moment, since our inception, we have conducted 1,578 inspections out of a denominator of 3,748 health establishments. Let me hasten to mention, honorable members, that the 3,748, it's not the actual total number of the health establishment that we need to reach as a regulator. We do know now that the master facilities that the National Department of Health currently has a total of about 52,000 health establishments. As a regulator, we need to at least reach out at least once in 4 years. All those 52,000 or so health establishments need to be inspected. This would then indicate the enormous amount of work that actually lies ahead for the Office of Health Standard Compliance. We also, for the private sector, we have reported, honorable members, that we have not been able to start with the inspections in the private sector. However, we are pleased that we now have the tool finalized. It was a lengthy process, probably much longer than what we anticipated. When we started to work with the private sector, we then realized that the service platform is slightly different from the public sector. We needed to adapt. We had to hold numerous consultations. We needed to understand their service delivery platform. However, at the moment, we do have the tool that has been finalized, and we are definitely going to start with these inspections at the end of Q3, most definitely Q4. So when we next come to Parliament, we are certain that we will be able to report on the inspections that we have conducted in the private sector. We're also required to conduct what we call additional inspections. These are actually re-inspections, which means that after we have conducted a routine inspection, if that health establishment has not been certified as compliant with the norms and standards, we're then supposed to go back to that health establishment and conduct a re-inspection. Since the promulgation of the norms and standards regulations, it was for the first time during the financial year 21-22, where we were able to conduct these re-inspections. We had a total of 182, which we had to conduct, and we're able to do 181, but at the moment, we are standing at 182 because the one health establishment which could not be inspected at that time was because of the renovations which were not reported, but it has since been inspected as well. I would like to take members through our projections over the financial years. If we look at 2017, 18, 19, you'll realize that we were able to conduct 930 health inspections. And then in 2018, 19, 730, followed by 647. We took a dip to 387 and 544 for this financial year. We have put a target of 786 for the next financial year, 2022, 2023. And as a result of really the additional staff that we have got, but as I've indicated, these are mainly contractual, so we cannot most likely hold them for long. But we've also undertook some processes internally to really be more efficient in terms of how we conduct our work. We're also required to then publish these outcomes and findings of inspections. Biannually, we are supposed to indicate all the names of health establishments that were inspected and certified. We were able to publish these two reports in our website, These really would indicate the name of the health establishment, the province, and whether it was compliant or not compliant. We also have a report which is more consolidated. It's an annual inspection report. We will come in the near future to the Health Portfolio Committee to then discuss this report. Now, this is a consolidation of all the findings where we then make recommendations on quality assurance to the entire healthcare sector. We have published the 2019-20 report, the 2021-22 annual inspection report. It fell into the next reporting period, which is 22-23, because there are certain other processes which we cannot ignore, such as giving an opportunity to the health establishment to respond to some of the queries and findings when we provide them with the preliminary reports. However, we do have this report and it will be brought to the Health Portfolio Committee. The third program, which also housed the Health Ombuds, relates to the complaints management, where we then consider these complaints that are submitted by the members of the public and are then managed and resolved within the program. As I have indicated earlier on, this is the program where out of the 5 targets which we had put for ourselves, we're able to only achieve 1. And this is the one that relates to the resolution of the low-risk complaints, which are within 25 working days since they're lodged with the call center in our office. For the financial year, we received 3,317 of these low-risk complaints, and we're able to resolve 2,756. Now, there was also a backlog that we had to deal with, but we're happy because in the previous years, when we came to Parliament, we were actually in the red even with this indicator. However, we're able to actually even surpass the target of 75%, which we had put. Now, the next 3 honorable members are all in the red. These are complaints that are resolved within 30 working days from the receipt of the complaint. One of the reasons and the contributory factors for this is that for the office or the Health Ombuds to resolve this case, there needs to be interaction between the office as well as the health establishment and the complainant. Now, often the health establishment do not necessarily comply with the timeframes that are provided by the office, which then leads to the delays. However, even though we are on the red, if we look at our performance over the financial period, we do note that we definitely had a steady increase from 7.4%, which we reported in the first quarter, to 27% at the end of the year. We also must indicate that we do not have a lot of staff or an adequate staff complement for this unit. We are at a 45% staff shortage in complaints and investigation, and this is a matter that the Health Ombuds has also previously alluded to. The next output indicator, the complaints that are resolved within 6 months, once again, we are in the red here. We had a target of 10%. We were only able to achieve 4.4%. And once again, the major issue here is the lengthy period in terms of interacting with the health establishment. And we've also discovered that the nature of these complaints tend to be very long in terms of undertaking the investigation, which would also require site visits and many other interactions with various stakeholders who are not even located in one facility, because most of these complaints would, or the complainants would have been through a number of health establishments. The next one, it's complaints resolved within 12 months. We had a target of 5%. We're only able to achieve 1.3%. What is of note in this indicator and the next one is that the office and the Health Ombuds has been busy with dealing with the backlog of cases, which have been resolved, and we have indicated them in our quarterly performance report. But because we are limited by the time period of this report, which is 21-22, we could not then include them in our output, but there's quite a lot of work that has been done in terms of really dealing with the backlog of cases. One other contributory factor is that we have seen an exponential increase in the cases that we receive from the general public, particularly around the COVID-19 pandemic. Now, that linked with the backlog of cases did pose some serious challenges for the office. Although with this one, these are the cases that are supposed to be resolved within 18 months. Although we did not resolve any within the prescribed period, we were able to deal with 13 backlog cases, which fell within this indicator. However, as I've indicated, those are not necessarily indicated here. So this is one program that we are focusing on, and we have established other processes in terms of how we deal with the backlog. Although it is not showing here, but we do report that there's quite a lot that has been done in trying to clear the backlog of the cases. The next program, the Health Standards Design, Analysis and Support. This program is really aimed at ascertaining that we as a regulator, we facilitate compliance with the norms and standards. It will also deal with the trend analysis of the findings that we make in all our activities, and also the training of all the stakeholders so that there is a basic and a common understanding and common interpretation of the standards as they appear in our inspection tools. We wanted to produce 3 reports, consolidated reports for the financial year. We were able to do so. I need to indicate to the honorable members that these are reports that take quite some time to develop. In that, we need to look at all our input data. We need to look at data that comes from the early warning system. We need to look at data that is submitted by health establishment, which we call annual returns. Once we've received all this information, we then consolidate it and start to analyze it so that we can then provide the health establishment with reports with certain recommendations. The early warning system report related to the monitoring of the indicators of risks on serious breaches of the norms and standards. The annual returns report, really here we look at the profile of health establishments. These would be input into the healthcare system, such as the staff complement, the training that is conducted, the budget. It is clear that if we do not have adequate and sufficient input into the healthcare system or a health establishment, you will then not be able to provide quality services. Once we've then analyzed this information, we then share back with the health establishment as recommendations, and also with the districts and the provinces so that they can be able to determine where are the pressure points and what areas they need to focus on in order to support the health establishments to reach or to meet the standards. We're also able to submit a report to the Minister of Health through the Ohsc board on the review of the norms and standard after the first year of implementation. The norms and standard regulations after promulgation in 2018, we then developed the tools and we implemented. It is also our responsibility to then inform the entire healthcare system in terms of what is our experience in the implementation of these regulations. We have identified some gaps, which we then have communicated. But I must indicate that even though I say we've identified gaps, it does not mean that the current regulations are not sufficient. The reason being that there was a conscious approach which was taken back then, that our approach will be incremental and developmental in nature. It therefore means that as you regulate, you will not be able to look at the entire spectrum of the quality of services. You will then be in an incremental approach, determine whether health establishments are able to meet a minimum set of standards. And once they have done so, you then move to the second level. We do anticipate that in the nearest future, when the department or the minister reviews the norms and standards, some of these gaps will then be considered in the revision of the norms and standards. We also have to interact with the various stakeholders in terms of providing them with guidance on how they should utilize these tools, but most importantly, to facilitate compliance with the norms and standards. So we do so through conducting these workshops to the managers and the leaders on inspection tools. We're also able to meet this target at 26 of a target of 24 for the financial year. The last program, certification and enforcement, this is where we certify the health establishments to be compliant or non-compliant. So once the inspectors have completed the reports, they will then hand over to the certification and enforcement unit, so that that also is an independent process where then the program will then determine whether the recommendation for compliance is actually accepted or not accepted. So far as an office, we have certified 33 health establishments in 2020. In 2021, we have certified 189. Out of the 189, only 161 were certified within a 15-day period. This means once a recommendation to certify is received, the certification or the compliance certificate should be issued within the 15-day period. It is for that reason that our plan target here is 100%, because we want to ascertain that all those that are recommended for certification should be certified. So as much as we've certified all of them, but it was only those 161 were within 15 days. But then it would be maybe the others maybe were within 20 days or maybe 25 days. This, honorable members, it's quite an important program for us as an office. The rate of certification or compliance with the norms and standards is low, and the focus in 2022-23 and moving forward is to ascertain that we support the facilities so that we have much more facilities that are actually certified and receive the certificate of compliance. This becomes even much more important and apparent with the implementation of the National Health Bill. Now, this depiction just shows by province the compliance certificates which were issued. The most were in KwaZulu-Natal, followed by Gauteng, then Mpumalanga, and the red at the top indicates where the certification was done, but outside the 15-day period. One of the most important powers that the office has is that in instances where there's persistent non-compliance with this standard, that we should be able to take enforcement action. In the past, we have reported that we have not started with the enforcement action. However, we're happy to report that the office has started to take enforcement action. Once a health establishment is inspected, the outcome could be that we issue a compliance certificate, which is what I've just explained, within 15 days, or we'll issue what we call a compliance notice. A compliance notice will then provide to a health establishment all the non-compliant norms and standards, and also indicate the time frame within which the health establishment should then remedy the non-compliance with the norms and standards. After that, we then have to go back and re-inspect those health establishments where we have issued notice of non-compliance. Once we discover that that health establishment is still non-compliant, then we take a enforcement action. In 2021-22, there were 24 re-inspections which were conducted, where we found that there was persistent non-compliance with the regulations. We then took the enforcement action in the form of warning letters. And I must indicate that the facilities have since been responding. Although some of this information fell into the first quarter of 2022-2023, however, all this work started in 2022. So we have started to take enforcement action where we think it's necessary and it's appropriate. Once again, biannually, we're supposed to then report on all those facilities where enforcement action was undertaken, and for the financial year, we were able to do so by producing these reports. That brings us to the end of the program information. We'll then go into the financial, the accompanying financial statements. But overall, we recognize that there's still much more that needs to be done, but we're happy that we're able to reach most of the targets. And we're also very much aware that much more needs to be done with regards to improving the resolution of complaints in program 3, and this remains work in progress for the Office of Health Standard Compliance. Honorable Chair, I'm going to request my colleague, Mr. Mapata, to then assist us with the next couple of slides. Mr. Mapata.
Thank you, CEO. Good morning, Honorable Chair. Good morning, Honorable members. I will present the summary of the financial information of the OHSC. If we can move to the next slide, please. On this slide, honorable members will see that the revenue of the OHSC increased by 15%, with the National Fiscal being the main contributor to the OHSC's revenue at 98%. And in general, the expenditure increased by 12%, and 67% of the expenditure of the OHSC is largely in compensation, because of the nature of the work of the OHSC, which relies on human resource to conduct the inspections and also conduct the necessary investigations. Next slide, please. In terms of comments on financial performance, once again, the OHSC has achieved a clean audit from the AG, same as last year. It was also a clean audit. We've seen, as indicated, a 15% increase in terms of total revenue. And we also saw an increase in interest on short-term investments as a result of the increase in interest rates by the Reserve Bank. And on the expenditure side, it increased because we had a number of contract employees who assist in the work of the OHSC, funded from the surplus as indicated by the CEO. And with the easing of lockdown restrictions, we've also seen an increased traveling in conducting the inspections. Next slide, please. And in terms of the surplus, these were the major contributors to the surplus. Towards the end of the financial year, with only 1 month left, we received additional revenue from the National Treasury. So it was not feasible to spend that money within 1 month. So it had to be rolled over into the next month. In the next financial year, we also had additional revenue in terms of interest and also the impact of COVID. But we are also happy to indicate, as indicated in the next slide, that in terms of total expenditure pattern, here we show the impact that COVID had on OHSC spending. In 2019-20, before the emergence of the pandemic, we were sitting at 158 million rands in terms of total expenditure. During 2020-21, it went down to 135. So it went down by almost 23 million, and picking up again in 2021-22 with some relaxed restrictions on COVID. Currently this year, our budget is 157 million. So this 157 is taking us almost back to where we were in 2019-20. So we expect that during 2022-23, expenditure will increase as the volume of activities has also increased as a result of the easing of lockdown restrictions. Next slide, please. We have since obtained approval from the National Treasury to retain the surplus. And in this end, we have a plan of using this surplus in terms of short-term employment contracts to supplement human resource capacity in the Inspectorate and also in complaints and other units. So the aim here is to increase inspection coverage and also increase in terms of the resolution of complaints that we received, and also clear the backlog in terms of investigation complaints. And also we want to continue implementing the communications and stakeholder relations strategy This is a matter that the portfolio committee has always raised with us to increase our visibility and to ensure that stakeholders are aware of the OHSC and the work that the OHSC is doing. So this is the plan that we intend to do, continue doing during the course of this year, using the surplus funding as well. So we can go to the next slide, please. I've already spoken to this slide in terms of the 12% increase on expenditure. We can skip this one. Now, in terms of the share of percentage per division, we see that on this slide, 55% of our total spending is in terms of the core functions of the OHSC, which is the Compliance Inspectorate, Complaints Management and Ombuds Certification Enforcement, as well as the Standards Development Division, with 45% being in support services, CEO's office, HR, finance, the board, IT, stakeholder communication and stakeholder engagement, as well as facility management. Next slide, please. In terms of compensation costs, almost 70% of the expenditure and compensation is at levels 9 to 12, and that is where the core of the operations resides. Majority of those are in the Inspectorate unit, with the other 30% being spread across other levels, but there's strong bias towards the core component of the employee cost in terms of distribution. Thank you. The next slide, please. And in terms of the staff complement, at the bottom table, support functions make up 28%, up by 1% from the previous financial year. And core functions make up 72% of the total staff complement. So there's a clear bias here in terms of distribution of staff, with most of the staff being in the core functions of the OHSC. Next slide, please. I think that was the last slide. Thank you, Honorable Chair. Thank you, Honorable Members. Thank you, CEO. I'll pause there. Thank you.
Board Chair or CEO? Anything else?
Thank you very much, Honorable Chair. That would be it from our side. That was our offering.
Thank you very much for that presentation, and congratulations on your unqualified audit which you have received. I'm going to give an indication of the members who want to raise some points with you. It's Honorable Members Ismail, Clark, Van Staden, Gela, Tembakwayo. Any other members? Ismail, Clark, Van Staden, Gela, Tembakwayo. Munyai? Any others? If not, we will proceed in that order, Honorable Members. Thank you.
Thank you, Chair. Good morning. Sorry, something happened with the network issue here. So I just have a few clarity-seeking questions, and good morning to the panel that have come of the OHSC that have come to present today. As I stated, I just have a few questions. And my first point is there was a 6 million rand government allocation to boost capacity within Compliance Inspectorate program. What are the current capacity needs within this program, and when will these positions be filled? My second question, since 2019, since the 2019-2020 year, program 1 has been overspending, that is 12.9 million in 2019-2020, 3.7 million in the 2020-2021, and 7.3 million in 2021-2022. Now, what measures have actually been put in place to prevent this overspending from continuing? My third question is looking at the amount of media, social media platforms to say fires and lack of generators at our public hospitals, and whistleblowers complaining about, working conditions at our public healthcare facilities. How has the OHSC actually dealt with these issues? And my fourth question, one of the reasons given for the underperformance under Program 3 is obviously delays and lack of responses from health establishments for requested information. This is actually unacceptable. What plans has the OHSC put in place to actually address this issue as it impacts directly on its performance? And when it comes to, the NHI, we know that for any public healthcare facility to actually operate under the NHI, these facilities need to be, certified as compliant. Now, looking at the space where we are now, do you as the OHSC feel that, you will reach the targets intended with the NHI to be able to have this certification in place for all our, or not maybe all, but I mean, most of our health establishments, that's primary healthcare district and our public hospitals in preparation to be functioning under the NHI? And on the point of certification of health establishments, this is my last question. I noted you said that, you give certification, etc., but I wanted to understand the ideal hospital and ideal clinic situation where, certification is given, for example, for an ideal clinic. But, we still have the same clinic complaining that they are short-staffed and, they haven't got enough infrastructure or capacity for these clinics to actually operate in an ideal situation. Kindly advise on this, please. Thank you.
Good morning, Chair, and good morning to the team, and thank you very much for the presentation, and congratulations on your outcomes in terms of the audit and the Auditor General. Really well done. Just a couple of questions I'd like to ask. In terms of the service providers for your IT, does the service provider also provide a maintenance contract in terms of when the necessity arises? And then of the 194 posts on the structure that's unfunded, how does the OHSC plan to address its limited investigation capacity? And I mean, if I look at the attachment that was sent with the report, there's 8 environmental health inspectors short, 4 waste audited practitioners, and around 63 complaints officers. And I think that makes your job incredibly difficult. And is there any move from the Department of Health to assist in order to fund some of these posts? Because obviously, our hospitals are really not in a great state at the moment, and you obviously have to deal with quite a lot of complaints. Then if you could tell me why were only 33% of targets for certification and enforcement achieved? This is within the AG report, and what remedial measures were put in place to deal with that? How many backlog cases are left, and what is envisaged timeline for resolving them? What are the root causes for non-compliance of inspection? And once you re-inspect, do you find that these hospitals or clinics comply to the resolutions you put in place? And then in the last 5 years, complaints to the OHSC increased by 332%, 713 in 2016 and 2,427 in 2021. In 2017, the OHSC spent 9 billion Rand of their 12 billion budget and still managed to inspect 696 facilities. In 2018, inspections decreased to 234 cases, but the budget increased by 50 billion and 49.7 billion was spent. If I could just have an answer to that. And then my colleague, the Honorable Ismail asked you, do you think that our current health environment can support what is expected of us to deliver in terms of NHI? Then in program 2, only 25% of targets were realized, and what consequence management is put in place in terms of the performance of this program? And then one of the reasons given for underperformance under program 3 is delays and lack of response from health establishments for requested information. What plans has the entity put, Hasina, Member Ismail has asked that question, so we will get that feedback from you. Thank you, Chair, that's all from me.
Thank you, Chairperson, and thank you for the presentation. I have just a few clarity questions, seeking questions that I want to know. Out of your staff members, the 4 vacant posts that is left, and you've got now 119 filled out of 123. My question on this is this sufficient? And if not, what do you see as sufficient number of staff members? My second question is there enough funding for extra staff members if needed? I see that you reported now this morning that you only have 42 inspectors, am I correct? For the whole of South Africa, but in 2019, you reported to us that you had 44 inspectors countrywide. So there's a decline there. If you can just correct me if I'm wrong or I'm reading it wrong, and what is the situation there? And if it has indeed declined, why? My fifth question is on how many complaints have you received from the public and private sector respectively? And then just for clarity, on slide 40, you've mentioned 189 health establishments that has been certified. Is the safety audits of hospitals in all 9 provinces, does it fall under this category? If not, can you give us the current status of the hospitals and clinic safety audits in all 9 provinces respectively? And then my last question, Chairperson, is does this office have sufficient funds to be able to perform their duties properly? Thank you very much.
Thank you very much, Chairperson. Let me also welcome the presentation and also congratulate the Department of OHC to get a clean audit, unqualified audit report from AG with no material findings. That is the good achievement for the department. Other questions that I wanted to raise is the issue of overspending, but it's been covered. I'm not going to repeat that. We'll wait for the response. But also the other issue that I want to raise, Chairperson, or need a clarity on, can we be updated about the progress of reviewing the organogram and how much is set aside for that implementation of revised organogram? That will be my question, Chairperson. But also under performance, the program 3 and a lack of responses from the health establishment, and also what is the plan of the entity to put in place to address all these issues directly on the performance. Thank you very much, Chairperson.
Thank you, Chairperson. And thank you for the presentation that we received today. Some of the questions obviously have been exhausted by the previous honorable members that engaged on this presentation. I just would like to refer the committee to, according to their mandate, which is consistent, and they said it's safe and it's health care for all. I would like to refer them to the evacuation of pregnant women in Dora Ngiza Hospital in Nelson Mandela Bay, where doctors were prevented by striking nurses to help them. As such, it was shut down. Even though the strike was unprotected, but the nurses were striking over genuine matters. And then I will also refer it to the complaints that other side. And I just would like to ask the department to say, what was your contribution in ensuring safety for both the workers, inclusive of the patients. If you were not involved in solving of this problem, what is the reason why you were not involved? And then I'll proceed to the second question, but this one is a mere request for your department to finish us or to finish me with the draft inspection tool that is going to be used for strictly the private sectors, and then including the tool that is presently used for the public sector, so that a person can be able to draw the differences, and if it's possible, to engage you on the contents of that particular tool that is used for the public sectors and the one that is being drafted for the private sectors. The third one, there was a mention, especially when the presenter was discussing issues on compliance inspectorate. That's what I noted. And he said the report will be given in the near future. My problem is near future can be a day, it can be a month, it can be 5 years, it can be indefinite. So we don't anticipate to get such utterances from your department. So I just need to be finished with what is the anticipated date, the corrected date. Can it be in 2 years or 1 year or whatever, but never use the word near future, because we won't be able to get anything of such reports from your department. The following one is in connection with the backlogs, and it has been mentioned during the presentation that there is a problem of interaction between the health sector and the Office of the Ombudsman, something that is not supposed to happen, and as it is proclaimed as causing delays. So how do you, as a department, intend to solve this problem that causes a delay? And it's all because of the interaction, which means there is no working togetherness between these two offices. And it's upon your office, as it is mandatory, especially when it comes to monitoring and bringing about a healthy relationship between some offices that are reporting under your department. So I just want to know, to say, what is it that you have in mind, the recommendations, and genuine recommendations, not just simple recommendations that we won't even understand what you are talking about. And then the last question would be, can you describe the nature of historic backlog cases and measures to resolve it? And just to ask you, because I said I'm also going to refer to this strikes and everything that are happening in hospitals. It's not only in Dora, but it's happening all over. Do you, under the cases that you receive such complaints? Are they part of the backlog cases that you have? Thank you, Chairperson, for the opportunity.
My hand was up. I don't know if I can have an opportunity. Thank you.
Honorable Munyai, and then yourself, and then Hlengwa.
Thank you, Honorable Chairperson. I saw the face of Wilson. I thought perhaps maybe there's a new intervention. Firstly, is to salute the organization for unqualified audit. Under expenditure for us, it's a crime. Over expenditure, it's a irregular expenditure. So that people must use the money against the approved budget. They cannot perpetually continue with the irregular expenditure. That is the only thing I want to cite. I'm very happy that the ministry is attending to the issue of the of the ombuds to stand alone, consistent with the law and other best practice internationally. After all, you have done well as an organization, but I don't tolerate irregular expenditure. For each and every organization that will come before us, irregular expenditure, I would say the same song. If they cannot continue, because if they continue to do that, they'll undermine the treasury regulation, and it's not right. It's not right. They must work according to the approved budget. Thank you.
Thank you, Chairperson, and thank you for the presentation. I think principally I'm covered. There's just a couple of things I want to raise, and I think these are major concerns. And I'm looking at the AG's report on your program's fee certification and enforcement, where only 33% of the targets were met. Now, I understand that COVID did have a part to play in this, but the fact remains is that it's a serious situation, because the purpose of certification and enforcement is to certify compliant health establishments and take enforcement action against non-compliant health establishments. And enforcement must be considered when health establishments are found to be non-compliant with norms and standards, which potentially impede the quality of care for citizens. Non-achievement of targets could result in citizens receiving poor quality of health in the health establishment. Now, there's absolutely no doubt whatsoever that this is very much the case. The quality of health in this country in probably 90% of the facilities is just damn right horrendous. It's appalling. And what happened at Dora was just one example of probably hundreds we could cite. And that is concerning for me. And while your organogram doesn't look bad, the AG's report said that according, your target over the next couple of years is to increase to up to 22% in checking on 22% of facilities for compliance. 22% is a very small number, but I understand that you are being hindered by staff shortages and lack of inspectors. So principally, I need to know how we're going to get around this, because number one, NHI cannot work if facilities are not compliant, and that's straightforward. And it's not just a case of being compliant, it's a case of meeting specific standards in order to be registered as a NHI health facility. And amongst the discussions that we have there, that is going to be registered against a World Health Organization standard. And I don't think there's very many, probably a handful of facilities in this country at the moment that will meet that standard. So that is my major concern, is that, we are non-compliant. Quality of healthcare is shot in this country. We are not inspecting enough. We're not inspecting fast enough. I understand that you are hindered by budgets, and I understand that you are hindered by staffing and inspectors, but it's something that I think that this portfolio must address very quickly at the highest level, because the situation in the country right now is quite frankly dire. Thank you.
Honorable Sengo.
Thank you very much, Chairperson. First of all, let me welcome the report from the Office of Health Ohsc board. Let me welcome such a report. But I have two seeking clarity questions. First of all, I have been partly covered by my colleagues, more especially Mrs. Clark. But I have a specific issue of this backlog of cases, because I have brought a complaint, or I have launched a complaint or case that has been happened in Endeavour General Hospital in Gauteng in 2021, June 19. That was Mrs. Tolle, and who died there, and the complaint was there.
My worry is that the office have wrote a letter of acknowledgement of the complaint to the family, not advising even the health committee or the one who has launched a complaint. That is the number one. Secondly, second clarity question.
Listen.
Sorry.
Hello? No, sorry.
Okay. In your projected 24-32 inspection for the next 3 years, how does this line up with the comments that there are upwards of the 52,000 health establishments that need to be investigated once every 4 years? I thank you.
Thank you very much, honorable members, for all of those questions you had raised. Is there anyone who has been missed out? And if not, I'm just going to speak on 1 or 2 issues because we've had, I would think, quite a large coverage of the content of your presentation being raised by the honorable members. For me, it's just about the targets, which was also raised. I see in both, in all of your programs, program 1, you reached 6 out of 7 targets, of which specifically the one that was not reached is on vacant posts. On program 2, you've reached 75% of your targets. In program 3, you've reached now higher 20%. I see another honorable member mentions 33%. I'm not exactly certain which one that is. But understanding your historic backlogs, there is this challenge of the vacancy rate again. And the mention there is that in terms of the overspending, it was because of the short-term contracts. Yet there is still this vacancy of posts. And then in program 4, the same thing seems to repeat itself for vacant posts. So I just want to bring those 2 to your attention. One of targets not being fully reached for whatever reason, but what your plans are to improve of this for the immediate future. And also in terms of what the possible causes are. And you're not the only entity. We seem to find this throughout that there are vacancies. And there must be reasons for those vacancies, whether you're not finding properly skilled people or qualified people, whether it's maybe cost to company, or whether it's expectation of higher salaries of those who seek employment, etc. But surely we need to be able to address this problem when, as Honorable Munyai had said, money is allocated for particular purposes, and it will assist our economy also if we should be able to employ people for the posts which are funded for that particular post. And those are about the few things I want to mention. So, Board Chair and CEO and CFO, it's back to you to answer all of those questions. Thank you very much. If we do finish earlier, honorable members, we will take a break because the CEO of the SAMRC is in another meeting. They will only be able to join us at 12. So we will then see what time we finish now. Thank you very much. Please continue.
Thank you very much, Honorable Chair. I think we have noted all the questions from the honorable members, and I will, for now, defer to the CEO to assist in answering some of them. She let us know when the board needs to come in. But CEO would like to start if you allow it, Chair.
Thank you very much, Chair. We thank the honorable members for the questions that have been posed, and we also welcome some of the general comments, and we have noted where they've also made suggestions. Shall be assisted by my colleagues in some of these questions. There's a question that has been asked by a number of honorable members around the national health insurance, whether we as the OHSC will be able to reach the target or even be able to inspect and certify health establishments, both in the public and private sector, so that they can participate in the NHI fund. Linked to that is the second question, which relates to the certification of these health establishments. Let me give the assurance to the Portfolio Committee on Health that we as the OHSC are definitely up to the task in as far as the national health insurance is concerned. However, we have been open and acknowledged the current weaknesses which we have, that is the staff shortages we are experiencing. In as far as the planning, the preparation of what needs to be done, I need to report that we just recently held a strategic planning session with the OHSC board, where we actually discussed and brainstormed the different approaches and all the activities that we would need to undertake. Also, about a year ago, the OHSC board approved an organogram, which really will assist us to be able to decentralize our functions and activities to other provinces. We do have the organogram with the staff complement that should assist us to expand the inspection coverage. However, it is also important to note that funding for this organogram is necessary. Now, as much as we have realized these surplus funds, even during this reporting period, the only thing we could do was to get contractual staff to assist us with some of the activities. But it is very difficult to commit surplus funds. In fact, you wouldn't be able to commit them to full-time employment because we do not know whether we would have those funds. Now, once again, with the National Health Insurance, as I've indicated that internally, the planning has started, and we already are aware that we need to have an increase in the staff complement. We also, in our activities, and as we interact with health establishments and other stakeholders, we do share and discuss some of the issues that health establishment needs to pay attention to with regards to compliance. We've indicated that our mandate, and one honorable member has also mentioned this, that we monitor and we enforce. One of our critical functions as an entity is to facilitate compliance with the norms and standards. And to that end, through the reports that we share with them, the interactions, we do raise these issues so that we can then be able to have more health establishments complying with the regulations. We agree and we admit that it is a concern for us that the compliance rate is slow and it's also low. We've been working with the National Department of Health at various levels in the provinces, at district level, and also through the quality learning centers so that we can have other concerted efforts put together to assist facilities to be able to comply with the standards, although we know that our role then come in more at a regulatory function. So we are ready for the NHI, but we'll only be fully ready once we have the accompanying resources that will enable us to take the processes forward. One of the major activities that we need to undertake, as mentioned by the chairperson of the board, Dr. Kenoshi, is decentralization of the functions of the Office of Health Standard Compliance. We will not be able to expand our inspection coverage, our certification coverage with the current model that we're implementing in terms of delivering our services. So it is crucial, it is an imperative that the office decentralize so that we can be able to reach more facilities. Now, the certification and the ideal hospital and ideal clinic, that was asked by, I think, Honorable Ismail. The two processes, what we do as OHSC and what the National Department of Health does or is doing through the ideal clinic and ideal hospital, those are very, very important and interdependent in that the ideal clinic and ideal hospital framework is a quality improvement process. It will go beyond what we look at as a regulator. It would look at other aspects of quality, which maybe we do not even have in our standards. It's supposed to be a sustained process. It's supposed to be ongoing. When we then regulate, we then come and say, are you compliant? Are you non-compliant? We then also feed back to the health establishments, districts and provinces on our findings so that they take these findings and incorporate them in the ideal clinic and ideal hospital framework in terms of the remedial actions that needs to be put in place. So the plans that the ideal clinic, ideal hospital would have should then incorporate our findings with regards to inspections or any other work that we do. So that would comprise a quality improvement process, whereas ours will then be a quality assurer. But the two, as I've said, are then interdependent or maybe even interlinked in that one would feed into the other, but one being even much more comprehensive. A question was asked by Honorable Clark, is there a move by the department to assist with staff? We have raised the issue, and I must say that the National Department of Health is very much aware and they are awake to the challenges that we are facing. In various platforms, they do indicate the need for capacitating the Office of Health Standard Compliance. And we must indicate that during the reporting period of 21-22, we received additional funds to assist with the Inspectorate functions, particularly in the quality learning centers. So I think generally in the healthcare sector, we all are aware and we all acknowledge that there needs to be funding for the Office of Health Standard Compliance. But beyond that, as the office, we've also started a process of revenue generation. It's still at its nascent phase, where we will then take it through the necessary and required steps so that we can also start to generate revenue based on the work that we undertake. And this is allowable in the Act for us to do so. So that should assist. But even if we were to do that, we do realize that we still require funding from the national fiscal so that we can be able to undertake all our activities. We also accept that the issue of funding, the issue of expanding our work, it's always at the topmost agenda of the OHSC board and also in various discussions that we also have so that we can be able to meet our mandate in the Act for the NHI and most definitely for the entire healthcare system in terms of improving the quality of services and safety. Yes, indeed, the 33% is low for certification, and that is the 33 and also the 189. But we are then saying we need to, and we are working together with the provinces here and the districts in saying, what are those elements that, based on our inspection findings, that should be really taken care of, or where the focus should go so that these health establishments are assisted to be compliant. When we then share our reports back with them, not only do we just submit the reports, we then interact with them. So that's also part of what we do in terms of facilitating the compliance with the norms and standards. There's also a responsibility that is at service delivery level, both the public and private, in terms of incorporating these findings and some that are actually in our reports. And we always remain available in the event a stakeholder would want to engage further with us or would seek guidance in terms of how they should comply with the norms and standards. So the current environment, I think the ground is laid for us to be able to move to the next phases in terms of the implementation of the National Health Insurance, but there are definitely these other qualifying, I think, factors that needs to be considered. The number of inspectors overall, we do not have adequate numbers. We will not be able to reach the entire country with the number that we currently have, 42. It is for that reason, we are then saying that decentralization would be very, very important for us, but not only to decentralize, to actually increase the inspectorate component within OHSC so that we then are able to expand. This would, in the beginning, obviously would have to spend funds to do so, but once we have inspectors that are located within regions or within provinces, it would be easier and much quicker for them to reach the facilities. And that will also shorten the inspection periods, because at the moment they have to travel from the central office in Pretoria and reach out to the entire country. The other questions, Honorable Tembekwayo, we will certainly furnish you with the inspection tool for the public sector and the private sector, the acute hospitals. I need to indicate that when we were developing these tools, one thing that we wanted to ascertain as an office is that this tool, both the public and private sector, do adhere to the standards such that even though they would inspect the various levels of care, public and private, but there should be no differentiation. The measures, the evidence that we would look at will be almost the same depending on the environment within which we will be operating. So we have actually taken a consideration of that, but we'll certainly do so. Perhaps it was the use of language that the 2021-22 report will be available in the near future, but let me also ascertain honorable members that the draft, we have the draft annual report, and we waited for the health establishment and we gave them the required period as it is stipulated in the regulations to interact with us with regard after we have provided them with the preliminary report. So this report will definitely be out and shared soon. The organogram, we do have a new organogram. Not only do we have that, the board and the management team worked on an OHSC, develop an OHSC business case. Now the business case outlines what needs to happen in the next 5 years for the OHSC. And when we developed the business case, we already had in mind the implementation of the National Health Insurance. We also had in mind our footprint in the private sector and also expanding in the public sector. Now, this business case then takes us through a framework and a path of what we need to do and what we are going to do given the necessary and required resources over the 5-year period. Yes, it is true that we currently, the 52,000 or so facilities, including general practitioners in the master facility list, and looking at what we have as our baseline, it's actually a far cry if you look at what we need to do. But we are confident that once we have decentralized, once we have the teams that will be able to do these inspections at the local level, it would be much easier for us to be able to expand and to accelerate our inspectorate work. At the moment, and once we have, the department agreed that they will give us full access to the 52,000 or so facilities, then we will definitely have a framework in terms of how we're going to reach these facilities at least once in 4 years. Honorable members would note that for 2022-2023, we have increased our targets really based on some efficiencies that we're able to realize internally after we also went back to the drawing board in terms of, what is that we can do in terms of realizing better efficiencies in our operations. But having said that, we do know that, and I don't want us to also commit to saying with the current budget and the funding structure, we'll be able to reach out to 52,000. That would not, it would not be correct for us to make that undertaking. But we do have the plans that will assist us to realize that once we have been supported and once we also start with our own revenue generation. At the moment, Honorable Chair, I'm going to pause here and I'm going to request my colleagues, Mr. Mapata, to deal with some of the questions that were raised around the budget and IT. And then I will also request Dr. Donna Jacobs, the Executive Manager of Complaints and Investigation in the Office of the Health Ombuds, to deal with the issues related to the late submission or responses of health establishments, the number of cases, and the nature, and also the complaints received in the public and private sector. Thereafter, Dr. Jacobs will be followed by Mr. Phiri, who will respond to some of the inspectorate questions around the Dorangiza strike of nurses, and also how it was dealt with. However, maybe just to make a general comment and say, most often we would hear maybe after an incident has happened, in that it would be reported to the office, or we will pick it up through our early warning system in the office. Then when that happens, we'll then interact with the facility. Where necessary, we'll go and conduct an inspection, or we'll then request a report. But we do react to these when they are received. So some of the inspectorate questions will be dealt with by Mr. Phiri, and I will also request Ms. Moleko to deal with some with one question, I think, around the interaction we have with the stakeholders around the tools. Thank you very much. My colleagues, probably in that order. Thank you.
Thank you, CEO. I will touch on the questions regarding the finances. There was a question from Honorable Ismail with regard to the 6 million allocation that was given to the OHSC. As indicated during the presentation, the amount was transferred to the OHSC at the end of the financial year with only 1 month left to close the financial year. So the amount could not be utilized in 1 month. What then since happened was that the amount was part of the surplus for which approval was requested from the National Treasury, and the National Treasury approved that request. And as we speak now, we have got about 26 temporary employees who are being funded from this amount and assisting also in the Inspectorate unit. So the amount currently is under use as approved by the National Treasury for retention. And there was also a question on the program 1 overspending by Honorable Ismail. In this, we've also noted that there's also a limitation in terms of the template that we use, because we use a template from the National Treasury. A portion of that over expenditure is actually funded from the surplus that was approved in 2021. So unfortunately, the template as it is does not allow for alteration to indicate how much was the original budget versus what expenditure was incurred in terms of the original budget and what the portion of the surplus was. So it gives the impression that there is an over expenditure, but that over expenditure is actually covered by the surplus that was received. As indicated by Honorable Munyai, we are also careful in terms of over expenditure. We manage and monitor that very closely. There was also a question with regard to the ICT maintenance. In terms of the equipment that we procure, the equipment, for example, in terms of the server infrastructure, will come with very stringent requirements in terms of maintenance. The service providers or the suppliers will require that this equipment be maintained to certain standards. And if that is not done, the warranty that is there on the equipment will automatically lapse, and we'll find ourselves in a situation where if this equipment breaks down, we cannot go take it back and claim new ones. So the equipment will come with the maintenance component, and that is the expenditure that will always show in the financials to ensure that the equipment is maintained to a certain level of requirement as per the prescripts of the original manufacturers, original suppliers. The issues around unfunded posts, the CEO has dealt with that. That we use currently surplus funding to fund the unfunded posts to boost capacity where it is generally required. In the letter that we received from the National Treasury recently in September, when they approved the retention of the surplus, in that letter they also indicated and said the OHSC is advised to be cautious around permanent appointments, noting that surplus funding is once off. So as the CEO has indicated, we only make short-term planning as a result of that without making long-term planning, as the National Treasury has also raised it in one of the letters. There were questions from Honorable Van Staden with regard to staffing and funding, which the CEO has responded to. We recently had an engagement with the National Treasury during August, where we also brought the issue of staffing and funding to their attention to indicate the shortfalls that we have currently as the OHSC, and also indicating the extent of the expectations on the amount of work that still needs to be done, and bringing to the attention that the current staffing and funding will be insufficient. So that was during August when we brought these matters to their attention. The issues around the organogram, I think the CEO has responded to that. There was a comment from Honorable Munyai with regard to under expenditure and over expenditure, and irregular expenditure, which we have noted. And we agree that the OHSC will always monitor that we don't incur any irregular expenditures. As indicated in the annual report, there was no irregular expenditure that was incurred, as audited also by the AG. And then there was also the question or comment raised by the Honorable Chair, Dr. Jacobs, with regard to the achievement of the targets. I think the CEO has responded to that in terms of long-term planning, the business case that we have, and for which we engage the National Treasury in terms of funding. So those are the questions with regard to finances that I had noted. Thank you, CEO.
Thank you, Mr. Mapata. Mr. Piri, then Dr. Jacobs and Ms. Modleko.
Thank you, CEO. Good morning, honorable members. I think most of the questions that relates to the inspections and Inspectorate CO has covered. I will directly then go to the question around Dorang Ginza. Ginza, as it is, it was on the news or on the media on the 18th of August. The Daily Maverick also reported some issues on the staffing, the upstats, the number of delays in terms of operations, and the time when it was reported, then the OHSC then sought information, wrote to the head of the institution to get information around the issues that were raised on the media. And I must say that at that time when we wrote to them, the CEO was off sick and had to ask for extension to gather the information to respond fully to the questions and bridges that OHSC has identified at a particular time. Their response only came back on the 26th of September, which we have now begun to engage. So when the strike erupts, it was the same issues that we are engaging the Dorang Ginza management and the province with. So we did not at that time then again write another letter because we are already dealing with the issues that has to the strike that was happening at that time. And I must say also then at this stage, remember that the Dorang Ginza as itself did not have a CEO for quite a long time. It's operating with an acting CEO as we speak. And some of these challenges then speaks to that. But having said that, also in our analysis, we have not fully finished engaging with Dorang Ginza's response as an office. But when you look at Dorang Ginza and where it's situated and how the district operates, Dorang Ginza is providing, for instance, maternity care around. And Mandela is the only one. When you go to the provincial PE, there's no maternity. When you go to Livingston, there's no maternity. So all the maternity cases are actually referred to Dorang Ginza. It's a 33-bedded or 30-bedded institution, but it takes an amount of up to 70 cases where you will find that the patients are actually lying on the corridors. But the challenge of it is where do they then turn these patients to? They cannot send them back home and to go and deliver there. So the maternity cases and the scissors, then they find themselves then flooded in the maternity unit. The way then the system operates at this current moment. But I must say that we are having our hands on the pulse. We know what is happening at that. We are engaging Dorang Ginza at this moment to try to iron out the challenges that they are facing. We have also involved the provincial government to also try to assist the health establishment, sort out the challenges that are also then happening in Dorang Ginza. So we're looking at it at the global and trying to bring all the stakeholders to try to assist the situation as it is in Dorang Ginza. Probably when we come back then to the committee later on, then we can then provide a full report as to then what was the resolutions post our whole engagement with the Dorang Ginza, plus also then the surrounding health establishment that fits into Dorang Ginza. I think that's that with Dorang Ginza CEO. Thank you.
Thank you, Mr. Piri. Dr. Jacobs, then Ms. Muliko.
Thank you very much, CEO, and good morning to the honorable members and to my colleagues. I would like to address some of the questions that were posed. And some questions I have grouped together, given that several honourable members did ask more or less the same question. The first is about the non-responsiveness of health establishments or provinces to our requests for information. I would like to state that over the previous year, this has improved considerably as opposed to 2 or 3 years ago. So the situation has improved and we are getting more timely responses to our queries. One of the things that we actually did quite intensively to try to improve this was to engage with the provinces intensively. We communicated with them and ensured that we kept up that communication. We also implemented procedural regulations 6 and 7, asking for a contact person or a person in charge with whom the Office of the Ombudsman could then communicate directly. And this has actually helped us immensely in terms of improving the response time, but also escalating responses for which we have answers that do not meet the needs. We have also engaged as the Office of the Ombudsman in a series of provincial visits where we actually engage with the HODs and the MECs of the respective provinces. We discuss some of the successes that we have had within the provinces, but also some of the challenges. And these have actually proven quite beneficial in hastening the responses to our requests. It is quite easy to answer a letter of a person that you know rather than a person whom you do not know. Having said that, we do still have challenges in some provinces. For instance, we do have a high-profile case that some members are aware of, where it has taken us nearly 3 months to get an appointment to interview a hospital CEO. And this, of course, then delays the resolution of some of our cases. So I think it is an ongoing dialogue, both between ourselves as well as with colleagues in the provinces. It has improved, as I stated earlier, and it will continue to improve. I would like to state that that question was asked by Honourable Ismail, Honourable Clark, Honourable Geller, and Honourable Thembekwayo. Moving on to the next question, which was raised about the backlog in cases, and this question was raised by Honourable Clark, Honourable Thembekwayo, Honourable Klengwa. In terms of the backlog cases, I want to provide a context to this. 2 years ago, the Office of the Ombudsman had a total of 323 backlog cases. 112 of those were medium risk cases and 185 of those were high or extremely high risk cases. Over the last year, we have resolved all 112 medium risk cases, and we have also resolved at least 20 high risk cases and are left with 161 backlog cases, all of which are either high risk or extreme risk complaints. To address these, we have developed a project plan that we have actually disseminated among our 3 investigators. We have to be in compliance with the relevant legislation while resolving high and extreme risk complaints. Therefore, some of our complaints require a lengthy period of time to resolve, as we have to interview between 50 and 70 complainants or interview staff or various witnesses in order for us to reach resolution. We also have to make sure, particularly for our high and extreme risk complaints, that all of our findings will stand up in court. All complainants, if they're unsatisfied with the findings of the Ombudsman, have the right to request an appeal through the Minister of Health, and an appeals tribunal is then constituted. Therefore, our report, our findings, and all of our witness statements must be able to stand up in court. So that is really the reason for the delay, I would say, in resolving some of these complaints. I think also while I'm talking about the backlog cases, Honorable Flengwa had raised the issue about the response to complainants. Honorable Flengwa, my team, Ms. Ndou, my Director for Complaints Assessment Unit, is online, and she is checking for us the status of that request. And it appears that we only had one email address of the primary complainant, which was K. Sitole. So that is the person to whom the team has responded to. If there is an alternate email address, or if there is an alternate person that must be communicated with, please let us know via the Secretariat, and we will certainly be able to provide a response to yourself. Let me move on to the third issue, which is the number of complaints received over the fiscal year. I think this comes from Honorable Van Staden. So we had 3,317 complaints over a 12-month period from both public and private sector facilities, or complainants who had used these facilities. I think that would be it. I just want to check that I have addressed all of the questions that were raised. Yes, I think that we have raised that. Honorable Thembekwayo had asked specifically if we have received any complaints related to Doranginza, and my team has checked. We have not received any formal complaints via our call center. Thank you, CEO. That will be it from me.
Thank you, Dr. Jacobs. I think Ms. Moliko is next. Thank you.
Thanks, Dr. Mdaweni, and thanks to the Portfolio Health Committee members and the board of the OHSC. Just to address the question that was asked by Honorable Wilson and Honorable Flengwa, the two questions, they speak to each other, where they were asking about what are the root causes of health establishment not complying. I must indicate that in terms of the health establishment not complying, we can only indicate the gaps that we found, and I will also be able to mention that most of the health establishment that we have inspected are the clinics. And the area where the clinics are not performing is the area of the clinic manager, where the inspectors go to the clinic manager service area and look at all the documents that are related to the running of the clinic. And in most instances, you will find that the clinics, they don't have dedicated operational managers or facility managers. People do rotate. And where those facility managers or operational managers are in place, they are also expected to be providing the services. And the areas of non-compliance, the common areas of non-compliance that we have identified as the office is where we are asking about service level agreements. Most of the services are currently outsourced. For example, security services, waste management services. And in most instances, we ask about the service level agreement to ensure that the services that they have been contracted are able to be provided accordingly and according to the requirements in the service level agreement. But unfortunately, in most instances, you'll find that the service level agreement don't exist. Where it exists at times, the very same activities that the service provider are supposed to be providing, they are not monitored. And also in terms of the SOPs, the SOPs are important. The standard operating procedures are important when it comes to management of patients. And in most instances, you'll find that those standard operating procedures are not in place, or even the guidelines. So these are the areas that at times you'll find that the patients were managed, but they were not managed according to standard operating procedures or guidelines, or where in other instances you'll find that they didn't even receive the care according to those guidelines. And other areas are in the emergency trolley, where you'll find that we are asking for equipment that are supposed to be in the emergency trolley. And you will find that in most instances, the emergency trolleys are not stocked according to the list that is there to guide the health establishment. And the other area is where you'll find that even in the health establishment, there are no oxygen cylinders. In other instances, they are there, but the oxygen gauge does not meet the minimum requirements levels. So these are some of the areas that we will always, and they are very common. And these are the areas that will also contribute to the health establishment not meeting the requirements for certification, because there are some of the requirements that are non-negotiable, and they must be addressed to ensure that patients are not, compromised in terms of the quality care that they deserve when they access these services. I will stop here, Dr. Mdaweni. Thank you very much.
Thank you very much, Memoleko. Honorable Chair, I believe we have covered the questions that were posed, unless if there's more that honorable members would like to inquire from us. Thank you.
Thank you. There's a hand raised of Honorable van Staden.
Chairperson, thank you. Now, I'm struggling. I don't think my question was answered regarding the current status of hospital safety audits in all 9 of the provinces. If we can just get the answer on that question as well, please. Thank you very much.
Thank you, Honorable van Staden. Our apologies on that question. Now, there's a difference between the audits that are conducted, or shall I call them the ideal clinic audits that are conducted by the National Department of Health, and what we then go and inspect in hospitals. We've finalized the hospital, the regional, district and central hospital tools. So we have started with those audits, but those are not the same. Ours are based on the regulations. Now, the question I think was whether those are within the 189 or some of those were around the 189 certified health establishment in 2021-2022. We can provide the list of all those that were certified. It is actually on our website, but we can provide you the specific names of those that were certified in 2022, so that you can look at those. I don't know if you are covered, Honorable van Staden.
Thank you very much.
Thank you.
Thank you very much. Dr. Kenochi, Chair of the Board, the CEO, Dr. Mdaweni, the CFO, Mr. Julius Pata, and all of the rest of your team, thank you very much for your contributions this morning. I was about to close and I saw the hand of Honorable Sengwa. Honorable Sengwa, is that a new hand?
Thank you very much, Chairperson. It was just to have a phone number for the lady I'm going to contact with, so that I can give him these emails, the second one emails. Thank you.
There's also the hand of Honorable Munyai.
Honorable Chair, I just want to make a joke. I thought in your profile there's a D. Jacobs who's speaking at the background. I said, hey, we are
not my wife, not a family member.
I'm just joking.
Yes, thank you. So, honorable members and OHSC and everyone else, we've come to the end of this meeting. Remember, our next one starts at 12 o'clock. I think you need to keep an eye on the WhatsApp group in case there's anything that changes, but we wouldn't think it will change. I would suggest we don't switch off our devices and that we all meet back again. Have some tea and relax. We talk again later. Thanks. Meeting is adjourned.
Recording stopped.
Are all of the members present?
We are
Honorable
here
Chair.
for-
Present, Chair.
We are here for Prof. Glenda Gray.
Thank you very much. Professor Glenda Gray.
I'm
Very
here.
well.
For my laptop, I need to be let in, and so I'm on my cell phone. So there's a request from INSERM, which is our sister organization in France, and I'm with them at the moment, and so they just need to let me in, so I can use my laptop. Otherwise, I can just carry on with my cell phone.
No, we will have the portfolio committee secretary let you in.
It's the INSERM one.
Say that
It
again.
looks like so I'm waiting to be let in on my laptop.
Yeah,
But it
what's the
won't be
name
under
of
me.
that device?
INSERM. It's INSERM. INSERM. ANRS.
It's not in the waiting room, Prof. It's not in the waiting room.
It's not in the waiting room. Okay, because it's on my laptop. It says I'm in the waiting room, but it's okay. It's fine. We can start.
Oh, so hang on quickly, Prof. Glenda Gray. Let's go a little bit slowly. You want your laptop, and your laptop is what named?
Yeah. So I was using another laptop, but what I'll do is I'll try and get my laptops connected, so you can recognize me. But we can start so long, and then once I get recognized, then I'll switch to my laptop. So my team has got the presentation, and Mongezi will show it. But first of all, I wanted to just also share. Okay, so we can just start showing our presentation. Then I would like to introduce you to the team that's on, including members of our board.
Prof. Gray, can I just ask, Honorable Chair, can we please ask the host to give us access to share the document? Currently, it's disabled. We cannot share anything.
All right. So would you want the, because I see Glenda Gray is the co-host, so they've made, okay. We need to make somebody else a co-host too. Is that what you're saying, Mongezi?
No, I think it's Lindo Kuhle who's the host. So the person by Lindo Kuhle should be enabling a sharing of the screen. We are unable to share
I'm
this.
asking who you are now a co-host, yes. Let us, so you're now a co-host. You can share your screen, but I will have the prof introduce the team first, and then we go to the presentation. Thank you.
Thank you very much. So first of all, I'd like to introduce our board members that are on, and I'm going to start. I'm going to just see who's on at the moment. We've got June Williams, who was a previous AG, who's on here. I'm just going down the list. So June, I don't know if you want to show your picture, your photograph. We've got Dr. Tim Tucker, that's also on. We've got Professor William Ray, if you just show your picture. I'm just looking through, is Eunice on? I can't see Eunice on the list. Is Eunice, are you on?
Yeah,
I'm
sorry,
unable to
I'm on. I'm
Okay.
on.
Okay, Eunice. And is Colette on? If Colette can show his face, and Emmanuel, are you on? If you can show your face. So we just want to acknowledge our board. Chair, our board are very important people. They support us in our audit and risk, in our human resource board, and our R&D, and it's generally, we just want to acknowledge them. They are some of them will have finished their terms, and some of them will be returning in the new board that's about to come. So I'm going to just so we've got the slides up.
think Glenda is frozen. Oh, it's still on. What is the wrong?
And ask if she's speaking.
Let's check internet.
This one. Internet is fine.
Yeah, but don't let it stop you.
Yeah, no one is talking. Can you call or text him?
Are we making progress?
Is it short?
Chair, I'm not quite sure whether Prof. Gray is frozen. Can you hear us?
Prof. Glenda Gray, can you hear us? Is there anyone else who can do this, start with this presentation so long? Honorable Muthe?
Yes, I can do that, Honorable Chair.
Yes, please. We're on very tight timelines for these few days. So if you don't mind.
Okay, thank you.
Professor Gray must sort out with Ms. Majalamba on the sidelines using the telephone to sort out the other issues so that we can continue, please. So please continue.
Okay, Chair, we'll do that now. Can you see our screen, Chair?
Yes, we can. Please.
Okay, thank you very much. Thank you very much, Chair, and thanks to the Portfolio Committee for this opportunity to present our 2021 annual report. So, as Prof. Gray has already introduced the board members, which term is coming to an end now on the 31st of October 2022. I have to apologize on behalf of the board chair that he couldn't make it, and some of also the executive committee members couldn't make it to this meeting. So Chair, just to give you a brief background about the MRC, MRC has got 5 programs, starting with administration and doing the conducting of research, thirdly, innovation, and then building capacity of new leaders, which is development. And then lastly, we look at the research translation, making sure that the evidence is translated into policy and practice. So just to indicate that we are an organization of about 600 employees. We roughly, our budget is around 1.2 billion rands. This is including both baseline and contract. And we've over the past year have given about 167 career awards. And then we've also in our performance, you'll see later on that we had some around about 60 innovation projects in the last financial year. So Chair, we are happy and we are pleased to get a gratitude and a message of support for all our staff from the Minister, the Honorable Minister, thanking us or congratulating us, the MRC as well as the board, on the achievement of the clean audit. So many clean audits over the past couple of years, Chair. So briefly to take you through our human resources, as I said, we are about an organization of about 600 employees. So what we've done here is to give you a 3-year profile of the organization where we moved around. We've been steady in terms of employing about 70% of our workforce is Africans and 17 coloreds, 9% Indian and white. This was in 2019.
Chair.
Yes, Matlengwa.
The screen is not moving. Don't see what he's talking about, where he read. The screen is not moving.
You're correct. The screen isn't moving, Mongezi. It's just
Okay,
frozen on the first page.
I'll share it again. Apologies for that.
Before I do that, Honorable Munyai, I see your hand still raised. Do you want to say something?
No, all I was saying that the better we sort out the computer of the prof, it will be helpful, because you know how she moves with this thing, with passion, you know, so we miss that. Thank you.
So Mongezi, it's still frozen. I could maybe Angela I think it's because we're using that boardroom. Angela, maybe if Mongezi can stop sharing and Angela can rather share.
Is it moving now?
No, Angela, just stop sharing Mongezi and let's get Angela to share.
It says host disabled, so I would need to get access.
I think you should have sorted this out a little bit earlier.
There we are. We've got it. We're on.
Is it moving now?
Yes, you now need to make up 15 minutes.
Yeah, but Mongezi, it's not showing in the right format. Okay. Okay, I think keep going. It's not showing in the right format. It's in a strange format, but I think just keep going.
Chairperson.
Yeah. Yes.
Is it? I know we have a tight program. I was just asking if we can allow them at least 3-4 minutes to sort out the logistic.
Yes, Honorable Munya, I've given them 15 minutes. They must sort it out now. They have another 3 minutes.
No problem. I'm sure they'll sort it out now. Yeah. I think they have to get the computers for Prof to.
Yeah. So if someone can disable, I can. If someone can give me give me access, I can use my computer. Mongezi, I can. If you just give me, I can share my my one.
It's moving from our side, and I think
that's not moving from our side.
I don't know. Chair, can you see?
Okay, there. But it's not in the right format, Mongezi.
Okay, can we?
Okay, let's keep going. Let's just keep going. Just keep going. Mongezi.
Which format can you see it now?
It's got the next slide. It's got the slide.
Okay.
That's fine. We can work from that.
Okay.
Okay, that's fine. Just go into presentation mode now.
It is on presentation mode.
Okay, go down.
It is not moving.
It's not moving.
Professor Gray.
Yeah, I'm going to.
I suggest.
Can you see my slides? Can you? Yeah. Yeah. Can you see?
Can you go on slideshow now? And let's see if it can move.
Okay. I'm going to put mine on slideshow. Can you see this, Chair?
Yes, we can.
Yes. Okay. I'll start. Okay. So I will drive the presentation. So just thank you very much.
Just before you go, I'll suggest that some of those you can go through quite fast.
Okay.
the initial one so we can get to some of the most important issues. Thank you.
So thank you, Honourable Chair and Honourable members of the Parliamentary Committee. We're very excited to present our annual report to you. Dr. Mongezi already showed you some of the slides. This is our board members. Some of them are exiting, some of them will remain, and some of them will get new ones. So we just want to acknowledge the work of the board and thank them very much. You've heard this already about what we do. I think you're familiar that we both conduct research and fund it, and we spend a lot of time developing research capacity as well. We're excited that our minister sent us a letter congratulating the MRC on another clean audit. So we want to acknowledge the NDOH and our minister for thanking us, and we appreciate working for the NDOH. In terms of the human resources, yeah, you can see from 2019 to 2021 that we've looked at our demographics, and we feel that our appointments by race in 2021 and 2022 reflect the composition of our country, and we will continue to endeavour to work on this. We are an organisation that has a lot of women, and we also will continue to endeavour to have more equity by race, by sex in our organisation. If you have a look at senior management by race, you can see as compared to 2019, this financial year, we're starting to look more representative, and we have at this level we have more gender equity. But we're very happy to look at our executive management committee. This is the EMC, and you can see that as compared to 2019, in 2021, this financial year, our transformation at the executive level is evident. And again, also that females represent and are highly represented on the executive management committee. We are committed to transformation, and we have a whole lot of processes that include working towards both in the intramural and extramural domain the transformation agenda of medical science in South Africa, in addition to looking at our broad-based Black economic scorecard, economic empowerment scorecard, which we are working on as well. I'm going to move to finance, and I'm going to ask Philip to take us through the finance slides. Philip, are you there? Just tell me to move the slides.
Yes, Glenda, I'm here. Afternoon, honourable members. For the 2021-22 financial year, our total revenue increased with around about 8% from 1.1 billion to 1.2 billion. Our operating expenditure increased by 16% from 1.128 million to 1.306 million. And you'll also see our investment income also showed an increase of 31%. That's due to the increase in our cash and cash equivalent, as well as the increase in interest rates. The net effect for the year is a surplus of 6 million versus a surplus of 79 million in the prior year. Next slide. Now, this is just a summary of our total increase in revenue of about 8% to 1.3 million. The baseline decreased by 0.43% to 740 million. Contract income increased by 24% to 528 million. And this big increase is due to the 58 million donation value of COVID-19 vaccines that we had to recognize in our financial statements. If you exclude that, then our contract revenue would have increased by 10% to 470 million. Then it's just the increase in the rental income, the investment income, and then for the financial year, we booked new contracts to the value of about 650 million rand. On the expenditure side, it increased by 16% to 1.3 billion. And the contributors there is the collaborative research increased by 3%. Travel costs, that also includes activities at the clinical research site, so like participant incentives, that showed an increase, as well as the appointment of contract staff and temporary staff. Lab cost increased by 192%. That is due to the inclusion of the vaccine donation that we received of 58 million. And then staff cost also increased by 13% to 436 million. Consulting cost increased infrastructure, as well as our audit fees. The audit fees is more of a timing issue when we received the invoices from the Auditor General. Next slide, Glenda. Thank you. This is just the revenue growth. As you can see, the top line, the blue line, that is our baseline. And from 2021 to 2021-22, it seems to me it's sort of flattening out. And over that period, our contract actually showed an increase, and as already explained, that is partly due to the vaccine donation we received. And the bottom line is the other income. Next slide, Glenda. And this is just the actual revenue and expenditure over the past 8 years. You can see it actually track each other. And now March 2022, it's almost, the expenditure almost touched our revenue. Therefore, we've got a surplus of 6 million. Next slide. This is just a bar graph of our baseline over the past 8 years. And as already indicated, seems to me now is sort of a flat line going forward over the MTEF, that there's not going to be substantial increases. So for the next year, 2023, there's only an increase of about 2% on our baseline revenue. That will make it quite difficult to initiate new activities within the organization. Thank you, Glenda.
So thank you. And Mongezi, do you want to take us through our performance management?
Yes, thanks, Prof. So quickly, just to indicate, as we've shown earlier on, that we received a clean audit, and the issue around the spending money, that we spend more money on research than administration. So we were able to achieve or exceed the targets for most of our indicators, save for the next indicator in the next slide, which is the indicator on goal 4. However, we are doing some SWOT analysis. This is the indicator about the awards to MSc, PhD postdocs in the HDIs. There you will see that the target was 70, but our performance only came out at 52. We're already working on this with the board. The board asked us to do some work in order to achieve that goal. So honorable members, I'm happy to indicate that we achieved all our indicators save for this indicator, but we are already working on it. Thank you very much. Glenda, you can proceed.
Just to say, in terms of our SWOT analysis on the HDIs, we see a lot of movement of staff, very poor laboratory infrastructure and research infrastructure, and also when once people do qualify, they move on. And so I think we're going to have to do a whole, and also because they're not research intensive, there's very little medical research going on. So we're going to have to work very hard with these campuses. We've already developed a laboratory infrastructure at the University of Zululand for malaria control, and we will be working with University of Zululand to increase their research intensity. So I think that's important. And also just to say that in terms of translating our knowledge into practices, the MRC, we should be very proud of the ability to influence both international and current guidelines, the reports that we do, as well as our representation both on national and international bodies, and the fact that the MRC funds scientific conferences, seminars, and make sure that we get our knowledge out there. In terms of our funding priorities, we are committed to a whole range of programs, and we want to also acknowledge the role that Department of Science and Innovation has in helping us fund all this work at the university level. This is the SHIP program, which is funded by the DSI, and you can see that we work in both HIV, TB, non-communicable diseases, maternal and child health, antimicrobial resistance, malaria, and COVID-19. We are committed to eradicating malaria in our country, and the NDOH has just given us a big grant to investigate the seepage of malaria from Mozambique into South Africa, and we'll be working with the University of Zululand to do this. So very excited to work with us. We're interested in both treatment, diagnosis, prevention, digital health, and precision medicine. And these are our major programs and our major work that we do. Also want to just acknowledge TIA, where we work with medical and devices, indigenous knowledge system, and plant-based medicines and new medical devices. This is a very interesting area of work. Also want to acknowledge the COVID work that we do, our wastewater surveillance, our clinical studies, our diagnostics, our basic science, the community engagement we've done, and very exciting is our collaboration for the mRNA vaccine hub. We will take this vaccine into clinical development early next year, and we're working with Afrigen and Co and BioVac to do this. These are other people that we work with from India to China to the United States to BRICS and to EDCTP. So we're very proud of our global collaboration. In terms of our technology, we're very interested in making sure that we commercialize our products and to make sure that the work that we invest is localized and is commercialized in South Africa. In terms of capacity development, as I've mentioned before, we have the Bongani Mayosi National Health Scholarship Program, the Clinician Researcher Program, the Intern Scholarship Program, a specialized training in vaccinology, given our huge investment in vaccine research in South Africa, and the Researcher Development Program. This shows you that we continue to award women, female scholars, as well as Black African scholars in South Africa. And this just shows you the awards that we've made. We're committed to developing clinician scientists and have this goal of having 1,000 clinician scientists in a period of 10 years. And so this is our progress towards this. If we look at our research at a glance, we look at all areas of these colliding pandemics. We focus on everything from health promotion and disease prevention, 10 units to maternal and child health and women's health, non-communicable diseases, health system strengthening, public health innovation, and biomedical research. You can see we have a big focus to support the NDOH's research strategy. This just shows you the spread that we have both in the intramural domain and in the extramural domain at universities. We're very grateful for our burden of disease that reports weekly on excess deaths in our country and was able to guide and understand the factors. And even at a municipal level, we can see some volatility at times. For instance, if there's an under 5 mortality increases in a certain hospital or in a certain region in our country, we are able to notify the Department of Health on this. Important to know that prior to COVID, our life expectancy was getting better. Women live longer than men in our country. But very important to note is that our under 5 and infant mortality rate is improving, and we still need to work on our neonatal mortality rate, which is deaths of infants less than 28 days of life. We seem to be static since for the last 5 years. So I think that's an important area that we need to work on. In terms of our highlights, I think our wastewater is one of our highlights. We've been able to establish wastewater in 80 treatment plants across the country. We strive to promote transformation. 75% of our trainees are Black Africans and 50% are female. And we are able to fund honors, masters, and doctoral students at partner universities, including HDIs. And this is just an example of the work that we do. We saw a volatility in the Western Cape last week. Today, this afternoon, we have our wastewater surveillance look at this week, and we'll be able to give an indication about whether these levels are going up. And we have alerted the public, and so we do encourage people to take care, get vaccinated, and keep watching the wastewater surveillance. We're very excited again also about our ability to work in the mRNA hub. We work very closely, as I've mentioned, with BioVac and Afrigen, and the mRNA vaccine for SARS-CoV-2 has been made. It's been tested in animals, small animals, and as I've mentioned before, we've been working with SAPRA and hope to bring the first human vaccine trial with our own Afrigen South African mRNA SARS-CoV-2 vaccine in May this year. Also, we have a collaboration with the Patrick Soon-Shiong Foundation. We know that we can become a pharmaceutical and vaccine rich country, and we need to make sure that we build the manufacturing environment in our country with laboratory scientists, process engineering, and quality assurance. And so we have 100 million rand to start training South Africans to be able to do vaccine manufacture. Our network for genomic surveillance, again, is in collaboration with the National Health Laboratory Service, is also an important spoke to understand the evolution of the virus in our country. And this group has been able to identify Omicron, Beta, and helps us understand what new viruses are emerging and where there is volatility in terms of in the emergence of variants in our country. Also have made lots of important publications, which I won't go through, but just to show that we are making impact, and the work that we do does end up changing international guidelines and practice. I'm going to just mention our 4 new extramural research units. I'm sure you recognize Ntobeko, Refiwe, Colette, and Pascal, and these are our new extramural research units, and we announced them at a launch earlier this year, looking at the intersection of non-communicable diseases and infectious diseases, looking at pharmacogenomics and research research and translation unit, looking at antimicrobial resistance and global health research unit, and a Pan-African Center for Epidemic Research unit. So we're very proud of this. This is the kind of work we do in our universities, in our research units, and are doing everything from antibody immunity. And this antibody immunity project helped us uncode the Moderna vaccine, so we could make our own mRNA. Committed to indigenous knowledge systems with herbal drugs, wound and keloid scarring with Nonhlanhla Khumalo, and stem cell research and therapy, as well as rural public health, a resilience in mental disorders, and HIV and TB. So we're very committed to making sure that we do the breadth of the research that's needed in our country. We've been able to transform our extramural units. When I started at the MRC, we had very few extramural units, and most of them were at universities that were more Ivy League. Today we have more women leading extramural units, and we've been able to spread the depth and the breadth of our extramural research units across the country, even in rural provinces. We just need to acknowledge Prof. Pazwana Mafuya, who's became the Queen of Research in Ghana, given her collaboration at a African continental level. She was made the Queen of Research in Ghana at a ceremony in Ghana just a few weeks ago. We do a lot of stakeholder engagement, from environmental impact to raising awareness around chronic diseases, to investing in TB to save lives. Have stakeholder engagements with the European Union, from the Kenya Research Institute, and just recently with the US Secretary of State. We were able to host them together with Minister Pandor at our offices in Pretoria. We're also committed to environmental impact evaluation, and this is Jagersfontein. And the NDOH, after Jagersfontein, the NDOH asked us to do an environmental assessment to look at the soil from the mud, to make sure that there were no arsenic or lead or any other toxins. And we got the results yesterday. So I'm going to ask Angie Mati just to mention the findings from the environmental assessment you've done. So Angie, if you want to say a few words here.
Yes, we did. We got results, as Glenda said, late yesterday afternoon. And what we found is that in the soil, there is evidence of arsenic and cadmium contamination, and in the water of lead contamination. But we feel it needs further attention, because we found those elevated levels in areas that were affected by the flood of sludge, as well as areas that were unexposed. So there's definitely a lot more thought and a lot of research that's needed to understand why there are these elevated levels of toxic metals. And we'll be communicating the results to the Free State authorities by the end of the day or tomorrow.
So thank you very much, Chair. And we apologize for the staccato start. And we want to just thank everybody, and we're willing and happy to take questions.
Thank you very much for the presentation and having made up some time. We're just going to have a look at so far. Let me see one member having raised their hand. Honorable Ismail. Can I get other hands? Honorable Munyai. Any other members? Ismail, Munyai, Clark. Ismail, Munyai, Clark. Honorable members, I've made this request a few times that you switch on your videos when you ask questions. There is going to have to be a time when I would have to enforce that rule. If you're not ready today to do so, please prepare yourselves for the other meetings, that the public is able to see you when you do ask questions. I think that's one of the rules that I laid out in the preamble to this meeting.
Now, Doctor, there's a load shedding in Gauteng where I am, and my network will be very terrible. I'll try in the next presentation or before we end, just to make sure that as I comply with your rules, Chairperson.
Thank you, but may I complete? I am saying to all of the honorable members, I made the same request yesterday, I made it this morning, I'm going to make it now, but from tomorrow I would have to then enforce it. So for today, yes, thank you. Those with load shedding do make those indications, but we should, if we expect our presenters to switch their videos on and for me to have my video on, we should be dealt equally. Same hand to everybody. So in the future, those are the only three for now, and myself, Professor Glenn Gray. I will allow the questions to be asked in the following order: Ismail, Munyai, Clark. Thank you.
Good afternoon, Chair. Good afternoon to the SAMRC. Thank you so much, Chair. And my apologies is Honorable Munyai stated we've got major load shedding and power failures in this part of the world.
Yes,
We will definitely.
Ismail, also for yourself, you always have this picture up. So we're going to allow you this picture today, but from here onwards, we need to show our faces as we speak. Thank you.
Thank you, Chair. I was just going to finish off to say that in future, we will definitely try and make sure that we are visible with our videos on. Thank you, Chair, for your, consideration. So to the SAMRC, thank you very much for your presentation. We note and congratulate, your achievement on an unqualified audit. But without wanting to take anything away from your good work, I see your report states an overachievement of the performance targets. Will you as SAMRC consider actually increasing your targets going forward? Since you're doing such a fantastic job, maybe much more can actually be achieved. My second question, I'm really trying to understand the dispute with the South African Revenue Services. Can you maybe explain this whole dispute issue with regard to the amount of value-added tax that is, with SARS, so that we can have a better understanding of it from where we are? Thirdly, what resulted to the legal fees incurred against, the National Education Health and Allied Workers Union? Are these actually related to any labor disputes? Maybe we could have some sort of understanding there. Now, with regard to the students that you referred to in your presentation, which we obviously are very proud of. So once they are graduated, just enlighten me, will they be incorporated into the field? I ask this as I'm just concerned about the amount of interns and comm service doctors that have to actually wait for some time, even longer periods of time before they're actually allowed to do the internship in comm service at our public hospitals. Does the same apply to these students? And, if yes, what's the waiting period? Or are they just incorporated as soon as they are, they finish their studies, if I can put it that way? Also, I would like to know, please, can you give us more information on the POX, Protein Public-Private Partnership for HIV vaccines, which commenced in 2016? And maybe at the same point, just tell us how far the HIV vaccine is. I think sometime back, I asked a question and the response from, if I'm not mistaken, the SAMRC and SAPRA was that the HIV vaccine is actually in the pipeline and should be, finished off or be prepared very soon. And also on HIV, maybe you could give us some research findings with regard to HIV and AIDS, TB, gender-based violence and femicide. Thank you, Chair.
Honorable Munyai.
I show my face, Honorable Chair.
Thank you very much.
I had to comply.
Thank you.
First and foremost, I rise, Honorable Chair, to congratulate the already congratulated organization, SAMRC, by our Minister of Health. So I'm sure they're worth endless congratulatory remarks from ourselves. This is the only organization that hasn't dropped the ball, and we pride ourselves with this organization. And it's an organization that build new generation of scientists, and they empower even the less privileges. You could see the demographics that the highest number is African in that organization, followed by colored and so on, and the white are little numbers. So, but I'm saying that we want you to retain, including those whites that are really doing pretty well, please. It should be not in the name of transformation alone, but I'm saying that we need to retain their skill capabilities. And I think you have demonstrated your ability as a great leader and the president of this organization. And I'm sure you are the symbol or the epitome of our country in the areas of science and development and innovation. So therefore, for me, Honorable Chairperson, esteemed Honorable Chairperson, we need really to make it our best that this organization get a lot of money, locally and everywhere where they can get resources, because what they do is quite developmental and to our country and to our people. And it's just a broad scientific area. It's not only focused on one areas of research. And there's no organization that really, could be compared here in the country to SAMRC. So therefore, President, you are doing quite well. And we really hope that the department, they must continue to retain you to serve the country in the manner that you do. I just missed one section of your presentation. The rest, I got it, and I'm very impressed. I just saw missed the one area where I saw the people graduating with UCT there. What qualification did they graduate on? And maybe I must also go to school and get through this one and my Josie scholarship. Thank you very much. It's fantastic. It's also excitement to wait to listen to you and your collective. And by the way, out of the focus, pretty soon we'll be dealing with the tobacco bill and the research that you've been sharing with us. We think it will be capacity for the members of parliament going forward. Thank you very much indeed.
Thank you, Chairperson. I've actually put my video on, but it's not showing, so I'm not sure why it's not showing. Because I wanted the chair to see that I'm not in my pajamas and that my hair is done, my makeup's done, and because I think that's what he might be.
Yes, that's exactly what we want to see. We want to see if people are doing the work. Thank you.
Just to say that thank you very much to SAMRC for what they do. And congratulations on your clean audit. We are very privileged to have a group of people in this organization that do the outstanding work you do. So we thank you for your contribution towards society. Just a few questions. The wastewater surveillance and research program that has been conducted in many provinces. Could you just clarify which provinces this is conducted in and how successful have they been? I am aware of it being conducted in the Western Cape and it was very successful there, but if you could just share the rest of the provinces with us. Then in terms of the contributing to HIV prevention by enrolling it into the project into Verulam Clinic Research Site in KwaZulu-Natal, and this is the first site in South Africa. Are there any movement to make sure that this project is rolled out in different sites within our country and within different provinces in terms of the outcomes of this clinical trial? Then if you could just tell me why there was such a huge difference in terms of surplus recorded. In March 2021, there was 79.2 million rand recorded as a surplus, where in March 2022, 6 million was recorded. And if I could just get clarity on why there's a huge discrepancy between these two financial years. And then what caused the lab costs to increase by 192%, consultancy costs by 142%, and audit costs by 127%? Then what are SAMRC's targets regarding percentage of population that need to be COVID vaccinated? And could that be reasonably expected to be achieved? And then during the lockdowns, focus shifted towards COVID and away from HIV and TB programs. Has SAMRC done any studies regarding the impact of this, as well as how we're going to be addressing this? What is the SAMRC focus in terms of malaria diagnosis and prevention? And what research is the SAMRC doing regarding mental health in South Africa? Thank you, Chairperson.
Thank you very much. Any other members?
Yes, please, if I may, Chair.
Yes, I was going to mention that you're struggling with connectivity, but you're here. Thank you, Honourables.
Thank you, Chair. I just want to turn down the other device, otherwise we're going to have an echo. Thank you. I think Principal and to Glenda and your team, always a job well done, and always an absolute pleasure to be dealing with you as an organization. I think you do some amazing work, and it's obviously greatly appreciated, and it does put us high up on the health stage internationally, and I think that's very important for us. And I think principally all my questions have been covered, but there's something I would like to ask you and ask if any analysis has been done on this. The country is the poorest that it has ever been, with people unable to get work, unable to survive on grants, the cost of living having shot through the ceiling as a result of the Ukraine war, amongst other things. Now, cancer, HIV, AIDS, diabetes, all of these kind of things are very, very much connected to diet. And right now, people are not getting proper diets. They are lucky if they're getting one meal a day. We are seeing more and more stunting as far as children is concerned. And I have a huge concern that the current situation with the cost of living, what the cost of living in South Africa is doing to the overall health of us as a nation, and particularly talking about diabetes, HIV, AIDS, and cancer, where diet is probably the most primary concern, and getting adequate nutrition, getting adequate vitamins, minerals, whatever it is that particularly those people in that sphere require. If there's any research being done on this, because I think it is becoming a very big problem very quickly in South Africa, and I would love to get a response on that. Thank you. Thanks, Prof.
I think we've lost him. We've lost the chair.
Sorry, I think I was muted. Can you hear me now?
Yes.
Muted, Chair. We can hear you now.
So I said congratulations on your clean audit, and also noting that you are spending more of your funds on research than on administration, which is always good. And in terms of your reporting, you've reported on the studies which you promote and fund in terms of research in South Africa. So the question that I would want to ask is, how do you decide on which research you would want to do? And we would understand that those could be requests, it could be decisions taken by yourselves as a board, it could be the prevalent conditions at any particular time, it could be because of the funders, because of the programs which they fund, etc. Because obviously, I would think that you would always do the research that, for example, the wastewater project to determine whether we still have COVID particles in the wastewater, the one that was done in the Western Cape, that you would always be informed by the conditions on the ground and the challenges at any particular time. It'd be good to hear and get an explanation from yourselves how you do that. Considering your sourcing and managing streams of funding, for example, for research projects, and obviously that would have the direct effect on those people who would want to do research and who would need funding to do research, and what your programs would be with regards to assisting even students with proposal developments and actually performing their research, even those out in the field and those within the laboratories which you have spoken about. I think cases in point are the request from the NDOH on the study of the Jagersfontein mine as disaster. And I think it's quite worrisome that you would have picked up arsenic in the soil. I don't know what levels those are because those were not mentioned by yourselves, and the lead in the water. And we know as medical scientists what those levels ought to be, that would be safe levels for society and for the communities. So I'd be quite interested in hearing from you what those levels were. And the question is, all of the other similar dams, mines which have unused mines, decommissioned mines, would we find similar situations in those dams? And are you thinking of doing such research to look wider than just the Jagersfontein one? And then the other case in point, of course, is your 4 additional extramural research units. We congratulate those members whom you have appointed, but we'd like to see you do much more current research. Yes, I do congratulate you also on the work which you do in providing leadership in this regard in South Africa. Yes, but let me hear what you would answer on that question and the questions of the other members. Thank you very much.
Chair, should I start with you or should I go?
You can start with me. Thank you.
Okay, so Chair, that's a great question. You know, how do we decide on research? And so this is a collective effort. We look at the 10 most common causes of mortality and morbidity in South Africa. We also work with the NDOH on their focus, as well as the National Health Research Committee. And working together, we look at what is the current problem and what could be future problems that we need to address. And so I'm glad to say that the National Research Committee will be meeting this in early November to set the strategy on health research in the country. And we attend these meetings and we're on the committee. And we also make sure then that our research is aligned to what the NDOH require and what the country has put forward as the research agenda. So it's a very collaborative approach based on burden of disease, the NDOH priorities, and what's coming out of the National Health Research Committee. So we don't make these things up ourselves. When we look at the 10 most common causes of mortality, we hold research priority meetings with various stakeholders to come up with important strategies that the MRC can afford to fund. For instance, for TB, we've spent a lot of money on developing TB diagnostics, and I'm going to ask Michelle Mulder later on just to talk about it. Our commitment to environmental health is what we do with Angie, as well as climate change, and we're doing some work on temperatures in schools and in clinics, and how changes in temperatures over time affect child health and particularly in schooling. And so we spend a lot of time working within the country about research priorities, and then also, because we have so little money, is that we look at the research that's coming out and decide, okay, what do we need to do better or more in certain areas? For instance, I'll take TB again. When we looked at our portfolio, we've done a lot of successful TB diagnostic programs which are being used in the country, but we hadn't focused enough on developing TB vaccines. And based on the mRNA technology we now have in South Africa, and understanding a little bit more about correlates of infections and immunogens, we're working with the TB scientists in South Africa to work on a TB vaccine using mRNA technology. So that's a very important aspect that we do. In terms of assisting young people, we have this what we call self-initiated research grant that anyone can apply for, and we have two streams, one for early stage investigators to help them develop, and one for more established researchers. In fact, the first research grant I ever got in 1993 was 40,000 Rand from the MRC, and these SIR grants are the catalyst for clinician scientists and scientists in our country to move along in their research career. So it's a highly successful program, and it's been running for many years, including when I was a 32-year-old pediatrician. So I think that's a very important thing to try and grow, people growing our own timber in our country. In terms of in other ways of setting up the research agenda, NDOH has also noted that they want to eliminate malaria. So even though malaria is not the 10 most common causes of mortality in our country, malaria elimination in our country is tangible. And so we need to work with the NDOH to make sure that we eliminate, one of the first countries in Africa to eliminate malaria would be wonderful. So we do work closely with them to try and understand how we can improve on this, and other issues that the NDOH may ask for us about, particularly say the issue of Jagersfontein. In terms of our extramural units, we have grown them, and we keep on looking at the landscape to make sure that we focus both on current and future issues, everything from mental health issues to precision medicine. And so we feel that we are straddling both the present and future health problems in our country, including using the fourth industrial revolution to help us. So I'll stop there with that, and I'll also get my other members of the team to add if I've missed anything, and then I'll move on to Honourable Member Ismail. Some of the issues around the legal fees and the issue around VAT and SARS, I'll let our finance manager and our legal people talk about. But I'll talk about our postgrads and do they get jobs. So we track this. So even though it's not an indicator for the MRC, we do track our postgrads, and we're concerned about them because we invest a lot of money in their masters and PhDs. And so I don't want to lose them in the pipeline. So we've created postdocs, internship programs, and networking in South Africa so that these young people can stay research active and stay in jobs. So we do track this, and we are, and maybe Michelle Mulder can say some more about how many of our postgrads get jobs. So we do track. In terms of our public-private partnership for HIV vaccines, we know that it's very hard to make an HIV vaccine, that the virus replicates all the time, and it's hard for us to find some of the non-variable areas that we can make immunogens to. And so we work very closely at a global level to try and find an HIV vaccine. Finding a COVID vaccine was easier. To get the neutralizing antibodies that we need for an HIV vaccine, it's about 50 to 100 times more than we see with SARS-CoV-2. So this continues to be an endeavor. At the moment, we are working in a vaccine called PrepVac, which was mentioned in Verulam, where we are looking at various vaccine strategies together with pre-exposure prophylaxis. And we continue to work in HIV vaccines, and hopefully we're going to be doing some monoclonal antibodies using passive infusion of antibodies that protect against HIV acquisition, both to try and prevent and eliminate breast milk transmission, as well as in preventing sexual acquisition of HIV. So this will be a lifelong project, and hopefully one day when I'm old, there will be an HIV vaccine, because I've spent, and many of us have spent since the early 2000s trying to find an HIV vaccine. So we remain committed, but it's a long journey. Hopefully with mRNA technology, we can do some of the work much quicker. So there's lots of strategies that we're working on, and this will be a global endeavor to find an HIV vaccine. But South Africa will be critical in helping to find an HIV vaccine. In terms of our TB work, as I mentioned, we've done a lot of work in TB diagnostics. So we're now focusing on TB vaccines. We've invested a lot in treatment strategies to try and shorten the course of TB, as well as treatment for multi-drug resistance TB. We also have worked in femicide, and I think just recently we've restarted another survey to see how year on year if the femicide rates are changing. So I'm going to carry on, and then I'm going to ask other members of the team to pick up where I might have missed out. For Honourable Member Munya, in terms of graduating, we graduate people with PhDs and masters from many universities, including UCT, and so you're quite welcome to apply for when we have our calls. We're very proud of all our scientists who graduate, and we work very closely with them. A lot of mentorship and a lot of support overseeing with supervisors. In terms of helping the NDOH, yes, we have worked on the tobacco bill. There's what's concerning us is vaping in youngsters as a gateway to nicotine or tobacco use. But also, I think it's important we've also been working with the government on alcohol operating hours, and one way of trying to curb alcohol abuse is to try and regulate alcohol operating hours, and also where alcohol can be sold. And so it's an ongoing commitment from the MRC to support the government in making sure that we can reduce the harm that alcohol causes in our country. In terms of Honourable Member Clark, I'll ask Angie to talk about our wastewater. This has clearly been successful, and I'd like her to tell you which universities we've gone to and how it's worked, and the kind of expansion of capacity that we've seen in this area. In HIV prevention, in the very limited area that you just mentioned, this is our PrEP vaccine study, as well as looking at long-acting antiretrovirals to prevent HIV. This work, we work closely about how we can scale it up, and we work very closely with the National Department of Health to understand how to operationalize PrEP. So now we have oral PrEP, which has been rolled out in our country. There'll be long-acting PrEP as well as other interventions that hopefully young women can take. I'll ask our finance person to talk about the huge differences in surplus. Our lab costs went up because we did a lot of research, and we funded a lot of research in COVID, in HIV, and in TB, and that reflects the country getting back into the swing of things to do research when there was a lot of slowdown during COVID. In terms of targets of a population, we will continue to work with the Department of Health to find ways of increasing the rates of population-based vaccination. We just recently published with the Department of Health recent vaccine efficacy data in South Africa, which shows that we do need to continue to boost. We are concerned at the moment that people are complacent and don't want to get boosted. And so we're going to reiterate the importance of being boosted. COVID did have an impact on TB diagnostics, on HIV treatment, and slowly we see us getting back to pre-COVID levels with huge commitment from the health system. Mental health, I'm going to ask Mongezi to cover that. We do a lot of work with mental health. We have the university survey, which maybe Mongezi you can talk about. And then for Honourable Member Wilson, in terms of health and the poor people being poor, we've just established a health promotion and disease prevention cluster that hopefully will look at everything from food sustainability to proper food usage and issues around diet and that, and to try and improve the stunting in our country. There's a lot of reasons that cause stunting in children. We have a program called Healthy, which we work with China, India, First Nations in Canada and South Africa to look at pre-conception and in utero nutrition to try and improve children's outcomes. And so that's a very important area. We're also committed to the health of old people. Old people have been neglected in our country, and we're looking at innovative ways to reach old people, to identify who has blood pressure issues. The issue of polypill, we know in some countries a simple, cheap pill that addresses diabetes, hypertension, and cholesterol can reduce strokes and morbidity and mortality in old people. And so we're looking into this polypill and are working to see whether this can be evaluated in South Africa. I'm going to ask, I think I've done most of what I can do. Shall we start with the finance person, then go on to Angie, then Michelle, and then Mongezi? Philip?
Yeah, thank you, Prof. So we have Natalie here who will talk about the lab costs as well as the VAT issue.
Okay, Natalie.
Thank you. Good afternoon, honourable members. I'd like to cover the question relating specifically to the legal costs that was referred to. So the legal cost was as a result of a legal dispute that happened in 2013, 2014, which was a bonus dispute. The funds have not been, the funds was awarded by the High Court, and NAHAWU has not claimed that. MRC has not written off that funds at all. So NAHAWU is meant to claim that, hence it is reflected in our financial statements as a provision. Is that okay? The next question related specifically to VAT. There are a number of VAT matters reflected in the financial statements. The one specifically on page 309 relates to interest that was charged on a VAT return, and the interest, we received a refund, we received interest on that refund, and there was then an assessment done. The assessment then reflected that we had to pay money back to SARS, and the interest was then charged on the assessment. So it was a setting off, we received that interest, and we then had to pay interest on the additional assessment amount. Further to that, in 2016, there was a VAT assessment on an amount that we had to pay to DOH. That amount is still in dispute, and the information is reflected as a contingent liability on page 322 under contingencies.
The lab cost, do you want to mention?
Yes,
I
the
did
lab,
cover that, but you can carry on.
yes, you did, and it was accurately covered, President. So we've got the variance for the lab cost is as a result of the increase in activity due to the COVID and studies that has been undertaken. So there has been a huge increase on that, in addition to other studies for TB as well as HIV. So it's all laboratory costs that has been incurred.
And then the differences in surplus?
That's the one that Philip covered. Philip, would you cover that again, please?
Yes, I will just do the difference in surplus of 79 million in 2020-21 versus 6 million in 21-22. The main reason for that is that in 2020-21 we received a additional COVID allocation of 150 million. During that year, RFAs was put out, but not all the projects could be implemented. And a lot of those projects was transferred here to the 2021-22 financial year, and therefore we couldn't spend that money in the previous financial year that brought around the surplus of 79, but we managed to complete a lot of those projects in the 2021-22 financial year. The same with the consultancy costs, the increase there, that's also linked to all the COVID-19 activities that were undertaken in the 2021-22 financial year, as well as the same with the infrastructure communication increase of 33%. That's also linked to COVID-19 activities, projects that were implemented, as well as increase in our services, utility services, telephone, security, and insurance. Thank you.
Shirley?
Angie.
Oh, Angie, do you want to cover the wastewater?
All right. So the provinces that we now have sites in is the Western Cape, where the MRC is the main partner, and then Gauteng, where we partner with Sipako Makgato University, Northern KZN, and our partner there is the University of Zululand, Limpopo, where we partner with Univen, and the Free State, where we partner with the University of the Free State, and in the Eastern Cape is the final province, where we partner with the Nelson Mandela University and with Fort Hare. And capacity development under the leadership of Dr. Mungezi Mdluli has been key to this whole program. So we've been able to provide equipment and supplies. We've been able to provide training on data analysis, quality control, and the drafting of papers and proposals for new studies based on wastewater surveillance. And all of that contributes to a really excellent platform that we now have. And we are just starting to think around how we're going to extend the value of that platform to, for example, track pollution and track pharmaceuticals in the catchments of those wastewater treatment plants. Thanks, Mungezi.
Thank you. Good afternoon, honourable members. I'm going to just touch on three of the questions which Glenda has largely answered, but just to add to them. So there were two questions from the Honourable Chair and Member Ishmael around the students. So we do support students who are applying for scholarships and career awards to assist them in developing proposals. We also have a program around mentorship. So a number of our programs require co-supervisors either within the MRC or the universities, which really allows them to get a breadth of experience and mentorship and supervision to ensure the success of their studies. And then the question around their, where do they go from here? There is no delay. They generally are immediately taken up by either the same university. I don't have the specific figures with me, but there does seem to be quite a large success rate in retaining those students within the same universities, and in fact within the MRC, they go on to get research jobs within the same institutions, or they move to other institutions. And what it shows is that they become quite marketable as researchers, stemming from the award and from their studies. Also to mention that on the question from, I think, Honourable Member Wilson around connection to diets, NCDs, etc. Glenda mentioned the Healthy Project. The one other thing that has come out of the Healthy Project is an extensive investigation around the community, social behavioural, mental health, and other issues within the Soweto community in which this cohort resides. And a lot of important information has come out of that around simple things like the inability of women in those communities to just go for a walk safely and to really, safely exercise, to access food, because they aren't always the ones making decisions about spending household income, etc. And the important thing about that is that there are interventions that are being tested, as Glenda mentioned, from preconception all the way to early childhood to prevent the stunting, the childhood obesity, and to really address future non-communicable diseases that may affect these populations. The question around mental health, we do have some specific programs in mental health research, one specifically with the Newton Fund. We also have a co-investment with the Gabriel Foundation at UCT on traumatic brain injury. And we're currently looking at a new program on genomics and mental health. So trying to look at a genomic link between certain mental disorders and obviously the host genetics. And then finally on the TB and HIV, Glenda mentioned we have looked at some priority setting around that. We held a workshop specifically with the leading TB researchers in the country about 6 weeks ago. We looked at what we're currently investing in and where the gaps are. And this will really form the basis of our new TB investment program going forward, which, as Glenda mentioned, is largely going to be focusing on vaccines, but also subclinical TB and taking some of these diagnostics to the market to ensure that they have impact. And then we'll do a similar exercise on the HIV front. We still have our historical investments in HIV vaccines, HIV cure, etc. We'll look to take some of those forward and to make new investments in future. I'll stop there.
Thank you, Shelley. So, Honourable Chair, just to finish off on the issues around what Shelley has just mentioned on the mental health. We also initiated a study together with University South Africa. That was around 2 years ago, where we invited other universities to participate in the mental health survey that's conducted by one of our early career scientists, Professor Banchis, who is now the MRC employee. And out of the 26 universities that were contacted, only 17 universities participated in the study, and about 28,500 students participated in the study. There's a report that's going to be issued, or a paper, a publication on the results of the survey. But safe to say that some common mental health illnesses were seen in the universities, and there were no disparities between the historically disadvantaged and historically advantaged institutions, just in briefly. And secondly, still on the mental health, the MRC has now, together with a university, I think University of Limpopo, going to establish a research chair on mental health, so that we have a widespread of studies happening in the country. So that's happening. And then there was a question around the targets. I think it was asked by Honorable Ismail, whether are we going to improve the targets. So what we did in 2020, when we set our new strategic plan, we set the targets for over a 5-year period. And we took into account that, as you may have seen with when Philip did a presentation, there's going to be a decline in the baseline in the MTEF. And obviously our publications, they have to take into account our budget. So around 2022-23, having seen that there may be a decline in the budget, obviously we couldn't put the targets far much higher than we could be able to afford. And safe to say, again, as you've seen with a lot of money that came in regarding the COVID study, that's why we could exceed the target so much. But yes, we agree. On a continuous basis, we look at our targets and we adjust where possible. I think I've touched all the questions around that were supposed to be touched. Thank you, Chair. Glenda, if there's anything, Prof, it's up to you.
Yeah, I think that you did it. I mean, maybe we should extend to the parliamentary committee the invitation to the National Health Research Committee meeting in November. I think it'll be important if we'll just let you know when it happens, in case anyone can come.
Thank you. I think you should. Maybe, yes, it's the right word. You should. But also extend to us, as you heard Honorable Munyai say, your mentorship program. Some of these want to develop proposals. Are you done? Are you done, Prof. Greg?
I'm done. I just want to thank you very much and just apologize for the hiccups. I think we must spend some more money on infrastructure, IT infrastructure.
I agree with you. Thank you very much. Thank you very much for coming, the whole team, led by yourself. It's always informative to listen to you and for all the work that you do in keeping our people healthy through research and innovation, etc. We've come to the end of this meeting for this afternoon. And so, yes, you are free to leave now. I only have a few words. Honorable members, we will be starting at 1400 hours. Our program has changed a little bit. We've have the Health Ombuds who will come at 1400 and not at 1500 hours. And we're trying to get Dr. Krishna Sami and his team for 1500 hours. So we're able to go home early today. You are at home, but if you're at Parliament, you'll be able to go home early today. So hopefully that's where we will be. We will start at 1400 hours today again. And enjoy your lunch. And thank you again, Prof. Gray and your team.
Thank you so much.
Thank you, Chair and honorable members.
Bye-bye.
Thank you.
Bye.
Bye. but I think this new way of working is really assisting. Apart from now, we're just working harder.
Yeah, well, yeah, because you can get everybody anywhere in the world. You can't escape it longer.
Yes, everybody's just calling a meeting and you must comply.
Yeah.
But it's like a lot of traveling time, I think, a lot of traveling time.
Yes,
Imagine
yeah.
what's all in Cape Town today.
Yeah.
And
I think it has changed the way we work, which is quite useful. Yeah.
Yes, very welcome. I want to make sure whether everyone is on the system still. So we'll start in a minute's time.
That's fine. That's fine. I'm ready.
Yeah,
Honorable
thank you.
Munya is here.
Thank you.
Good afternoon, Prof.
Good afternoon.
Good afternoon, everybody.
Good afternoon, honorable member.
Good afternoon, Prof.
Good afternoon, honorable member.
Good afternoon, Chair. Good afternoon, Prof. I just want to notify you that I am on the platform.
Well, we have been on many platforms together recently.
I don't know, Chair, I don't know why my camera is not working. It just gives a black thing. I'm going to have to ask IT to look at and see what's going on with this computer.
No, you can certainly hide behind that today, Honorable Clerk.
No, I'm looking for to prove to you that I get dressed and do the hair and the makeup every day. And I especially got ready for Prof.
Oh,
that's an honor.
yes. I was going to say, Prof, you're very well liked by the look of things. Now you're here. Other members, are you all here? I want to hear the other voices for us to start.
Afternoon, Chair and Professor, I'm present.
Oh, nice to see you.
No, we're still here, Prof. Doctor.
You're going to be here the whole day, I suppose.
Yes, we've been going since early morning, and it's just for this week. This is a tough week, but we're managing. I think the members are doing well. We're all surviving. I think we're going to start now.
I'm back. Good afternoon, Honorable Prof.
Oh, good afternoon, honorable member.
Thank you.
So, Professor Makgoba, thank you very much as the Health Ombuds to this meeting of the Portfolio Committee on Health, which is a continuation of a meeting of this morning. We've had a number of presentations since yesterday in preparation for the BRRR process of Parliament. And we've also had the briefing from and presentation from the OHSC. We've had a number of these presentations from you before, and we always look forward to interacting with you and, of course, to assist where we can as the Portfolio Committee. And I know your presentation is probably not going to be very long today, so I've taken the liberty to ask Dr. Barry Kisnasamy of the CCOD to come a little bit earlier if it's needed. So we are honored to have you, and thank you very much for coming, and we're looking forward to what you're going to be discussing with us. Thank you. Over to you, Prof.
Thank you, Dr. Jacobs, honorable members. It's really my privilege and honor to have this session annually, I think, to present, the work of my team as a complement to what you would have heard, I think, from a presentation of the OHSC in the morning. First of all, I'm doing this presentation accompanied by Dr. Jacobs, Mr. Douglas Mapeto, who is a senior legal advisor in the Office of the Health Ombuds, and Ms. Helen Petwana, who is the senior health investigator in the Office of the Health Ombuds. So that is the team that is present from my office. I have really got just about 5 points that I want to bring to your attention on this presentation. The first point I want to present is really a progress report. In my last interaction and meeting with the Health Portfolio Committee, we discussed the issue of the Health Ombuds bill, and we then corresponded to request that I meet with the minister and map a way forward. I'm glad to say that I did meet with the minister and his team, and we came to the conclusion that this was an urgent matter to complete the bill and the business plan for my office. And to that effect, the minister appointed Dr. Nicholas Crisp to prepare the bill, and the bill has been prepared. I think it is on its way to, has been commented by the state law advisors. It is on its way to the cabinet, and I'm told that after cabinet, it will come to the portfolio committee. I think before then it gets commented. But I think the bill is an improvement on what we had before in terms of, I think, the mandate, I think the appointments and the objects of what the Ombuds does and the consequences of his work in relation to the total national health system of the country to assist that. So that is the first point I want to make of progress that has been made, that has come out of our meeting last year. The second point I want to make deals with the unit of complaints and assessment in my unit. This is a unit that has really received the complaints, and in total, over the period of 6 years, we have received 9,490 complaints, the majority of which come from the province of Gauteng, about 57%. And the majority of these complaints are brought to us through emails. And I can say that the majority of them too are often low risk type of complaints. And the majority of this, about close to over 96%, have been resolved completely within the prescribed time. And we have had an annual 28.4 increase every year since 2016. And what is more important is that this unit of the complaints unit and the assessments unit have been receiving feedback from the complainants that are captured, I think, on page 5 and 7 of the report. And these are really positive feedbacks that talks to the speed and the professionalism of the people that work in both of these units. So that is my second and third point, the complaints and assessments unit and the feedback that they've received from the people that they serve over the past 12 months. And the third point I want the fourth point I want to talk to, it's really what I call a project that we have undertaken in my office, which has twinned my office with the Parliamentary Health Services Ombuds of the UK, in which we decided on a series of projects that are articulated on page 11 and 12 of the report. Largely, these are learning exchanges between our offices, but more importantly, these are programs to benchmark ourselves and to know what the rest of the world is doing and be able to keep up to speed. And it is funded through the so-called Better Health program that is funded by the British government. The areas that we have covered between ourselves and the Parliamentary Health Ombud are really an overview of our methodology, the prioritization of cases that we investigate, the quality assurance that are supposed to be involved in this, the early resolution and mediation of some of this. That's why we have about over 96% of our low risk being resolved. Communication with complainants, and that's why we have the feedback program that you have had, and case studies, which really talks to the fact that medicine has become so complex that even as the health ombud, you cannot know every aspect of medicine. You require other people that know better, say, for example, in the field of obstetrics, in the field of psychiatry, and in the field of genetics, and in the field of biochemistry. So when you investigate complaints, it is often very useful to humble yourself, to require and call upon expertise, since most of our work is going to be subjected to court reviews, challenges, and so forth. And you don't want to run the risk of being told that, how can we trust your judgment on this when you're not an expert on it? So we engage ourselves in this matter. And the last point that we did between ourselves was really a clinical advice learning exchange between ourselves and the UK. But more importantly, just to finalize this point, is that as you know, when I was Vice Chancellor at the University of KwaZulu-Natal, I established with the former Public Protector Mushwana, the so-called the IOMA, which is the Association of Ombuds, I'm sorry, AOC, which is the African Ombuds Research Center that is located at the University of KwaZulu-Natal. This was established many years ago, and the former Public Protector, Tuliman Tonzela, was actually an associate professor in that unit. And they are now conducting seminars around leadership, and they are linked, as we are linked to the Institute of, the International Institute of Ombuds, and they are also linked to the African Ombuds Mediation and Assessment Body, which is located in Africa. And this teaches us on how to handle complaints, but also it is internationally benchmarked, and we are able to know that what we are doing is right, or we can improve in the following manner. So those are the areas that really cover this issue. And the final point I wanted to share with you really deals with the issue of a visit that I made towards the end of last year to the Eastern Cape, because the Public Protector and the Office of Health Standards had done an investigation in the Eastern Cape looking at 3 hospitals: the hospital at Livingston, and the hospital at Doranzinga, and the Uitenhage Hospital. And there were complaints that the quality of service delivery was suffering. So after the initial reports that were produced by the Office of Health Standard and the Public Protector, the findings were largely the same. I went there a year after to go and see whether the recommendations that were made by those 2 offices had been addressed. Regrettably, I engaged the Department of Health in the Eastern Cape through their HOD and their DDG, Dr. Matiwana, and they had hired a quality assurance expert, Mr. Musibi, who used to be the former CEO of Ohsc. I involved Denosa, Nehau, Hospesa. I also involved the leadership of health in terms of the CEO of the 3 hospitals, the district health leadership, and I brought them together over a period of 3 days, partly because I did not regard this as a complaint, but to try and assess whether the quality of the recommendations that had been made by both structures were being undertaken by the Eastern Cape Department of Health. Lo and behold, I came to the conclusion with one major findings, although there are specific findings for each of the hospitals, that the relationship between the labor structures in the Eastern Cape, that is Denosa, Hospesa, and Nehau, together with the Department of Health in the Eastern Cape and the medical profession within the Eastern Cape are really not helpful. And it was worse even in relation to the medical school that is just emerging in that part of the world. However, because I had the DDG and I had the dean of the medical school and I had the quality assurance person who was supposed to mediate between the three, I made it quite clear to them that really the only stakeholder that suffers in their low trust relationship is the poor quality service that they provide to the patients of the Eastern Cape. And it is up to them really to raise their standards and see that, things are improved. In their own words, they describe the service as being chaotic and in a mess. All the stakeholders, they agreed. The medical profession blamed sometimes the health department blamed the labor formations, the labor formation blamed both. So all of them were at each other's neck, but nevertheless, I think the service there was not of good quality. I say this just to reflect that over the past 12 months, and I think it will be a report for next year, I visited all the province. And it is becoming quite interesting, and I think the portfolio committee should be alerted to this, that the quality of health deliveries in our hospital is deteriorating. And whilst we're preparing ourselves for the NHI, we don't seem to be raising the standards in the service delivery that we are giving to the population of South Africa. Of the 9 provinces that I visited, the only province, and I'm going to say this, the only province that seems to have got its act together is the Western Cape. Under Mbombo, Dr. Mbombo, or French Mbombo. They seem to have got their act together. They seem to understand their mandate. They seem to want to serve the people of the Western Cape. The other provinces are really in difficulties, and I think they need to be called upon to jack up their work. So on that note, honorable members, I will stop, and my team is ready to take questions. I know that lots of you will have lots of questions to ask, and I look forward to engaging this. As a final note, this will be my last presentation to the committee, as I will not be the Health Ombuds from next year, June. Thank you again. Thank you, Dr.
Very much, Professor Makgoba. I'd also taken my jacket off. It's becoming exceptionally hot now. So there are some members who'd like to engage with you. Very insightful presentation, very frank, open, and thanks for also alluding to the visits which you had done to the provinces, and also the outcome of those visits and the challenges which we face in the health sector. I'm going to take the names of the members. I have Honorable Gela, followed by Honorable Van Staden, Clark, Wilson, Munyai. Gela.
Chair, raise my hand on our WhatsApp group first. Please note me.
Okay, so did I not mention you now, Honorable Ismail?
Not at all.
Okay, good.
Please mention my name, Honorable Chairperson. My hands are up.
Okay. So it will go like this. Gela, Ismail, Van Staden, Clark, Wilson, Munyai, Slengwa. Any other members? If not, let's continue in that order, honorable members. So I'm going to repeat: Gela, Ismail, Van Staden, Clark, Wilson, Munyai, Slengwa. Honorable Gela.
Thank you very much, Chairperson. Let me welcome the report from Prof. Although it's frustrating, but we understand and there is a room for improvement as our government is trying by all means to make sure that the health department it's where it's supposed to be, and also challenges that you have raised will be addressed. But Prof, I think the NHI, it's a good move for us as a South Africa to move to NHI to address the challenges that you have just raised, and also to be in level with other countries where they've already implemented the NHI. Coming to the issue of Eastern Cape, we note the report as presented before us, but also I think, Chairperson, we need also as a portfolio committee to visit this province and also to check actually, and also how far is the process or progress after the op-ed, whether they've been addressed or not. Those are my two questions. Thank you very much, Chair. But we welcome the report. Thank you. Lastly, I think, Prof, maybe there are one or two things that are also good in other provinces. Also the Gauteng and Limpopo. I don't know, but you said Western Cape, but I think also other provinces in other services there. Thank you.
Yes, Chair, I'm just waiting for Honorable Gela to finish. Thank you, Chair. Good afternoon again. Prof, yes, Chair. Can you not hear me, Chair?
All right,
Chair,
I can hear you now. Yes,
Thank
I
you.
can hear you now.
Okay, good afternoon once again, and thank you for the presentation from the Office of the Health Ombuds. I must say, Professor, it has been really, phenomenal to be working with you as the Health Ombudsman. And, you've really set a very good track record, and I hope the person after you actually follows in your very good, in your footsteps, where you've really set a very high standard, going forward. I just have a few questions. You have responded on a few of my clarity-seeking questions. But firstly, I note 5 vacant positions within the complaints investigation unit. Have these vacancies been affected, or should I say, is it due to these open vacancies that, the Health Ombuds Office cannot actually do their work optimally? And how have these vacancies, basically I'm asking, how have these vacancies affected the stipulated timelines for resolving complaints, and when will these vacancies be filled? I need also, maybe you could update the committee with on the appeal process by the 2 appellants on the Tembisa Provincial Tertiary Hospital investigation report. There was a big hype on it in social media recently, and I think it's important for us to get the report back. And also on the Tembisa report, can the office share with the committee the progress made in implementing the Ombuds recommendations by the Gauteng Department of Health and the hospital? It seems to be an ongoing issue, and it's important for us to get a proper report back. I'm not going to touch on Eastern Cape. I think Honorable Gela has. With regard to whistleblowers, like Dr. Tim Meyer, the whole issue, and it was really shocking what took place there. How has the Office of the Health Ombuds dealt with this matter? Your findings and resolutions on this matter, because this really sets the precedent to be able to say, whistleblowers should actually be protected and not be treated in a manner that they have been. You're looking at the Babita issue as well. My next question, Prof, is, has the OHO actually received any COVID-19 vaccine related complaints, adverse events, etc.? If yes, how did the office actually handle such complaints? My last question, We all believe in universal healthcare. We all support universal healthcare. But in the South African context, Professor, we know that the NHI requires public healthcare facilities to be compliant with certain criterion. Do you feel, I mean, honestly feel that the OHSC and your office will actually be able to inspect all our health establishments in preparation of the NHI? And do you think most of our public healthcare facilities will actually meet the NHI prerequisites? On the very same point of the NHI, Prof, what is your view on the fact that when you compare, you know, we all say universal healthcare, whether it be NHI or NHS, and you know what's happening in other countries. But if you're looking at the platform base of maybe we look at the UK and we look at the challenges that they are actually facing with the NHS and comparing it to South Africa, where when they actually implemented the NHS, you know, they had a much more functional, you know, healthcare system. When I say functional, I'm saying not to the point of having such high shortage of staff, not to the point of having such, you know, when I say a fragmented healthcare system, I mean infrastructure based, etc. What is your opinion on how it will actually be playing out in South Africa, considering, as you very well said before, that you know our healthcare is actually, let me put it frankly and very basically, you know, we have a lot of work to do still when it comes to our South African perspective of our healthcare system. Thank you, Chair.
Should I answer these two questions first? Dr. Jacob?
Prof, yes, Prof. So
Oh,
if, you
okay,
haven't taken, if you're not taking them down, then maybe you should do that first.
Let me do them before. I've got a short attention span. Maybe I've got ADDH or something. But let me take Honorable Gela's questions. First of all, I happen to have worked in the NHS in the UK for a period of about 15 years. So the idea of universal health coverage has always appealed to me. In fact, when I think Minister Motsoaledi initiated this, I supported him through you know, interviews to support that this was really the right way to go. I wrote papers in relation to this matter, supporting that South Africa deserves, I think, to implement an NHI as a system for universal health care. So it is not something that I'm opposed to. It is something that I strongly support, that I think it will bring health equity into the country and it will serve all members of our society. I think in relation to my comments on my observation in the provinces, just to touch base, there are lots of goods and pockets of goods that are happening in the provinces. But let's remember that my mandate only investigates complaints that come to my office. And I can tell you that the three provinces that gives me headaches is Gauteng and Limpopo. I'm not saying that there is nothing good that takes place there. There is a lot of good. But when I and my staff visit Limpopo, they get some of the, you know, the most troubling complaints from those three provinces. You know, the Northern Cape is hardly ever complains, but maybe it's situated in a desert and maybe they haven't caught up with what we do, although we have spent time with them, the MEC and his department. So I agree with Honorable Gela that there are lots of good things that are happening. The NHI is a necessary evil that we must swallow. It is an important, I think, structure that I think the new government has taken, and we must support it, all of us. To come to Ms. Ismail's question, there are vacant positions in my office, about 5 of them she mentioned. Let me state clearly, the 5 vacant positions in complaints and in the assessments do not really have not affected the work of the complainants, the complaints and assessment unit. The unit that is mainly constrained in this process is the investigative unit. And I think it is the unit that experiences backlogs. It has only at the moment, only 3, I think, staff members. And the investigations, because of the nature of the complexities of the complaints, often take too long. Now, to come to the Tembisa matter, on the 27th of January 2021, I presented my report on the circumstances that led to the death of Mr. Shonisani Litole. And as you know, the appeal process requires that within 30 days, an appeal should be lodged. And I had identified 20 people that needed to undergo disciplinary processes. And out of those 20, 2 made an appeal to the minister. And the minister duly appointed a tribunal, and they requested all kinds of information. In fact, it was almost like they wanted to revisit the investigation of the ombuds. Be that as it may, because everything in my office is recorded and is kept on record in terms of documents. We provided them with every kahoot that they wanted. On the 5th of October last year, the tribunal invited us to make presentations, and it's chaired by Judge Nkabinde, Bess Nkabinde. And after that presentation, we have not had anything. We have not had a thing until maybe a month ago. We were given an information that at the end of September, they will write to us and tell us when they are going to make their judgment. As September came and they never said anything. And just today, I received a note that they will be writing to the Department of Health again to find out what is really going on. This is our lawyers. So in terms of this appeal, if the portfolio committee complains about the ombuds taking long to investigate, this process has taken from the 27th of January, 2021 to today without an answer. Now, as they say, I think justice delayed is justice denied for both parties, both my office. But remember that, as I say, there were 20 people that had been identified. And those, I think the Gauteng government is following its own process. And I think Mr. Mapeto can comment on that. The issue of Dr. Tim Myers, I think, as you are aware, I think, Ms. Ismail, I have mounted an investigation into this matter. I am actually literally going there tomorrow to meet with the CEO of the hospital, and then I will meet with the complainant, and I will be, at some point or another, I'll have to meet with Dr. Meyer. I agree with the concept that I think all whistleblowers must be protected, and hopefully that's what will be done. In terms of vaccine-related complaints, as the Office of the Ombudsman, we have never received any of that. I think the question you ask is about the Ohsc, Inspectorate, and the NHI. My view is, and I've shared this with the Ohsc, that they need to set up a program of all the health establishments as to how they are going to inspect them and how they are going to certify them. As things stand today, I think we couldn't go into the NHI with the level of inspectorate and certification that we have done so far, because I suspect that most of the hospitals will not meet the high standard that are required, I think, to meet the requirements for the NHI. But it doesn't mean we should stop trying. It doesn't mean we should stop putting our energy. I think this is an important project of the new government. It is really, it levels the playing fields of our country, and we should all put our effort into it. I hope that answers your question. Thank you.
Thank you, Prof. The next questions, I'll take them then 2-2 for you. I have them on my system now. Okay, so Gail and Ismail, Van Staden and Clark.
Thank you very much, Chairperson, and Professor. It's nice to see you again. You've answered most of my questions, so my list is a bit short. I only have 3 questions for you. Regarding staff in your office, is there enough funding for extra staff members, and do you need extra staff members? That's the first question. My second question is does this office has the sufficient funds to be able to perform the duties properly? And then my last question is on the number of complaints that has increased, can surely not only because of the COVID restrictions. Can you please explain to us, Professor, what the exact reasons for the complaints are that your office are receiving over a period of time or in this financial year? Thank you very much.
Okay, I think Clark, I must have Clark now.
Thank you very much, Chair, and thank you, Prof, for your presentation. And I would also like to thank your office for always being willing to assist when issues are brought to us as members that need to be investigated. I must say to you that I do my own oversights a lot, and I had done an oversight at the Livingston Hospital in July, as well as Rahima Musa. So, the issue around Dr. Tim de Meyer, there's also a lot of issues around the hospital itself that also needs to be attended to. And I listed what I had uncovered, to your office. Then in terms of the Livingston Hospital as well, I was there in July, and I can tell you what I saw in July was horrific. And that's why I agree with Member Gela that we need to, as a committee, go and visit these hospitals. I mean, I found that the health cleanliness was just terrible. There was feces backed up in the toilets and the bath, no sufficient equipment or resources to perform orthopedic surgery. Doctors were resigning in droves, treatment of doctors and staff shortages. They were exhausted, the medical staff there. Supplies not paid on time for about 3 years. IT equipment not functional, no clean linen, theatres not able to operate at full capacity. And those are just some of my observations at the Livingston Hospital when I attended that hospital, myself going on an oversight. So that's the one issue. And then just in terms of the vacancies, I'm sure it is concerning for you as the Ombudsman, in order to really do what is needed to do. And are there any plans to fill those vacancies? And how does the Ombudsman intend to address the lack of response from health establishments to their queries, which results in low target achievements? What measures are put in place to address the large backlog, and what is envisaged timelines to address this? And what does the Ombuds need to eradicate the backlog and ensure timely address of new complaints? And then does the Ombudsman have a breakdown of the type of complaints received? Are there common theme issues regarding these cases? Because they have increased by about 29%. Thank you very much.
Thank you. Let me start with Mr. Van Staden's questions. Just to give you as a matter of comparison, the United Kingdom has got a population of about 67 million. And South Africa today has got a population of 60 million. If you look at the office of the Ombud in South Africa, we really do not have enough staff to do the work that we're supposed to do. The Office of the Parliamentary Health Ombuds in the UK has a staff of 450 staff members. As you can see, I only have 3 investigators and a manager, and I have to borrow staff from the OHSC if I need that. And that's one of the issues that have provoked the matter of the bill. So yes, we do require extra staff, and we require lots of extra staff. Do we have sufficient funds? No, we don't, but I think we are able to make do. I think in Afrikaans, they say, a boer maak 'n plan, and I think we have adopted that attitude. It seems to work. I think we work very well and smartly with the Office of Health Standards, and they've been able to support us in the way that we do need and request them. But frankly speaking, we need several millions that we don't have. I mean, we don't even have a fraction of what the public protector has. And as you know, the health sector is a huge sector that has got a lot of complaints that requires a number of issues to be addressed. And I think this office could do that with a little bit of more staff and a little bit of funding that is directed towards it. What are the types of complaints that we are receiving? I think in the office, generally, I think the complaints are related, to poor quality of service that is delivered to patients. I think that's the general or poor advice that is given to patients, and delays, I think, in seeing patients. But there is a new phenomenon that is also emerging of the types of complaints that we're receiving. It is people who, as a result of maybe of poverty and others, wants the Office of the Ombuds to provide them with a license either to sue doctors or to sue health establishments. Now, that is something that exercises my mind when I see a complaint, because often, I think you'll see in my report, there have been areas where I've refused, I think, to get involved, where a hospital or complainants invite you to something with the hope that they can swing your mind around, and then they are able to sue either the doctors and so forth. So that is an emerging phenomenon from the types of complaints that we are seeing. Now, to come to Ms. Clark's complaints about Livingston and Rahima Musa, I was in the Livingston area for 3 days. I couldn't agree with you more about what is happening at Livingston. When I was a medical student in the 70s, Livingston Hospital was the place where we all wanted to be to go and train. I don't think I would want my daughter, who's a doctor, to go and train in Livingston today, because it is just so filthy, so disorganized, and I'm not sure what is supposed to be happening in that hospital. But I would agree, I think, with Honorable Gela and yourself, that maybe as a committee, I think you should dedicate time just to go and look at those 3 hospitals in the Eastern Cape, in the Bay Area. In terms of Rahima Musa, a team of my investigators has already gone there to do the preliminary investigations. And as I've said, I'm going there tomorrow, and I'll be seeing the MEC on Monday, and I'll see the HOD after that. And I'll see, I think, Dr. Meyer. Clearly, from what I've seen, that hospital is another one that is in big trouble, but I have to go there and probe the sort of questions that I have at the back of my mind following the preliminary investigations that I've received from my colleagues. But it's another one of this hospital that seems to be living in another world and not in the South Africa of today. So I hope that I have answered some of the questions from both honorable members. Thank you.
Thank you very much, Honorable Wilson and Munyai.
Thank you, Chairperson. And Prof. Makoba, you've broken my heart today. It is absolutely devastating to hear that you will be leaving us in the next few months. You have just been so phenomenal in every meeting that we've had with you. And I cannot begin to tell you how much we appreciate your honesty and your transparency. And I think that's vitally important. And I think that's what we need more of, particularly in these departments, and considering the kind of issues that we're facing at the moment. So it is absolutely devastating news. I'm sure you're looking to a bit of a retirement and a bit of a break, particularly after the many years of hard work that you've put in. And while we're pleased for you, we're very heartbroken for us, and you will be sorely missed. We've talked about Limpopo, Prof. Makoba, and as you know, I am from Limpopo, and that's where I do a tremendous amount of my oversights. And the situation here is really horrific, and we have raised issues around several clinics, and in particular the Philadelphia hospital, which is an absolute nightmare. And just this morning, I received a video of a woman giving birth at the gates of a Burgers Fort clinic. It was just before the clinic was due to open. The sister was shouting at everyone, telling them to keep quiet. She slowly put on her gloves, and the baby was delivered a few minutes later. And all on the grounds, and she wouldn't open the clinic because the clinic only opened at 7 o'clock. Now, you know, I have, and this is one of probably many you've heard of, many situations we've dealt with like this. But it's very, very tragic when we sit with a situation where medical personnel, on the grounds that the clinic doesn't open till 7, deliver a baby on the ground at the gates of a clinic. You know, it absolutely blows my mind that a woman should be treated to that kind of undignified and inhumane treatment when it was a case of literally opening a door, getting her onto the bed and delivering the baby in a proper facility. Having said that, I can't agree with you more about Limpopo. It's obviously where I am. It's obviously where I do my oversights, and it is a huge problem. But I think my biggest concern, Prof. Makoba, and I've raised this in many, many meetings before this that we've had with you, is that you are just so seriously understaffed. And you've given us the comparison of your office with that in the UK, and we've seen that before. And despite the fact that this has been raised in several reports from us, it appears not to have been dealt with. And when we are sitting with a situation where we're sitting with 125 billion rands worth of medico-legal claims, I can only imagine what you're going through and how difficult this has become. The problem is what we are seeing is a continual decline in health and health facilities, and we've talked about several today. And those medico-legal claims are probably going to rise quite considerably over the next few years. And this is going to put your department under even more pressure. And you know, when we're sitting with medico-legal claims that are actually in excess of our own annual budget, the situation has got very, very problematic. But I just, and you know, it's little things that bug me. I'm busy with the report, we're busy with the affidavits. I have raised this in a meeting a couple of weeks ago at a situation at Grays where a doctor removed a cyst from a patient. That cyst happened to be that patient's bladder. It wasn't a cyst at all. What he didn't remove was the cyst. He actually removed the bladder, which also gives us serious concerns about the standard of training that people are getting. And I think this is fast becoming an issue. And the fact that doctors now will not enter into the public service. When you're sitting with 125 billion rands worth of medical legal claims, and the bulk of those come out of private health facilities, doctors and specialists and surgeons and even nurses are very, very wary about going to work in these facilities because they don't want to be at the back end of the claim. And the back end of the, those claims are easy because there's no infrastructure, there's lack of staffing, there's lack of theatres, there's lack of oxygen, there's lack of whatever it is, linen. It was raised by my colleague a short while ago. So surely, Professor Makoba, this should also be having a tremendous impact on where we're sitting at as a Department of Health in this country at the moment. But in closing, Prof. Makoba, you've done an absolutely sterling and amazing job. I cannot begin to think or imagine the pressure that you've been under, but we are so grateful to have had you, and we are going to be very, very sorry to lose you. Thank you, Chairperson.
Thank you. I think there is Manyai or something.
Oh, yes. Thank you very much, Honorable Chairperson, and I should also thank the Professor for really coming here. But the most important issue is to join hands with those that are, are concerned about your leaving. I think you are leaving pretty soon.
No.
You may not agree, but when you came to Parliament to try to to raise an issue that there should be difference between an ombuds, like any other country, you gave UK and other examples between ombuds and Office of the Health Standard Compliance. That time you were within the middle, covered by the Ohsc. So we're very happy now there's a bill that is going to liberate the ombuds to be really genuinely independent in terms of law. And I'm sure the necessary support is key. Financing and capabilities of the ombuds should be stronger. Otherwise, everything will be weak. So lastly, I think I know that we'll remember you by your frankness and straightforward, because you are not biased. I mean, if there's something wrong, like in our province at some point about life as demand, you were straightforward. Even if you are expressing a view on Livingston and other one, we know it's a genuine, you are a patriot who love your country, but then for us to fix things is to be honest with ourselves and transparent and be straightforward like you do. And I'm sure whoever that's going to be the ombud leader will be able to really follow your steps. But the question that I want to ask, in a South African situation, and I know you gave the UK example about 400 staff plus. What do you think a South African number ombuds should need to have beyond the affirmation to say that, no, look, we are right, we can do our work, but we know you're overstretched. The challenges of healthcare in the country are too huge. So therefore, you'll need capabilities in terms of human capital and as well as resources. Is there any indications of the numbers informed by your experience of South African situation? Just to align with other organizations, but of course, taking into account the material condition of South Africa. Your views in this regard, please. I'm very happy that you were able to clarify your experience in London so far as NHLS and the advocacy you would have made in support of the National Health Insurance. We believe it's important to do away with a two-tier system in the Republic to address issues of the equity. So that was very important on my part. Lastly, I must congratulate you in your new endeavor, be it retirement or other responsibility. but your brain seems still powerful to handle any capabilities. Thank you very much, Prof.
Thank you, honorable members. Let me first of all say to Honorable Member Wilson, I come from Limpopo. I was actually born at Jane First Hospital. I've got a very strong passion for being from Limpopo, and I get quite upset when I find that things don't work, like in places like in Philadelphia Hospital, Jane First, and so forth. But to underline, I think something that really the Office of the Health Ombuds, what does it expect of the health professional? We're not expecting anything extraordinary. We are just expecting that health professionals have codes of ethics, have codes of practice, and have certain things that they are taught, I think, to do in the most difficult circumstances. And all that the Office of the Ombuds deals with is to say, have you lived up to the codes of practice that all medical schools, wherever they are, teach you as either a nurse or a doctor or a physiotherapist? And so we are not saying you must do extraordinary things. Now, when initially I took these positions, there were a few things that I wanted to do, and there were a few things that I had discussed with Minister Motsoaledi at the time. And I think Minister Patla at the time was Deputy Minister of Health. One of the things was, if the health system and the health professional did the minimum that they are taught to do, we would not have medical legal claims like we have today in South Africa. And in fact, if the Office of the Ombuds had been sufficiently resourced and staffed, it would form part of alleviating these huge claims, I think, on medical legal claims that are being made by people around hospitals, around the medical profession. Honorable Mnyai, I'm not going to leave until the end of May, which is the end of my contract. I'm not immigrating. I'll still be here in South Africa, and I'll always be available to my country, especially the Department of Health that has looked after me for the past 7 years. So I will make the inputs that are necessary at the time when I'm required to do so. So I don't think people should be lamenting this. It's just a natural progression that you enter a contract, and when the contract ends, I think you must be honorable enough and give enough notice that, look, my time is up and I need to look at something else, or go and rest and look after goats in Skunot and Skukuni. So I'm around. I've been privileged and honored, I think, to be given this position. I've enjoyed doing it. I still will enjoy reading what my successor will be doing, and I'll be happy to support them. It's a very unique opportunity, especially that it comes in the period where we are going to start the NHI. This is a very big project, and I want to emphasize again, when the UK went into the NHI, they were poor, they were not rich at the time. Children in the UK were suffering from malnutrition, and the United Kingdom had just come out of World War II. So there was abject poverty around in the UK. But what did the British people decide? They decided we're going to invest all our efforts and energy into the NHS. Even today, the challenges that they face are still enormous, but you have never had a single British politician say, no, we must can it down, we must leave it. It is still the strongest things that bind British people. And that makes, I think, many countries like the US envious of living in Britain, the NHS. And whatever else happens, that is what gets protected. What sometimes I think irks me is that we spend so much energy in South Africa debating whether we should have it or not have it. And I find that lamentable, but I suppose that's the nature of our democracy, and somehow or another we'll overcome that. But it's an important statement, I think, that this government, the new government, can really stamp its authority to say, this is not negotiable. I think we go ahead, we're gonna invest in it. Health is expensive anyway, and it's not gonna get cheaper with time. It's gonna go more expensive. But it doesn't mean that we should allow ourselves to let people wither away because they cannot afford things. And I think that would be a very sad and traumatic story. So Honorable Wilson and Munyai, I'm grateful for your comments, but I will still be around to assist wherever I can. Thank you again.
Yeah, Prof. Honorable Hlengwa next, and then myself. Any other hands, honorable members? Hlengwa, you next.
Yes. Thank you, Chairperson. Thank you, Prof, for your wise words. And it will be very pleasure every time to listen to your wise words. But let me start with the complaints, because I'm the one who forwarded the complaint in June last year and never get the feedback of that. My complaint was about the passing away of Mrs. Tole in Edeval General Hospital. There is no feedback, there is nothing. Even the social worker to come to her family to counsel the children, there is nothing. Therefore, I'm pleading the professor to come and see that case of Mrs. Tole at Edinburgh General Hospital. Secondly, it's very a concern to me in KZN, there is a stage of cancer treatment or cancer equipment, more especially in Grace, because Grace is a hospital where cancer patients go to. But what worries me, patients from Ngutu to Newcastle then go to Grace. It's a long journey going with a bus, only to find when they are in hospital, they find there is no oncology or equipment or medication. They have to sit there with their families and go back without treatment. That is Grace Hospital. And patients were upset. Some of them are dying now, but we're still talking about them. Thank you.
Okay, Honorable Shengwa, let me first of all say that I think the issue of Ms. Tole is something that maybe I will have to look into. If you can provide us with an email address, and I'll get I think members of my team to get into that. The issue of oncology in KZN is not something I'm aware of, but let's remember that at some point or another, KZN had a health ombud in the province. And every time I received complaint from KZN, I had to go back to the KZN health ombud to ensure that I don't cross boundaries and assume that everything must come directly to my office. So I have not been aware of the cancer issue in KZN, and I can follow that up and come back to you with a reasonable explanation. But at the moment, as I say, I apologize, I'm not aware of it, But just do bear in mind that KZN did have a provincial health ombud to look after some of these issues. And we always went through him, it was a him, to make sure that, as I say, we don't duplicate work and we investigate things, I think, in a smart way. My apologies again. Thank you. I think it's now the turn for Dr. Jacobs.
Yes, thank you, Prof. So, Prof, I'm just going to mention a couple of things and not necessarily everything that you will respond to, but it's entirely up to you. One is I'm very happy that there's been great progress with the development of the bill. I think it's going to resolve many issues, and that you've had assistance from the department, the minister, and Dr. Crisp. Second one is, it's good to hear that your complaints and assessment unit does so well to have 97% of cases resolved. It speaks much of the approach that you and your team has to try and sort out the challenges which people are having. And then the fact that you use experts in the field, if we understand the court processes, it's a question lawyers like to ask, is this your field of expertise? Are you an expert on the field? Those kind of things. So I'm very happy that you're mindful on that. You bring in the necessary people, if it's depending on which discipline in medicine or healthcare that the question is about. And then your strong support for the National Health Insurance is noted. Your experience that you've had having visited the UK, your own experience in medicine itself, even as the Vice Chancellor of UKZN before, you have tremendous experience and understanding of health and healthcare and the plight of our people and the need of our people to be able to access quality healthcare at the nearest point of care, closer to them. And so, those words, and I'm going to quote you where you say that NHI is a new strategy of government and we must all support it. And also bringing it into relation to the fact that there was no money available in many of these countries who started it, and that we must embark on this journey. It's not going to be an easy journey. It's going to have its challenges, but I think in all fairness to all of the citizens of South Africa, we owe everybody an opportunity to have better healthcare. Ultimately, for all of us, it's about how healthy we are in order for us to be economically active and take care of our families. And then on the many provincial visits you made, it's been mentioned by the others, your frank and open, I mentioned it also earlier, frank and open discussion that you're having with us. I note in particular the medical legal claims, and we've had a presentation on that from the AG of South Africa. And it is a big challenge, and it is something that I have constantly in my head asking myself, where is the problem? Why is it that we have all these claims? I raised it yesterday that we have the victims, and the victims are those who are affected in their lives and the ability to have quality lives because of whatever goes wrong in the process. But we need to be able to diagnose it. We need to be able to pinpoint it, put our finger on it, address it, and improve on it. And that is really, from my perspective, it's something that I am very keen on doing. I've expressed that with our portfolio committee. We will have a special portfolio committee just to look at medical legal challenges. And anybody else listening out there, if you're an expert on this field, we'd invite you to write to us. So it's something that I, as the chairperson of the portfolio committee, would like to have a look at and to see how these can be addressed. For example, we had a training program called ESMO-E, and you might remember Essential Steps in the Management of Obstetric Emergencies, which there was a training program for doctors, and it was run by Dr. Bob Patterson and the team. And it seemed at that time to have a good effect. I don't know whether it is still being, that program is still running, and that's just in how to handle obstetric or deliveries and postnatal care to the babies. So you know, it's I think just one thing that comes to mind. But if you have any thoughts about it, I'd be very happy to hear from you. And then one point that you raised, that the portfolio committee should visit the hospitals in the Bay, in the Eastern Cape. It is something that we've been talking about. We will do now, but our programs have not been such that it was quite easy, and we might have to do this over a weekend, honorable members. So some of those things, Prof, if you want to talk about it, you're welcome. Thank you.
Thank you, Dr. Jacobs and honorable members. I think I did not answer honorable member Clark's one question about the backlog and whether we have any plans, I think, to deal with that. And maybe I should deal with that now before I comment finally. Honorable Clark, we do have backlogs, I think, that are located in the investigative units. And this often involves, I think, cases that are historic. They've been there for a long time, but also is compounded by the fact that we have only about 3 investigators in this unit. And on the whole, in medical or health-related investigations are complex and protracted. They take a long time because, let me give you a very simple example. In the investigation of the Tembisa Shonisani Litole case, we had to do 113 interviews in order to piece the whole issue together. 113. And in the process of that, you will have letters and responses. So investigations of high risk matters related to health, compounded by the fact that you know that your reports are subject to court reviews, court challenges, require that I think we're all careful and do them properly. Yes, I think there is a concerted effort. In fact, I think since we were provided with some additional funds, I think we've been able to acquire a few, 2 or more other people that assist the investigation units in order to address this matter. I just thought that I should clear that up. It is not out of lack of trying, but it's out of lack of capacity and out of lack of funds, but also the complexity and the nature of the court challenges that we have to face. I can't recall, since I've been here, there has been no court challenge to what the OHSC does, but every time we have an investigation in the OHO, we know that we have got to have some lawyers around to make sure that we write, I think, reports that are legally tight, and but that are factually correct and have no agendas, and we are not angry with anybody who brings a complaint to us, and we can't have agendas against such people. Finally, Dr. Jacobs, I want to give you another quotation maybe for the future. You know, human beings are not born with money, but human beings are born with brains and a mind. So great nations succeed and fail not because of money, but because they lack ideas and they don't use their minds as best as they can. I think this brings me to the challenge of the NHI, as I indicated. When the UK went into this in the early 40s, they had no money, but they had ideas and they had a passion that they wanted to lay a foundation for a future society that would depend on this so-called NHS. They have done it for the past 70 years. No matter what problems they've encountered, they've regarded this as their loads are, something that they will carry on, they will suffer for, but they'll make sure that it does happen. And this is something that I think we need to learn, if we are to learn anything from people in the UK, that it is great ideas and the passion to pursue those ideas that will deliver the NHI. I think on that note, again, I want to thank this committee for the engagements we have had. As I've said, I've got 3 or 4 other colleagues here that may want to comment on 1 or 2 things. If it's not overbearing, I would ask that they are given a chance to make 1 or 2 points. I think there is Dr. Jacobs. I think he was there in the morning, and there is Mr. Douglas, who can comment about the issue of what the Gauteng department is doing with the other people in the Tembisa case. And there is Ms. Helen Petuana. So they can just be given a few minutes to comment, and we should close this matter. Thank you very much again.
Thank you very much. They welcome, Prof.
I will ask Dr. Jacobs, if you are around, can you make 1 or 2 comments?
Thank you very much, Prof. And thank you to the chair of the Parliamentary Portfolio Committee. I was with you this morning, so I think I have addressed many of the questions and the comments from honorable members in the morning. I would like to just make a comment about what you said earlier about the program looking at SMOE for the alleviation of maternal deaths, particularly in the intrapartum period. That program was a very useful program. I unfortunately do not believe it is in existence any longer. And really just to share with the committee that we are having a large number of complaints which we categorize as high risk and extreme risk complaints regarding maternal deaths. Thank you.
Douglas? Douglas, are you around?
Yeah, yes, Prof. Thank you, Prof. Good afternoon, Honorable Chair and honorable members. Maybe to add on what Prof has already, answered the question raised by Honorable Ismail concerning the update with regards to the progress on the from the Department of from Gauteng Provincial Department regarding the 18 staff members that have been recommended for disciplinary action. The department, the report that we got from the provincial department is that the department has instituted or rather drafted charges against the staff members for misconduct, and that matter is still ongoing. And those staff members have to appear before the disciplinary hearing for misconduct. And again, the department has also instituted summons, civil litigation through summons for medical negligence against other staff members. So that matter is handled by the state attorney, assisting the provincial department. So yeah, that is that from my side as far as the progress report is concerned. Thank you, Prof, and thank you, Honorable Chair.
Thank you, Douglas. Helen, any comments?
Thank you so much, Chair and honorable members. Prof, I just wanted to make an input on the breakdown of complaints that we have investigated and resolved. Just to indicate to honorable members to say that the breakdown is reflected on the annual report on page 8 to page 10,
we try to indicate the discipline of complaints that we have investigated and we have resolved. So I think it will assist a great deal because we also have reflected on the various provinces that we have investigated and resolved their matters. Thank you so much.
Thank you, Chair and honorable members. I think that is our report, and as I say, I think it should be read in conjunction with the report that you have heard from the OHSC this morning, and it is our 2021-22 report, and we appreciate all the insights that you have provided, and we will be in touch whenever it becomes necessary. Thank you again, Chair.
Thank you very much, Professor, and to your team. And please ensure that we do receive the report. I cannot remember having seen it. So we're looking forward for it to be shared with us. And
Sorry,
thank you. You're welcome to stay.
Yeah, I did raise my hand.
Wilson, I'm not keen on the follow-up. I'll give you one minute because we need to move on. We've invited the other presenters a bit earlier, and I do not really want to be unfair to them. 1 minute to you.
Okay, it will take me 30 seconds. Professor McCarver, you talked about backlogs, and we talked about specifically backlogs of the cases that you're investigating. But one of the things that came up in the report that we saw last week was the backlog of surgeries and the tremendous impact that the backlog of those surgeries are having on people who are in pain and agony, who can't get orthopedics. Can you just give us a comment if you have been asked to be involved in that and what the situation there is? Thank you.
I have not been involved in those backlogs as far as I am aware.
Thank you for the short reply. So, Prof, you're welcome. You and your team to stay on should you want to. We're going to move on to the CCOD. Professor Dr. Barry Kisnasamy is already on the platform. Do you have any closing remarks shortly?
No, just give my regards to Barry Kisnasamy. He and I come a long way in the struggle and in medicine, but give him my regards.
Thank you, I'll do so. Dr. Barry Kisnasamy, you're up next. You can please show yourself and start speaking and just tell us who you have brought along to this meeting today. You do know that this is a portfolio committee meeting, portfolio committee on health meeting, and we're receiving reports towards our process of the PRRR. Thank you.
Thanks, Chair, and really appreciate Prof. Makoba's leadership and guidance. He was ahead of us in medical school, and thanks for his closing remarks and the tremendous work he's done in terms of the independence of his office and the inputs he's made. Well, let me go on to our presentation. Chair and honorable members and colleagues. Chair, is my presentation being seen?
Yes, it is.
Thanks. So, Chair, with your indulgence, we've invited, well, I've got members of the MBOD, CCOD, the partners from Minerals Council that have assisted us, the stakeholders that have come with us on this 10-year journey of, which has just been a tremendous issue about really sorting out the past and going forward. In terms of the mine workers that built the economy of this country and in its wake suffered both economically and medically in terms of it. But someday, we'll speak about that, and I've made previous presentations. Chair, I just need advice. We are presenting 4 annual reports. So I'm doing an overview slide, and then you can guide us as to how you want us to take 18, 19, 19, 20, 20, 21, and 21, 22. I will beg your indulgence to say, could we just do the 21-22? And then I need to conclude with a very important update we've done on an integrated reference database. So that's the presentation this afternoon. But you'd guide. I mean, a lot of the issues in the 21-22 would have been covered from earlier presentations, but you could guide me on that depending on the time constraints faced. I know you've had a long 2 days.
Yes, thank you, Dr. Krishna Sami. I think this portfolio committee has been with you for a while, and we've seen the progress that you have made steadily towards completing the outstanding financial audits and statements, and you've come to the point where you are now. So we'll continue with 21-22. If you need to make a short reference back to any of the other years, I think that should suffice for us for now. And also, secondly, you would have to tell us about this name, because we saw something on the AESA report that spoke about a different name. Before you continue, so that we know you are the commissioner, but you just need to inform us, and also remind me towards the end of that presentation that you want to make on what did you call that earlier? I think it's your system that you have in place.
The
So
integrated database. The integrated database.
Yes, thank you. All right,
thanks, Chair.
2021, 2022. Thank you, and the rest that I asked you to do. Thanks.
Okay, thanks, Chair, and really appreciate. In terms of the group that's here, as I said, we also have some of the trusts that are present. Asbestos Relief Trust, Quebec Trust, Kalakadi Relief Trust. These were Settlement Trust and Shemiso Trust. And then colleagues internationally that are joining us from Canada and the Asian Development Bank. So, but we do appreciate, because this has been tremendous, and I'll be speaking to some of the inputs that colleagues have made along the way. Firstly, thanks to the Portfolio Committee for guidance and support on a difficult journey. Some members might be old enough to remember when I started in 2012. My first presentation to the Portfolio Committee at that stage, post the previous commissioner, was the legacy problem of neglect, both by, in terms of the past. I mean, this is the Medical Bureau, a public works building in Braamfontein, the lifts, files, that each file represents a claim. We had to reorganize that. The telephone system didn't work, and of course the building. But what have we done? So this is the 4-year overview, which I'm sure members have read, but this is summarized. Well, we had tremendous support from the Minerals Council, South Africa, and social partners, historically World Bank, Global Fund, University of British Columbia, University of Cape Town, Witwatersrand University, and so both academic research partners, developmental agencies that really assisted us, notwithstanding the voted funds. Firstly, we've had approvals of actuarial valuation reports, which was fundamental to the fund. And that reminds me then about your question about, am I legitimately in front of you? So we had a discussion between the Auditor General, and I sat in partly on the Auditor General's report to Parliament, to your office, to the committee yesterday, where they've mentioned that they audit the Mines and Works Compensation Fund. So in terms of the Act, the Mines and Works Compensation Fund is a fund that's separate. It is an unlisted public entity, which we've been discussing with National Treasury. And essentially all the background work has been done by the officials in National Treasury to list the unlisted public entity. So that's the Mines and Works Compensation Fund. The CCOD administers the Mines and Works Compensation Fund. So we are civil servants in terms of the split. Medical Bureau for Occupational Diseases, led by Dr. Machali and Dr. Rabada. They do the medical assessment side, and then once somebody is found to be eligible, they pass it on to my office, and my side does the payments. So we administer the fund, and therefore Auditor General had made it quite clear that because it's an unlisted public entity, they've only worked under the auspices of the Occupational Diseases, Mines and Works Act, and some overlapping legislation under the Public Finance Management Act in terms of auditing that fund. And because it's an unlisted public entity, they did not audit the report, the performance report. So, fortunately, we do have members of the Audit and Risk Committee also present, and I really want to acknowledge their support for the process to date. And there's an internal audit process as well as there that looks at some of the performance indicators, and notwithstanding a governance structure, the Audit and Risk Committee that oversees some of that. So that's the whole issue around this kamors, using the good Afrikaans word of what we inherited into the process. But we are legitimately in front of you, Chair, and I hope you'll just allow me to continue in terms of our reports to Parliament. Then we've got where we've come from, the audit of the annual reports and financial statements. So members would recall in 2012, we had 6 years of disclaimers. We then in the 2012-13 year moved to a qualified audit on revenue. So we were cleared on the payments, but subsequently, this is the 18-19, we had presented the previous reports to Parliament. So it was a qualification on revenue. 1920, we had an unqualified report with just some findings. 2021, unqualified. And these were transversal reports mainly. It was related to information technology and one or two other issues which we've discussed with the Office of the DG. And the good news, Chair, is that 21-22, we have an unqualified audit in Auditor General's term with no material findings. In inverted commas, a clean audit. So it took us 10 years, but we appreciate that. In the meantime, of course, we have done tremendous innovations in service delivery, sorted out a database, which we'll demonstrate to you, sorted out service delivery announcements, reduced the levy, and really been out there in terms of working in terms of interventions for the group of people that actually built this economy. So we work closely with the Class Action Settlement Trust. Some of them are present at this Portfolio Committee hearing. Other social protection funds, which are also present here, Mine Workers Provident Fund, UBank, which also has unclaimed funds, which used to be called the Table Bank or Bank for the Mine Workers. We're also working with the banks, Capitec Bank, ABSA Bank, etc., working very closely with provincial and neighboring country governments. Some of them might be present here as well, particularly the Eastern Cape and Northwest, where we kicked up substantive interventions. And then, of course, Mozambique, Lesotho, etc. And members would recall 1/3 of the ex-mine workers are in the Eastern Cape, 1/3 are in Lesotho and Mozambique. Of course, we did have issues in terms of the COVID-19 pandemic that affected the back office activities, where we had to stop certain activities, albeit we did put in remote working processes. And of course, we're dealing also with the same constituency above 60-year-olds in the main, and our services benefit medical examinations, where you had to convene workers, ex-mine workers, to come to come to a service point, St. Elizabeth Hospital, Freya Hospital, Rustenburg, Shashai, Mafeteng. We couldn't bring them together at that stage. And also the big issue, we have to provide lung function tests as part of the impairment, and of course with COVID-19. So COVID did affect some of our back office activities and then the service delivery. So what have we done? So we certified 56,000 claims. We paid approximately 40,000 claims, and this was 50% of claims finalized in this last 4-year period compared to 80,000 over 23 years. We paid benefits amounting to about R1 billion, and we also increased the benefits in 2018-19. We collected levies, 443 million, including a levy correction in 2018-19, which, and I'll show you a slide which shows how the drop in levy has been quite substantive. We inspected 467 mines, and you will allow me about 3 minutes at the end for Andre Fourie to show you the integrated database, which is now web-based, and we'll speak to a bit more about it. We introduced an electronic compensation claims management system, so we're doing away with paper-based systems. We have a functional call center, which I hope members will test, and we are also on the website of the National Department of Health. So these are certifications that have been done. We think we have reached a peak in the 2018, 2019, 2020 period. Of course, there were some issues and there was a backlog which we helped to clear in 2021, which Dr. Machali and Dr. Rabada helped together with the certification committee doctors, and then the drop that's coming in terms of 2022. In terms of claim finalized, these were the number of claims finalized over this period, including the value, and this amounts to the 900, the 40 plus minus 40,000 claims finalized, and approximately 1 billion paid out. This is the levy correction which was done in 2018, began in 1st April 2019, and you can see the drop for the gold mining industry. So while we've had strong links with the gold mining industry, we hope that they appreciate that their interventions with us in terms of secondments, technical support and outreach activities, and improving financial management systems led by Kat van Eden and Mishak Maswangani, actually did a correction, proper actuarial valuations, and gold virtually halved from 180 rand per 180 million to approximately settling around about 100 million now per annum. So, and overall, similarly for platinum, similarly for coal. We didn't put all the inputs in, chrome, manganese, etc., but it's just giving you an example. These are what took us out of the qualification on revenue. This is the percentage mines and works paying levies, and you can see the tremendous push that we instituted since the last year. We couldn't inspect some of the mines in over the 2020-2021 period because of, again, COVID and work. But once the lockdowns were lifted and the mining companies came back into full steam, this was the major push. 83% of the mines now being inspected. So some of the highlights, we managed to get silicosis, mine workers and TB onto the agenda of the UN High-Level Declaration on TB. This is President Ramaphosa addressing the UN Special General Assembly. And we also had a BRICS side event addressed by Minister Motsoaledi at that stage. And one of the big issues is in ending TB, mine workers in particular, and Patrick Osewa, I'm not too sure if he's online, led the big team when he was still at the World Bank, in the World Bank office in South Africa, where we spent a lot of time on TB in mine workers and mine workers as a vulnerable group in terms of TB. President Dr. Jim Yong Kim visited us in December 2018, the president of the World Bank. And again, you know, tremendous success story about the interventions we had made and changing the lives and livelihoods of our people on the ground in terms of the cash transfers that we are doing in rural areas of Mozambique, rural areas of Lesotho, rural areas of Eastern Cape, where ex-migrant workers were now going back to. Of course, the big issue was the silicosis settlement of 5 billion in 2019, which we helped to put together. And of course, there are colleagues here from the mining companies and also from the Shiamiso Trust who are present. And then led by University of British Columbia, who are present, Prof. Annalie Yassi and Prof. Jerry Spiegel, Prof. Rodney Ehrlich from University of Cape Town, and Dr. Warwick Sief from University of Witwatersrand, was a tremendous work we've done on computer-aided diagnostics and the fourth industrial revolution, and work that's being done now on operational efficiency gains. So notwithstanding our service delivery, we still concentrated on policy interventions, multilateral interventions, and then also interventions on the class action and other settlement processes. So let me just digress a bit. This is the 10 billion rands due to mine workers. From compensation, my fund, 1 billion due, class action settlements around 4.5 billion, pension and provident funds 4 billion, etc., etc. Members of the portfolio committee should know about the TEBA deferred pay. For those members that come from the Eastern Cape, I suggested to the Premier of the Eastern Cape that there should be a special plaque at the Amtata airport celebrating the contribution of the mine workers from the Eastern Cape that paid for the terminal building at the then Kaiser Matanzima airport. This was from the deferred payment interest that should have been paid to the mine workers when they returned back to the Eastern Cape. But there was so much money in that fund that they actually paid for the airport. Members have gone through the NHLS input. We also discovered in 1912, the SAIMR building in Braamfontein was also paid for by the mine workers. So the mine workers' monies paid for it, not the Chamber of Mines. The mine workers' money, salaries paid for the airport in Amtata, not the Minerals Council. So these are interesting things which we'll have to pick up at a later stage. So let's look at the unpaid funds in which we are going to concentrate now that we've got maintenance work to do in the MBOD, CCOD. 60,000 of these claims are before the year. Oh, my presentation. Chair, is my presentation still showing? Chair?
No, we can see you now.
Yeah, no, it's not showing, Chair.
Okay, let me just, I think something, let's go back.
Maybe you're talking too fast for your presentation. I can't keep up with you.
No, the host disabled participant sharing.
Oh my goodness. Yes, we've lost our secretary due to the load shedding.
I've enabled Dr. Kitnasamy again.
Thank you.
So it was sabotage, Chair, on your side, not my side.
That's fine. They're not your fast speeches. Please carry on.
No, I'm joking. Load shedding affects all of us, thanks to the parliamentary secretary. Chair, is it showing?
Yes, it is. Just, yes.
So this is the unpaid claims, and we've got to do some major work with about 60,500 are from before the year 2005. These are certified claims that's due a payment, and we have to now go and find them. And part of the issue related to this is that many of them would have died in rural areas, and we've now got to get into the hospital records-based database, the EVDS database, etc. But we can talk about that later on. This is the Mine Workers Provident Fund. I talked about the 4 billion because there are other funds due to mine workers, Sentinel Fund, 1970s Fund, etc. But 3 billion is sitting in the Mine Workers Provident Fund. If you just look at the Eastern Cape, 306 million. So these are pensions due to mine workers right now, if we can find them. 4,000 mine workers are due 306 million. Mozambique, 3,500 mine workers, 3,300 due 300 million. What this does to one of the poorest countries in the world is that it makes a big difference in their lives. So we took one of the mining companies, and thanks to the colleagues in that one major mining company, we won't mention the name. We ran it against our database. We discovered there were 6 ex-mine workers who are due over 1 million rand each from their pension fund of that big mining company. Approximately 30 of them are due the equivalent of greater than 500,000 rands each. So this is the work we are doing, Chair, in terms of the process. Let me look at a concept called stranded assets. And there are colleagues here who are working very closely with us from Project Pakelwa, that there's 120 billion. So I talked about the 10 billion due to mine workers. Overall, there's 120 billion due to our people in Southern Africa from unpaid pension funds, banks, Guardians Fund, Class Action Settlement Fund, the Stock Exchange, Johannesburg Stock Exchange has got a whole lot of BE deals that they've done. They can't track the people who are recipients of those shares and the payments, insurance policies. So overall, this amounts to about 120 billion. We're probably looking at about 150 billion that's due to our people. This is money sitting in Santon in a bank account. Of course, sometimes we are naughty and we steal the money. But in general, the process is that we've got to do a lot of more work on this. So we think we have perfected a model. We're still learning, but we perfected a model with the compensation fund of delivering our agenda, and we can move forward in this wider agenda. And Chair, hopefully at some stage you will speak in your remarks about the inter-portfolio committee that you will be convening. Well, what are the challenges? Of course, I talked about the buildings problems and then facilities in Eastern Cape, Gauteng, Limpopo, neighboring countries, the one-stop service centers, as we called it. We are getting increasing requests from provinces, neighboring countries. I don't know if Dr. Dlomo has joined, but Dr. Dlomo is leading a major initiative, and we were in Mozambique in May this year. And as we've increased the communications and linkages, we've had a lot of requests in terms of service delivery. Of course, we've got to upskill our human resources in terms of new technology, paperless systems, etc. And just to note that the governance committees are functional other than the risk committee, and really special acknowledgement of the audit and risk committee. So where we're going forward on is the amendment to the Occupational Diseases and Mines and Works Act. The draft bill is ready. Preliminary consultations have taken place. We've done the socioeconomic assessment study. We're due to meet the presidency next week. We've met the state law advisor, and hopefully, Chair, we're really pleading if this can see the light of day in next year's parliamentary session. Minister has already written to the Deputy President of that. Of course, we think we've delivered the agenda on models for service delivery. We need additional funding. We've made a special request to National Treasury, and hopefully that will be looked at positively. We've had very little increase in voted funds, and currently the Minerals Council South Africa, and prior to that the Gold Working Group, helped us with a voluntary levy in terms of support for the work at the MBOD CCOD. And of course, we should prevent the workers from getting these dust diseases. It's really a sad indictment. And I pointed out to you in Australia, they had 16 cases of coal workers pneumoconiosis, and they had a Senate inquiry. And, you know, I pick up 1,000 cases per annum in terms of different occupational lung diseases. and then we're quite busy with the legal reform processes. So just to acknowledge many of the colleagues who are here, there are also trade union members that are present here, Minerals Council members, and a special thanks to Mr. Cutler for his guidance and advice. I came in quite new into this portfolio, and he often reminded me of the annual reports, the APP, the strategic plan, and whenever you called us to report, Chair, or your predecessors in terms of this process. So, Chair, that's the overview. I'm quickly, if you, with your indulgence, going to go to the 2021 report, and then, so let's share. So this is not the correct one. Stop share. This is the Mindworkers database. I got to find the correct screen now. So, Chair, while I'm looking at that, let me just quickly do the Mindworkers Provident Fund, and then I'll hand over to Andre, and then I'll quickly come back to that while I find the 2021 slides. So this is the Mindworkers database, which is a very important innovation. I take it's showing. So we've now got an integrated Mindworkers database, which we spoke to you all about previously in the portfolio committee. The data is hosted and owned by the National Department of Health, and you can only access the database on the web through approval by the Commissioner. So this is the records that we have in the integrated database. 2.3 million records are currently in the database. We have, of course, our records from the MBOD CCOD. We have the CMSO Trust records. We have the National Department of Health patient registration data. We have the Mindworkers Provident Fund database. We have UBank, Eastern Cape Provincial Department, provincial hospitals. We're now talking to Northwest and some of the other provinces, Capitec Bank, and the Sentinel Pension Fund. So this gives us tremendous outreach in terms of unpaid claims. It's a web-based tool, which we're also quite happy to make available to constituency officers, etc. It's available to all stakeholders in terms of approvals. And this is the database itself in terms of the process. I'm just going to hand over to Chair. I see a hand from Ms. Wilson, Honorary Wilson.
Honorable Wilson, I think that's just a hand to indicate she'll ask a question later. Am I right, Honorable Wilson? The hand has been there a long time. Continue, Dr. Kisner-San.
Okay, sorry, Chair. So this is the 21-22 annual report, which basically covers the past as well. So as I pointed out, it's an unqualified opinion, no material findings. Mishak, if you're on the line, if you want to quickly take us through this slide through you, Chair, to Mishak Masangani. This is the voted funds expenditure, and I need to bring in the Director of Finance who talks about the voted funds. Mishak?
Okay, thank you, and good afternoon, Chairperson, honorable members of the Portfolio Committee, and then guests and colleagues. So I'll be presenting the voted funds financial report. So this is the voted funds actual expenditure for a 3-year period. So for 2020 financial year, our total spending was 65 million. For 2021, our total spending was 60 million rands. For 2022, our total spending was 59 million rands. So in addition to that, in the current financial year, we've been allocated a total budget of 63 million rands. And next slide, please. Okay, so this is the voted funds actual versus budgeted expenditure for the financial year 2022. So under composition of employees, our total spending was 34.9 million rands. which is 96% spending. Under goods and services, our total expenditure was 22.9 million rands, which resulted to 118% spending. So there we've got an over expenditure of 18%, which was as a result of the payment of a COVID-19 quarantine sites. So under transfers, this is the money that we receive from the National Department of Health for the payment of the monthly pensions coming from the old Act. So there we've got 100%. So under capital expenditure, we had no spending during 2022 financial year. So the no spending was as a result of the carryover into a new financial year of the procurement of the office computer equipment. So overall, our total spending was 59 million out of 60 million budget that we received from the National Department of Health. So that resulted to 98%. That is considered as a reasonable spending. I will end there and hand over to Mr. Adrian Mallet to present the financials of the compensation fund. Thank you.
Through you, Chair, to Mr. Mallet on the compensation fund financials. Mr. Mallet.
Thanks, Dr. Krishnaswamy. Afternoon, Honourable Chair, and with all the other protocols observed. This is the slide on the financial performance of the Mines and Works Compensation Fund for the 4 years ending 2022. The tax levy revenue at the top is the levies that are contributed by the Mines and Works for the risk stripped works. The numbers are fairly stable for the 3 years ending 2021, and then an increase as we moved into the 2022 financial year and coming out of the COVID period. The Mines and Works contributed more in terms of the number of risk strips that were worked. The non-tax or interest revenue is the interest earned on the funds invested. The decrease in the returns is due to the drop in the interest rates on the investment earns, not on the capital balances. And this is in line with the reduction in interest rates over the COVID period as announced by the Reserve Bank. The other income needs to be read in conjunction with the expenses line, which covers the movement in the actuarial valuation and the long-term provisions and short-term provisions that have been calculated by the external actuaries. The 85 million in the 2022 year is a release of that provision other than the unwinding cost. The expenses of 271 million in the 22 financial year represents interest on the unwinding of the provision as each additional year of interest is incurred. Can you next slide, please, Dr. Krishnaswamy? This represents the financial position of the Mines and Works Compensation Fund for the 4 years. The investment balances increased largely with interest earned over the years. The fund is in an accumulated surplus position over the 4 years, which supports the going concern assumption adopted in the financial statements. And the provisions have been shown no material movements and are currently sitting at a combined 3.4 billion for both the current benefits due and long-term incurred but not yet reported provision. Next slide, please. This represents the budget for the next 3 years, with the 2022 numbers being actual. There are no significant revenue increases forecast. The increase is driven by increase in the levy rates, which are determined annually by the external actuarial valuators. The interest revenue is expected to increase in line with the increase in interest rates and the growing investment balances over the forecast period. No material other income or releases in the provision are forecast over the next 3 years. The expenses are forecast to increase to 512 million, which is a combination of the unwinding costs plus additional charges to the long-term provision. And then this is the last slide, which is the forecast balance sheet position or statement of financial position for the 3 forecast years. Investments are expected to grow with interest earned over the investment period. The fund is expected to remain in an accumulated surplus position over the 3-year period with no expected going concern issues. And then the provisions are forecast to increase to roughly 4.3 billion by 2025. This is in line again with the discounting charge on the provision. Thank you. Now, over to Dr. Kishnasamy, who will talk on the performance objectives.
So these are the concluding, thanks, Mr. Mallet. These are the concluding performance indicators, Chair, in terms of the APP. I talked firstly about the Odumwa legislative changes, and hopefully it will see the light of day in terms of the Section 3A entity. The master database, if you will just allow 3 minutes at the end of my presentation for Andre to present the integrated database. And this is amazing that you can now look up in Shashai, Inambani, Amzimkulu, Kailicha, constituency offices, local government offices provided, and look up the tool in terms of multiple claims that individuals will have. I did point out in terms of the performance indicators that we had a drop, but we think we reached a peak, and unless we do something more about the unpaid claims, mainly from before 2005, we're not going to reach some of the targets in terms of this. So these were the certifications and the benefit payments. And then claims finalized either than pensioners. And then National Treasury asked us to put in a tracking tool about claims being finalized month 1. A claim is lodged. Month 2, the claim is certified, and month 3, if eligible, it's paid. So, and we managed to do this in terms of all documentation, 90% performance achievement. We had a lower target base, we were not too sure, but this also is assisted by the electronic compensation claims management system. This was the big ticket item that got us out of the revenue qualification to a clean audit, where 83% of controlled mines and works are now paying levies. And then, of course, we came up to date with all of our financial statements to Parliament and the Auditor General. And this was the major push we made over the last year of inspecting 139 mines, which was an indication. So, Chair, I'm just going to hand over. I know it's been long. Andre, I'm going to stop sharing. If Andre Fourie can just demonstrate the tool, Chair, and then we will hand back to you. Through you, Chair, to Mr. Fourie. You will need sharing rights. Andre Fourie.
Thank you, Dr. Kishnasamy, Chair, and honourable members of the committee. If I can maybe just get sharing rights, and I'll quickly open and demonstrate the database for you.
Ngubane, please attend to that.
I think it's working now. Thank you very much, Chair. And thank you very much. This is the reference database of all the mine worker unclaimed benefits. And it is hosted on the Department of Health infrastructure. So all the other health websites in the Microsoft Azure cloud platform. So you'll land on this page. Just to comment, this data that I'm going to show you has been anonymized. So this is not a live database, just a demonstration database. So I'm just going to log in here. So you take it to this landing page. We can now search for any mine worker on this database. You can search for ID number, passport number, surname, if you want to. So I'm just going to put in the surname there. And it will give you like the top 10 matches for your search criteria, ranked by highest matching score to the lowest matching score. So if you look at this first individual here, Vincent Strancha Muketsi. So if I go into his detail, here to there, then you'll see that here it shows you on the top, it shows you all his demographic info, his ID number, passport number, etc., where he lives, and his cell phone number. And there at the bottom here, with the benefits overview, it will actually show you all of his unclaimed benefits, as well as his engagement with the mine working, tracking and tracing third party, the project partners that's involved with this project. So immediately you can see that this individual on the 17th of February actually visited the National Department of Health clinic, Mtambela Clinic. We also know for a fact that he's got an active Capitec bank account due to the data that was shared with us with Capitec Bank. We know he's got a Ubank unclaimed benefit, and we also know that he's in the Tiamisa Trust world, so he's got a record of service with the trust, so he's due examination and potential benefit there as well. We know that he's got a CCOD second degree unpaid claim, so you're looking at approximately 100,000 rand benefit there. And we know that he was already paid a smaller loss of earnings claim in the CCID back in 2013. So that's just your benefit overview. So then the idea is, once you make you get this person in front of you, so if anyone has access to this person, they're going to go into this screen. You're able to update his contact information and put any comments in here for the next person that might also be wondering. So if I'm just going to update his industry number, for example, I can say that he's maybe no longer in, I saw him in Gauteng, maybe like update the district, Ekurhuleni, pick a town where I saw him, since I saw him in the city of Ekurhuleni, and I can just say, I saw this individual 22, 10, 12. Then if I update this info, then you'll see here at the bottom now, it tells the other people that are also looking at this database that this user, just a test user that I was using, actually saw this individual on this date. Then what will happen is the system will automatically email all the project partners that there's benefits due to this individual. So UBank will get a notification, Tembisa Trust will get a notification, and the CCID will get a notification. This person was contacted and he's got benefits due. And so the idea is then to expedite the tracking and tracing and expedite payment. Okay, thank you very much. That's it from my side.
Chair, that was anonymized data. So just in terms of Poppy, by the way, we have spoken to the information regulator, but that was a dummy screen that that Andre showed. Chair, back to you. That concludes our presentation, the achievements, the challenges, and thanks to the Portfolio Committee for the support over the last 10 years. Over.
Thank you very much, Dr. Kisnasamy and the team for this presentation. Quite a number of things have been raised. We see a lot of progress having been made over the last number of years. And congratulations on receiving a clean audit. I will have some things I want to speak to later on after I've given the members an opportunity to raise their questions and concerns with you. Firstly, it's Honorable Clark, followed by Van Staden, and then Gela.
Sorry, Chair, I'm covered in this section. Thank you.
Thank you, Clark and Gela, in that order. Any other members? Kaba, and Munyai. So it is Clark, Gela, Kaba, Munyai. Thank you, in that order.
Thank you, Chairperson. Just a few questions I'd like to ask. In terms of the 120 billion rand owing to South Africans, can you please explain to me if any public awareness campaigns have been done in terms of this to try and trace people that these amounts are owing to, because it's a huge amount in terms of potential claims. And then also, can you just please tell me whether the compensation claims management system is internal or whether it's been outsourced? And then what is your current claims backlog currently? And then I didn't pick it up in the presentation, but you know, I acknowledge as a new member that where you've come from to now, that you're you guys are doing so much better. But could you please tell me whether what your fraud and corruption cases are like? Are there any outstanding disciplinaries? And in terms of those disciplinaries, are there any criminal cases that have been opened in terms of fraud and corruption? Thank you, Chairperson.
Thank you, Chairperson. Let me also welcome the report, the presentation. Yeah, it's a good presentation, but also depressing on the other side with the amount that is sitting there and people are not being paid yet, especially in these provinces. I will talk more about Eastern Cape. I think you know I'm always raising this when you are doing a presentation, it's because I know that there are still people who are not being paid so far, and the money is still there. Then the issue that also I want to raise, Chair, we welcome the outcomes of the audit generally, but also for the financial year 20 and 2021, the AG gave an unqualified audit opinion, but also some issues that I want clarity on. Chairperson, is that under the report itself, Chair, the material misstatement of contingent asset identified by the auditors in the submitted financial statement were corrected. But the other issue that I want to check, Chair, which we appreciate, but there's an issue of leadership, not or the leadership did not exercise oversight responsibility for the financial reporting and compliance, as well as related to internal control, which is something that was also raised. And also the other issue, it's an issue that I want to raise. Just hold on, Chair. I just want to check by when is the proposed amendment bill expected to be tabled in Parliament. And then the other one, Chair, is that you have conducted a survey. Let me phrase it to correct, Chair, sorry. The other issue, Chair, that I want to raise, Chairperson, is that has there been any update on the risk committee that was reported to be not functioning optimally? Those are my questions, Chairperson, that I wanted to raise. Lastly, Chair, the one that I was talking about is that has there been conducted any survey on its performance following the phasing in of its compensation claims management system? Is this done internally or outsourced? If I can just get the clarity on that. Thank you very much for the report. And I'm worried that the man was, Chairperson, think we need also to check actually and also get how far and what is the plan or how can we assist, because honestly, Chair, where I'm sitting, there's that outcry that the mines are still owing us. And also the other issue, I hope that you can also have something to prevent people not to get this disease. Thank you very much, Chairperson.
Thank you, Honorable Kaba, and then followed by Honorable Munyai.
Yeah, thank you, Chair. Chair, mine, I think it is with regard to mine's claims with respect to the tracking tool developed by Treasury. To say, Chair, in joining what Honorable Gela had just said, how do we then assist on such process and quicker? I know we are busy with NHI now, but it's quite very much important that we focus and have our people assisted better with regard to that mine chunk money that is laying there instead of assisting our people. I think as a portfolio, we are ready once guided. Thanks, Chair. That was my just question of clarity and input in terms of how are they proposing, then we'll decide. Thanks, Chair.
Honorable Munyai. Honorable Munyai, are you still on the platform? If not, Dr. Kisnasamy, thanks again for the presentation. Any other members? Now, we've heard a lot of things being said by you, Dr. Kisnasamy, and your team. And we have also had many presentations from you over the last couple of years. We have seen the progress that has been made in terms of the work that you put out with your team. And I also noticed the number of, the increase in the number of claims finalized from 6,155 to 7,700 this year. I think I see Honorable Munyai has raised his hands again, and I want to be the last actually to speak on this matter from us. So I'm going to allow Honorable Munyai first. Honorable Munyai.
Thank you, Honorable Chair. I'm just raising my hand because you know what? The load shedding just switched off all my system. May I please comment?
Yes, please do.
Hey, I'm so excited and I pride myself with Dr. Berry for the work and the team that they've made. This is one of the organizations that really pulled through. There are two clean audit, it's SAMRC and this organization. So we must really give credit to where it's due. At the beginning, the data was a mess at Bramfontein offices. You know, it was a paper, they digitalize, and they're embarking on a comprehensive campaign to go and look for the claimant, and they paid up some of them, and they crisscross the country, Mozambique, Lesotho, South Africa. So their work is quite hard work, but I'm very excited today, Honorable Chair, by the progress this organization has made. The challenges still remain to mobilize, to really find the claimants and also to support them. This is the key issue. So, Chairperson, today I don't have any drastic question for them, except to appreciate that their progress that they've made, and also internal controls and management of finances. This is the key issues. And I'm very excited about it, Honorable Chair. So I would be it would be very bad if I could not speak just to congratulate them. Where they've done well, we must give credit to where it's due. And I do it today on, on this platform, Chairperson. Thank you very much.
Thank you very much, Honorable Munyai. To carry on from where I was talking, Dr. Kisnasamy, also on your work of inspection of mines, I know there are a lot of challenges with decommissioned mines and the fact that you have to go and inspect them. And I'm hoping at some stage you'll be able to share some of those results with us. We have seen the incident of the Jagersfontein disaster, and we had a presentation from I think you were not on the platform, the SAMRC, speaking about the arsenic levels and the lead levels in the water, for example. So just in terms of that work also that you are doing, if you would at some stage maybe report to us. And then the advances which are made in reaching the people, the ex-mine workers especially, but also just staying in touch with the current mine workers and having an approach to that is quite essential, so that we do not go through a process again where we neglect people due to who are affected due to exposure to the various elements, being it mine dust, fungi, asbestos, not so much anymore, but still, whatever the causative effect could be, that people would know they'd be able to go somewhere and get answers to their questions. We still have people presenting with mesothelioma, pneumoconiosis, etc. And so the work that you're doing is very, very crucial. And secondly, also crucial to those who are affected while they're still alive, and of course to the beneficiaries of those who have passed on. And we would really want to encourage you to continue doing this work. From my side, I had written to some of the trusts in my capacity as the coordinator of the parliamentary working group. It was already in July of this year. And due to the parliamentary process, we've not been able to get this group together. And this group is a group that has to be comprised of the following portfolio committees. It's health, mineral resources and energy, employment and labor, appropriations, finance and justice. And we'd already reached out to them, and these portfolio committees need to come together as joint portfolio committees so that we can attend to the writing that I had done to the trust, and also the follow-up that they sent back to me, and also the support that you would be requiring in terms of the bill that you say has already been gone through a certain number of controls and looking at certain requirements. For example, the CIAS and having had discussions with the minister, etc., and those responsible in the National Department of Health. So I also want to congratulate you on the progress you've made with the draft bill on amendments to ODIMWA, and also on the mine workers database. It's impressive. It'd be good if people there would be a system through which people would be made aware of the database, of your call center, of the ICT program that you have, wherever people will be able to make contact with your team and be able to find out whether they are eligible for any of these funds. And very shockingly, when one looks at the amount of 120 billion rand in bank accounts, it certainly is what we would call a low-hanging fruit to improve the lives of people who are the actual beneficiaries of those funds. And we need to be able to expedite that. And surely whatever it is that we can do, we would have to do as a portfolio committee. And we would have to meet with those other committees as soon as possible. I think as soon as this process is done, it would be one of those things we would have to do. And I've also communicated earlier on something else that we do. So we have a number of tasks ahead of us as a portfolio committee, and this is one of those tasks. And then, Dr. Kishnasamy, if you were to give me in 5 lines what it is that we can do as a portfolio committee to assist you and your team, you're very welcome to maybe mention those. I think I've now mentioned one already, where we are looking at getting these portfolio committees together so that we are able to attend to the challenges. And justice specifically, because the trust apparently say they are only accountable to the master of the court. And it is surely something that we would then have to look to in terms of the law. and the application of that law as legislatures. So I will leave it over to you now, Dr. Krishnasamy. You've had some members giving some inputs. Thank you.
Thanks, Chair, for your comments, which I'll come to towards the end, and to the honourable members who did either in the chat. I think Honourable Munya and some of the others have mentioned congratulations. Let me start with Honourable Clark. The issue around the 120 billion is what we could track through Project Pakalwa. There are some colleagues here who, through the chair, if you'll allow, there's Rosemary Hunter, there's Ohsc Shezi, the former DG of Public Works. There are quite a few colleagues here who have begun to start working with us very closely on these unpaid funds. And it is a side indictment in terms of the process. Now, just to split it into three broad groupings, there are statutory funds which are regulated by law. You know, like my Act, Occupational Diseases, Mines and Works, Unemployment Insurance Fund through the Department of Employment and Labour. There's another compensation fund, QIDA, Compensation for Occupational Injuries and Diseases. Then you've got a whole lot of pension and provident funds through Fiscal, the Financial Sector Conduct Authority, which is managed through National Treasury. And then you've got this whole group of insurance and Johannesburg Stock Exchange, etc. So it's really one of the issues we are saying is that we think we've done a fair amount of work as the CCOD from a collapsed system to actually show that you can make a difference. You don't have to hide under POPI. You don't have to hide under the information regulator. In fact, they are an important player, and we should invite them, Honourable Chair, for the next meeting. If you know, in terms of the portfolio committee, inter-portfolio committee. But one of the big issues we've had with many of the funds, Honourable Clark, is they hide behind POPI. They say they can't give personal information, and that prevents people from tracking and tracing, etc. So we'd be quite keen as a Project Pakalwa team, depending on Honourable Jacobs had said, give him 3 points to talk to. And one of the issues would be about how do we unlock unpaid funds in terms of the database, tracking and tracing, unique service delivery, and ultimately paying our people across Southern Africa. Of course, there might be people also in England, United States, Philippines, etc. But generally, 90 to 95% of people are probably sitting in Shashai and Amzimkhulu, etc. So let's flag that. The Project Pakalwa people have, and they might want to comment depending on time from the chair about the public awareness. Public awareness has been very fragmented. When I first came to this portfolio, I discovered an advertorial or an advert in Business Day saying the following 20 people have an unpaid, unclaimed benefit. By the way, unpaid means that we haven't paid them. It's an active process from our part as the person who's holding the funds. Unclaimed means it's passive. That means Barry Krishnasamy has an unclaimed benefit. He has to find the truth. Unpaid is where we go and find Barry Krishnasamy and pay him his due, which is what we've done with our outreach activities. So you find an article in Business Day saying 10 people, please call. Unfortunately, Business Day is not read. I take it to a certain extent in Amzimkhulu or Shashai in Mozambique. So one of the issues we did, and working quite closely with the CMSO Trust, was actually outreach campaigns on the ground, community radio. We've been quite concerned about not releasing names. We've tended to go on targeted campaigns like we've done in the Eastern Cape, Northwest, etc. Next week, we'll be in Mafeking for a 1 week's delivery system, working with the Northwest provincial government. But we've tended not to give out names and details because, you know, of the other dynamics, that if somebody knows you've got money, you know, there could be other problems with it. So again, let's have a special discussion. Awareness campaigns have been, and tracking and tracing agents are, you know, many, they tend to go and do tracking and tracing. They get paid large sums of money, and there's been no delivery in many of these issues. Hence, you've got this 120 billion sitting, and hopefully through Honourable Jacobs's leadership, you know, we could bring that to Parliament again in a special sitting, together with National Treasury as well, and the Information Regulator, etc., and colleagues from Project Pakalwa. The CCMS is a compensation claims management system. It's we have a memorandum of understanding that signed off after the intervention of Minister Motsoaledi and the then DG Ms. Precious Motsotso for the mining industry to work with me. This goes back to 2012, 2013, where Minister Motsoaledi at that stage met with the captains of industry and the Chamber of Mines, the then Chamber of Mines and Minerals Council. Mr. Nix Lesufi is here, who heads this portfolio with Roger Baxter in the Chamber of Mines and Dr. Balfour. And essentially what's happened is that we requested support from the mining companies, and they've made available technical resources. So the compensation claims management system is under very strong governance, but it is an outsourced service. It's gone through all the checks and balances, including agreements, and it currently sits with one of the mining companies, and there might be some changeovers of ownership, etc. But it is an outsourced service paid for by the Minerals Council South Africa in our case. But we've checked it through in terms of our ICT policies, etc. But the database is held by the Department of Health. So the operating platform is outsourced, but the database is ours, and we have strong governance in place. And the payments for that is through the Minerals Council South Africa. Claims backlog. We do not have any claims backlog. That's the good news. But the key area is that there are people out there that needs benefit medical examinations to be done, and certifications and all of that. So we've had funding constraints in terms of the outreach activities, and hence our special request to National Treasury, which is going to be agenda item 4 for Honorable Dr. Jacobs towards the end, about the National Treasury support for the MBOD, CCOD, now that we've proven ourselves in a different way. We do have our unpaid claims, which I showed you, the plus minus 90,000 unpaid. We've tried our best to reach out, but we're going to need new ways of tracking and tracing, etc., in terms of process. So claims processing, we don't have a backlog, but we have to go now and look at new ways of actually reaching out to the 90,000, of which 66,000 are before the year 2005. Fraud and corruption, unfortunately, in a game that we are in terms of paying money, there is problems. There's been no losses to the fund per se, other than 1 or 2 where there's been payments made to the wrong person, and we've followed through with that. In terms of process, we had a significant input made by the Minerals Council and the previous gold working group on this area of work. Remember, this money comes from the mining sector, from the mining companies, and I raised with them at an early stage, how do we protect this investment? We grew the fund, by the way, from 2.8 billion in 2012 to 5 billion currently. And ultimately you saw in the MTEF, it'll be around 6 billion, notwithstanding payments and increase in benefits and reduced levies. But in terms of the issue around fraud, so we had a substantive issue. The fraud has been not fraud to the fund, but it's been touts with insider trading that gets to the individual on the ground. We can only pay into the bank account of the individual. The tout, some or the other, goes to the individual, and in especially a deceased case where they go to the spouse, the family, and say that they can facilitate the claim. They then organize the claims and the bank accounts, and ultimately we pay into the bank account, and then there are withdrawals. So it's not a claim on the fund, but it's actually stealing from the poor, and that's something. So we've got 3 cases registered in Limpopo, in Northwest, and in Gauteng. I've had discussions with the Hawks and the national, the NPA, but I guess with the backlogs, it's something that we have to resuscitate. The Audit and Risk Committee has asked about this, as well as the Auditor General in terms of the process. There are 2 or 3 insider trading collusion issues that are also being investigated by the SAPS at the Hillbrow office of SAPS. Given that we are based in Braamfontein. So that's what's happening in terms of that fund. We've tried to, overall, with the electronic systems, the proper database, the checks and balances that come in with very strong internal controls, hence the clean audit. Of course, it is a sample, so things might get missed. We've tried to actually circumvent many of these issues, and the public awareness campaigns, working with the Office of the Premier in the Eastern Cape, Office of the Premier in Northwest, working with the Ex-Mine Workers Association, very strong on the ground inputs. And to say to people overall that this is a free service and they should not be paying for anything. We worked very closely with the CMSO Trust, which has also emphasized that this is a free service. So that's Honorable Clark. Honorable Gela and Honorable Clark, thanks for your comments. Honorable Gela, I'm going to deal with the first comments and then ask Kat or Adrian to talk about the material misstatements. On the leadership issue, the Auditor General, you'll recall that we did not get our annual reports and audited financial statements in time to the Auditor General and subsequently to Parliament. We had to seek through the Minister permission from the Speaker of the National Assembly and the Minister of Finance to say that we won't be putting in our documents on time. So the exercise of leadership was in terms of the fact that we didn't put in our financials on time. The second issue on internal audit is a transversal issue. We've raised that with the Director General. The funding for internal audit, the funding for many of our ICT, information communication technology, the funding for human resources comes out of voted funds, and there are procurement processes in ABX building that actually have to manage this. And unfortunately, there were delays in the internal audit process. So these were really not the responsibility directly of the Commissioner, but unfortunately, we got painted with that brush about lack of leadership and oversight in terms of that. But we have raised it with the Director General, and unfortunately, we now have a fairly good functioning internal audit. It's co-sourced between internal audit in the department and an external service provider. And the Audit and Risk Committee might chair, Mr. Shaldikok is present. He might want to comment on that later if you allow, Chair. The Risk Committee has been a problem. We've tried to improve on that. Remember, the Risk Committee is chaired by the Chief Inspector of Mines. Hence, the Portfolio Committee meeting that the Portfolio Committee Chair is calling, we are going to raise this issue around the fact that it's chaired, and the law makes it quite clear if the Chair and the Deputy Chair come from mineral resources, and unfortunately, you can't have although there's a quorum from the trade unions and from the mining companies who are present at the meeting, they can't convene a chair. So the meetings have been cancelled at short notice. It's one of the amendments we're making in the new bill, which is to have a different form in terms of risk assessments for exposures, etc. And if there's governance, it will be totally in the control of the new compensation authority. So yes, I mean, it's functioned somewhat, but two steps forward, one step back. Survey on performance of the CCMS. Yeah, we do have reports, monthly reports from the CCMS, and hence we could track, the 90% payment process of files completed within 3 months. We also can track productivity of staff in terms of inputs, and we can also track service providers like the mining companies and submissions. Chair, what I'll do outside of the meeting, we will make that report available to your office, to the secretary, and they can take that. It's a PDF file, and members can see that, and it's a monthly process. And we also have quarterly meetings with in fact, we had one yesterday overlooking the new budget provisions and service announcements with the CCMS team. I second your point on Regela about prevention, but unfortunately prevention sits, I've got a small prevention tool called the levy. I can move the levy up and down, but the true prevention tool comes from the Mine Health and Safety Act, which sits within the Department of Mineral Resources and Energy. The true prevention tool in work comes from the Occupational Health and Safety Act, which sits within the Department of Employment and Labor. And unfortunately, I don't have enforcement rights in terms of prevention, other than saying your TB rates have gone up, corporation X, mining company Y, and therefore I'm putting your levy up. So it's after the event. Prevention intervention sit, unfortunately, in two different legislative processes and two other departments. And maybe members who sit in cross committees could raise it with those colleagues in DMRE and DEL. Honorable Kaba, I'm not too sure of the tracking tool with National Treasury. We are in meetings with Fiscal, the Financial Sector Authority, so I could have an offline discussion with you about this tracking tool in National Treasury. We've got our own tools, and we'd be quite happy to be part of the process with you on the targeted tracking You've just seen the demonstration of the website, etc., etc. So if there's a tracking tool by National Treasury, we're not too sure what this is. So I do apologize that I have no insight into terms of that. Honorable Munai, thanks for your generous generosity of comments and congratulations. And let me conclude with Honorable Dr. Jacobs. One of the key areas is that Mr. Nix Lesufi is here, who's been providing tremendous support, as I've mentioned. While we've concentrated on the legacy project and the ex-mine worker database, we haven't forgotten the current mine workers. And thanks for reminding me, Dr. Jacobs. We have a project which is kicking off in January. The architecture is almost developed. For every control mine and works at this moment in time, I mean, unless when the new bill comes in, then it'll be all mines and works. But the control mines and works, plus minus, I think 387. I can't remember the actual numbers because they close and merge, but the annual report's got the number. But say plus minus 400 control mines and works. Will have to give us the name of every mine worker, the name of every contract employee, so the full list. So there'll be a register of mines and works, a register of every worker, and a register of workers with risk work. So that's a MITSA project. It's called the Mines and Works Register of Workers, and that's kicking off early in January in terms of that project. We were concentrating on some of the other work and the clean audits, so we had delayed a bit on the current register of mines and works. So a future commissioner, a future director of the MBOD will not have this problem of the legacy that we had, where our data was not kept on many of our people. On the mesothelioma asbestos, we look forward to your meeting. We are in engagements with the Asbestos Relief Trust and the Kalahari Relief Trust. I see there are the chairpersons that are present here. And we look forward to your meeting, Chairperson, where we will pick this up directly. There is a special project that I will be convening with the Northern Cape Provincial Government and the Northwest Provincial Government on mesotheliomas that are presented at the public facilities, Kuruman and Kimberley Hospital and Bloemfontein. And we're hoping to actually pull together a special project in terms of some of this work. And I could also have an offline discussion with you if there's things that's come to the portfolio committee's ears in terms of the issue. At the moment, it's a sad indictment. The treatment for many of these cancers, the treatment for the occupational lung diseases, unfortunately, is paid for by the state. So although I'm given to understand that the trust actually should have funds set aside for the treatment, but we could pick that up at that special portfolio committee hearing, which you are convening shortly with the different trusts. And of course, we'll also pick that up with the Quebecer Trust is in its final stage of winding down, but we can pick up some of those issues. And of course, Sheemisa Trust is just starting off as we go forward. But Kalahari and Asbestos Relief Trust are probably going to be around for another 5 to 8 years. Okay, the database I've covered. It's substantive, and so firstly, to thank you for your leadership on a couple of things. I do recognize that you'll have gone into a parliamentary recess and then kicked off on NHI. So we are hoping that the 5 points that you needed was firstly the urgent portfolio committee meeting, inter-portfolio committee meeting that would cover some of the points we've raised, unpaid benefits, corresponding overlaps in terms of, you had mentioned also Jagersfontein. So we did, there's been a Human Rights Commission report on distressed mining communities and the externalization that mining companies and mining in particular has done for communities. I will try and get hold of that copy. And this is about, I think it was around 2014, 2015, and it raises substantive issues on mine tailings. And at that stage, it was looked at mainly dust as a nuisance factor, and also, holes in the ground, children falling into it, the acid mine drainage, the water problems, etc. But the whole issue around slime dams, etc., I think is substantive, and I'm sure there's a hiatus. And again, portfolio committee members that are working in multiple portfolio committees could actually seek out that. It might be something you could put onto the inter-portfolio committee if there's time. But from our side, unfortunately, we have a narrow mandate, Chairperson, to look after the health of the workers and the ex-workers in terms of occupational lung diseases, and I can't extend my mandate. And anyway, I might be wrapped over the knuckles. I mean, I do have a background, of course, in occupational environmental medicine, and maybe, you know, those are things that we can pick up. But the direct departments involved, environmental affairs, national and provincial, and mineral resources, I think they had some overlapping problems. We did pick up that Jagersfontein mine was controlled by my office, but was decontrolled in the mid-70s. So unfortunately, I didn't even have jurisdiction post the mid-70s because there is a government gazette which decontrols them. But we have to pick up on this issue. The Human Rights Commission report is very, very revealing on the problems faced by post-mining problems in our society. The asbestos dumps, the, you know, Kuruman, Priska, Pomfret, you know, and then, you know, the tragedy that befell us in terms of the Slimes Dam disaster. So the 5 bottom line issues, the first one is the portfolio committee in terms of the trusts and the Minerals Council. We're supposed to have a hearing with both groups in terms of support to the MBOD, CCOD, some issues around governance, and then of course the dynamics on service delivery integration in terms of that. So that's the one portfolio committee. The other one is the inter-portfolio committee, which covers a much wider base, including the unpaid benefits and overlapping issues. We are seriously looking for additional funding for the initiatives. I've got to beg and borrow all the time, not so much the borrowing, but beg for funding. Fortunately, Mr. Lesufi has been very supportive with the Minerals Council in the voluntary levy. We're going into a new 3-year cycle in terms of support, but we think this is substantive. I mean, otherwise we're going incrementally, you know, year 1, Eastern Cape, year 2, Northwest, year 3, Free State, year 4, Limpopo, I mean, Mozambique. And as Deputy Minister has pointed out, we don't have time on our hands. Many of the ex-mine workers are dying, and we need to get to them sooner rather than later. Fortunately, we've had good support from the Shiamiso Trust, but we need much more integration in terms of one platform, one service delivery, and there's some overlapping dynamics that we need to work through. So that's the third issue, is the funding of the initiatives. The fourth is the Occupational Diseases Mines and Works Act reform process in terms of trying to get into legislature early next year, and hopefully it's the Odimo Act is long by its sell-by date, doesn't meet constitutional requirements, and we'll take it forward. And the fifth is continued support from your portfolio committee in terms of oversight, encouragement, and also where we are off the path to let us know, you know, how we can correct ourselves. And we hope that through this process, and we definitely will ask if your constituency officers can be part of our outreach activity and your awareness campaigns, and we'd be willing to talk to the multi-party constituency officers about making available the tracking and tracing tools, etc. And of course, with due respect, through proper approval processes. So that's the fifth point. How does the portfolio committee overall help to get the money into the hands of our people? Thank you, Chair, and over.
Thank you, Dr. Kistasamy and your team. I think very informative. We're looking forward to further engagements. We're looking forward to the engagement with the other portfolio committees. And I think this has brought us now to the end of our meeting for the day. Honorable members, just to be reminded, we are meeting tomorrow at 2 o'clock. Dr. Kistasamy, you raised your hand.
Chair, there was just one on the issue around Honorable Gela's point on misstatements. I do apologize. Kert or Adrian will answer that. If you, I'm sorry to cut in on that.
Thanks, Dr. Kistasamy. Thanks, Chair. Maybe just to give a quick answer to that. With discussions with the Auditor General, it was noted that we do have some recourse to the state or treasury if we could not obtain bad debts or not, or recover bad debts, or if we paid somebody in error, then there is recourse to the state account or treasury for that matter, and they felt that that should be disclosed as under the contingencies note. So no further change to the financials were made. It was just added as a note to the financial statements, and therefore it was noted as part of their report that we made a change to the notes of the financial statements. All of these were addressed in the 2021 financial statements, and everything was then done without any findings for the 22 financial statements. Thank you.
Thank you. So that having been said.
Chair, 1 minute. I'm sorry to interrupt you. Procedurally, I take it you'll address the issue around the fact that we presented 4 financial reports to your office, but we've discussed just 1 year and the overview. But I guess you'll manage that process because we don't have time to go over the others and there is repetition. Chair, I'm sorry to interrupt you. Over.
Thank you very much. Yes, that will be managed from our side. We appreciate that. If there's a need for me to come back and you need to present on those, we will certainly come back to you. All right, so that brings us to the end of today, honorable members and all of our guests and our staff. We will be meeting at 2 o'clock tomorrow afternoon. We'll continue with the work. Thank you very much. This meeting is adjourned.
Thanks, Chair. Bye.
Thanks. Bye.
Thank you, Chair.
Thank you, Chair. Bye.
Bye. Dankie.
Hey, my broer.
Hello.
Thank you, Chair.
Thank you. Bye.